Ambedkar Hospital and College is a final year MBA student, Dr. Ritik. Please come to the dais.
Dr. Dipesh, tell him you have only 6 minutes to present your paper, and then you'll get 1 or 2 minutes to answer some questions, right?
Good morning, respected jury, respected seniors, and all my dear friends. I, Ritik Goyal, final year MBA student from Dr. Baba Saheb Ambedkar Medical College, is going to present my research entitled Unlocking New Avenues, Repurposed Drugs versus NDM1 in Klebsiella pneumoniae, a promising strategy for inhibition. So, to begin with the introduction, as we all know, Klebsiella pneumoniae is one of the most important nosocomial infection which causes pneumonia, UTI, etc. It is a non-motile bacterium which belongs to Enterobacteriaceae family. In the recent 2 decades, therapeutic failure has increased due to emergence of multi-drug resistance in Klebsiella pneumoniae due to the production of extended spectrum beta-lactamases and carbaphenemases. There are various virulence factors that are responsible for it. One of the most common virulence factor is NDM1, which is a metallo-beta-lactamase. It changes in last 2 decades to make this organism into a complete failure of beta-lactam drugs. It is a polypeptide consisting of single chain of 270 amino acid long with N-terminal end with 28 amino acid long single molecules. So the rationale of our study is that traditional drug development takes around 15 years. It is labor intensive and costly and high risk procedure. And due to the paucity in research and development of novel antibiotics, these multi-drug resistant organisms proliferate and causes all drug resistance. So we are repurposing FDA and world approved libraries by computer aided drug discovery for the use in multi-drug resistant Klebsiella pneumoniae. The aims and objectives of my study is to discover repurposed affordable drugs to take care of multi-drug resistant Klebsiella pneumoniae, and further the antibacterial spectrum of these drugs can be extended to other organisms. The materials and methodology of my study is, it is a computer aided drug discovery. We have started with our work on delineation of NDM1, which is the most commonly virulence factor. We have found out the docking site, and after which we have standardized the docking protocol from FDA approved drug library. The 3D crystalline structure of the protein have been delineated from RCSB website in PDF format, and after which the key conserved residues, which means the amino acid residues, which are similar in similar organisms such as E. coli, Acinetobacter, and in the other virulence factors such as NDM2, 3, 4, and 5 have been found out, and the binding pocket has been created. After which a list of drug molecules from FDA library have been downloaded from Zinc 15 website, whose link is given here. All the drug molecules have been then docked in the binding pocket after exported into CSAR. All the selected molecules have then been arranged as per their strength of bond formed and their affinity to binding site. And multiple sequence alignment have been done by cluster omega. Redocking was done for further optimization of intermolecular clashes, and torsion stresses. This is the methodology timeline. First, we have done extensive literature review, after which the key conserved residues have been delineated by multiple sequence alignment, after which we have exported them to CSAR, and docking was performed with FDF subsets. The drugs with minimum binding affinities were delineated and redocked for further optimization of intermolecular clash and torsion stresses. So this is the CSAR Zinc website from which we have downloaded the drug molecules, and PDB from which we have downloaded 3D molecular structure. This is the CSAR, and this is showing the interaction of drug molecule with the protein. This is showing the 3D structure of protein. So our result shows this is the binding pocket which we have created using these amino acid residues, and we have delineated total of 5 drugs. One of which is latanoprostene binode, which is a prostaglandin analog and used currently for the topical treatment of glaucoma. Other one is flufenazine decoinate, which is a phenothiazine neuroptic, and it is used for the treatment of schizophrenia. The third one is tocopherol, which is vitamin E. Other one is cibenadate, which is a beta-2 agonist and used for the treatment of COPD and asthma. The final drug is Teslone, which is an antitussive, non-narcotic oral drug. So the scope and future considerations of our study. This study suggests that these new drugs can be used against Klebsiella pneumoniae, but their use in Klebsiella pneumoniae and human body interaction is doesn't known. So we would suggest further in vitro studies to narrow down the therapeutic use and other interaction of these drugs. And the in vitro efficacy of these drugs can be checked by standard agar dilution assays or MIC determination assays. Also, we can assess the burden of multi-drug resistant Klebsiella pneumoniae in tertiary healthcare center in Delhi. These are the references. Thank you.
Good. You finished it on time, and if you have any questions, we can ask. Anybody from the audience? Any questions in the audience? Okay, in that case, thank you very much. We can have the next presenter.
The next paper presentation is from Dr. Sahaj and Prateek from Action Balaji Hospital.
A very good morning to all the respected judges, jury, and all the respected delegates present here. I am Dr. Sahaj Singh Sethi,
And I am Dr. Prateek.
and we are from Sri Action Balaji Medical Institute, and we are going to present an interesting case of hypoglycemia, a case report. So we had a patient at our hospital named Mr. ABC. She was 38 years old, female, admitted to us in the month of August, and she presented with the chief complaints of altered sensorium, and there were multiple episodes of blackouts, dizziness, sweatings, and she was experiencing these kinds of episodes for last 1 month. History of presenting illness of this patient was that she presented to the casualty in altered sensorium, and this patient had multiple episodes of blackouts, dizziness, and sweating. She explained that these symptoms were usually after a meal intake, after 2 to 3 hours of meal intake, and were frequently associated after she consumed a high carbohydrate diet. These episodes were occurring spontaneously without any apparent triggers, and these symptoms usually recovered after she consumed her meals. The patient also experienced these symptoms 2 to 3 times in a month. As per the patient, we did not find any history of diabetes in her. There were no neurological deficits. There is no history of any seizures. Patient did not have any weight gain or weight loss. There was no history of exogenous insulin use. She wasn't taking any oral anti-diabetic medications. There was no history of any prolonged starvation. She wasn't an alcoholic, and there was no history of any substance abuse, and there was no history of any fever or jaundice, signifying that there were no apparent cause of hypoglycemia in this patient. And her past history was not significant, and there was just a history given by the patient that she was consuming multivitamin pills as prescribed by her RMP. Her menstrual history was also normal. The cycles were regular of 28 days, and the flow was also normal. When we examined this patient on general physical examination, this patient presented, as I told, in altered sensorium to the casualty. She was moderately built, adequately nourished, vitally stable. All her vitals were normal. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy. The physical and neurological findings revealed no overt abnormalities, and her BMI was also normal.
And also there were no signs of insulin resistance, and her BMI was 23.
When we ordered some lab investigations for this patient, we found out that her HB was normal, TLC count was normal, platelet was normal. As we can see, the RBS level of this patient at the time of presentation was 30, and she was a 38-year-old female, and her HbA1c levels were 5.10, and there was no history of any insulin or oral anti-diabetic medications. Her liver function tests and thyroid function tests were both normal. Calcium levels were also normal, and her urine routine microscopy was also normal. So we ordered some specific lab tests following this.
Her serum cortisol in the fasting was 11.2 microgram per deciliter. Her serum insulin level were more than 1000, and C peptide was 9.5, which is elevated. Then we went on to do a ratio, serum insulin and C-peptide ratio, which was more than 1, which is not seen in the normal physiological cases. It is less than 1.
So this ratio more than 1 signified that in normal persons we usually have a serum insulin to C-peptide ratio of less than 1. This ratio of more than 1 signifying that whether a patient can be taking exogenous insulin or the patient must be having any specific antibodies. If the patient was taking exogenous insulin, then we can get a C-peptide level which is very low and a serum insulin level which is high. So then it makes the ratio more than 1. But in this case, we also had the serum C-peptide levels 9.5, which was elevated. But the serum insulin fasting levels was way above the serum C-peptide levels, which also made our ratio more than 1. And we performed, so this is a picture showing our lab results in our hospital. As we can see that the serum insulin levels was more than 1000 and the C-peptide levels were 9.5, both of which are elevated as per their normal values.
Then we had a suspicion of insulinoma or the high endogenous insulin levels. So we did a CT scan whole abdomen where we couldn't find the insulinoma.
The CT was perfectly normal, our pancreas was normal. Then we performed a specific lab test named IAA antibodies. These were insulin autoantibodies and these came out to be positive. And we diagnosed this patient to be as Hirata's disease.
Which is in which there is high level of endogenous insulin and there are autoantibodies against this insulin, so we get hypoglycemia frequently.
So we asked the patient to avoid carbohydrate-rich meals and advise her to take frequent small meals at regular intervals. Also advised the patient on, educated her on recognizing and managing hypoglycemia and advised her to carry glucose tablets for emergency use. We also started her on low-dose oral steroids. We also started her on low-dose oral steroids and she's on regular follow-up now. So this patient had Hirata's disease, which is also called as insulin autoimmune syndrome. So in this, there's an autoantibody to serum insulin, which induces hypoglycemia. It's a rare and often misdiagnosed condition. It is characterized by spontaneous hypoglycemic episodes as we had in this patient. It can lead to significant morbidity and mortality if not acted upon promptly and identified and managed. So here we presented this case just to increase awareness of this uncommon disorder and emphasize on early recognition of this disease. So in the pathophysiology, we can see that body is forming antibodies against insulin. These are autoantibodies, IAA antibodies. These bind to endogenous insulin and this binding is often temporary. So body in response to this antibody increases its endogenous insulin supply, and as this binding is temporary, this antigen antibody complex dissociates frequently, leading to hyperinsulinemia causing hypoglycemia. And this condition is often seen in some genetically predisposed condition and often triggered by certain medication containing sulfhydryl drugs, commonly being methimazole. So this patient had a long history of recurrent hypoglycemic episodes and the diagnosis was ultimately confirmed by these tests. We can also see that this patient was consuming a multivitamin tablet commonly used as Mecofol Plus, and this tablet had a molecule named alpha lipolic acid. This is also shown in some studies that this can also precipitate this disease. Thank you.
Very interesting case. Thank you. Any questions from the audience? Judges, any queries?
Good presentation by
Thank
Prateek,
you.
and this is definitely a rare entity, and I also have diagnosed 7 to 8 years old Hirata disease or autoimmune hypoglycemia. So they're rare, but if patient have recurrent hypoglycemia, then we go for the only septicemia and insulinoma rule out. Then if they are larger, there's definitely the peptide level and insulin level is more than 1. Then they also think about the autoimmune antibodies. If they are so significant, there is this also. And not a very dangerous disease is mild and the recover only large light doses of the steroid also. So patient become all right. So next speaker for pre-paper is the Sachin Kumar from Hindura Hospital. Please come.
Respected judges, and all the respected esteemed audience. My name is Dr. Sachin Kumar, and I am presenting a case of a study of carotid intima media thickness in the patients of rheumatoid arthritis and its correlation with the acute phase reactants and disease activity. So to begin with, I have no conflicts of interest, either financial or non-financial. To introduce the topic, we all know that rheumatoid arthritis is a chronic systemic inflammatory autoimmune disease of unknown origin with characteristic persistent symmetric polyarthritis and the extra-articular involvement. Now, why I have done this study? I have done this study because there is the increased risk, almost twofolds higher in the RA patients of having cardiovascular disease that is due to the atherosclerosis. Now, what I have used here, I have used CIMT, that is carotid intima media thickness, to assess the level of atherosclerosis. CIMT is a surrogate marker for subclinical atherosclerosis in the RA patients without any pre-existing cardiovascular disease. And it has been used in the several clinical studies. It has been recommended by American Heart Association, American Society of Echocardiography, Society of Vascular Medicine as a screening test for the heart disease in apparently healthy individuals. Now, what were the aims and the objectives? My primary objective of the study was to determine the carotid intima media thickness in the patients of the rheumatoid arthritis without any pre-existing cardiovascular disease. And my secondary objectives were to determine the correlation between the CIMT and the duration of disease, the acute phase reactants, and the disease activity, which will be determined by the simplified disease activity index. Now, the materials and the method what I used in the study was, my study was done at the Hindura Hospital in the rheumatology clinic, and it was a cross-sectional study, and the period of study was from January 21 to July 21. My inclusion criteria in the study were the patients of RA, which have been determined by the 2010 revised ACR ULR criteria, and the adult patients above 18 years of the age. My exclusion criteria were patient with pre-existing diabetes, hypertension, pre-existing cardiovascular diseases, high-dose steroids, kidney diseases, dyslipidemia, smokers, liver disease, and the juvenile rheumatoid arthritis. These all were excluded. The methodology, what I used, we have taken the cases as a known case of the rheumatoid arthritis on the basis of 2010 ACR ULR. We have completely clinically evaluated the patients, hematological and the biochemical profiling was done, ESR, CRP, and the platelet count was used as a marker of acute phase reactants. Two groups were made of 45 patients each, 45 cases and 45 controls. And all the patients of the rheumatoid arthritis were evaluated for the simplified disease activity index to determine the disease activity. Now, this is the chart for simplified disease activity index. Now, we have used B mode, that is the linear probe of the ultrasound, to determine the carotid intima media thickness in the patients. And this table shows that CIMT, on the basis of many studies, it increases according to the age. Now, CIMT was then compared with the disease activity, duration, and the level of acute phase reactants. Now, in one study, according to the Homa et al., the intima media thickness of the common carotid artery, which was measured at the site where there is no plaques, it increases linearly from 0.48 millimeters at the age of 40 years to 1.02 mm at the age of 100 years. And the following formula is being used to calculate the age and CIMT dependence. CIMT, how it was measured? It was measured in all subjects with the carotid ultrasonography. CIMT was measured bilaterally in the common carotid artery up to 2 centimeter proximal to the bifurcation. CIMT was then taken at the site of greatest thickness, and the 3 readings were taken on each side. And all the measurements were taken in diastole, so that when the lumen diameter is at its smallest and IMT at its largest. The mean value of 6 readings were taken as the combined reading. Now, this is the method how we used the ultrasonography. This is the picture, and that is the ultrasonographic image of the IMT. Now, coming to the results. In the results, this is the comparison of the age and the control, which was fairly normal. The association, we found the female preponderance, that is 37 females out of the 45 males. Now, coming to the interesting part, the CIMT was significantly raised in the cases group. And the mean on the standard deviation of the CIMT in the cases were 0.95 mm with 1.06 mm of standard deviation, whereas in the control group it was 0.6 mm with a p-value of 0.002. That is a significant. Now, there was moderate positive correlation between the CIMT and SDI, and this correlation was statistically significant. For every 1 unit increase in CIMT, simplified disease activity index increases by 2.92 units. There was a strong positive correlation between the CIMT and the disease duration, and this correlation was statistically significant. For every 1 unit increase in the CIMT, the disease duration increases by 1.26 units. And conversely, we can say that for every 1 unit increase in disease duration, CIMT increases by 0.19 units. CRP, ESR were found to be significantly high in the RA patients, but we didn't find any positive correlation between the strong positive correlation between the platelets and the disease activity. To conclude, there is a strong correlation between CIMT and the disease duration in the patients of the RA. Hence, CIMT is a useful surrogate marker for detecting the atherosclerosis in the patients of the RA. And in view of relation to the disease duration, physicians should regularly screen the established RA patients so that to identify the evidence of atherosclerosis and manage it earlier. It can prevent the cardiovascular disease in the RA, and it requires the integrated approach encompassing the cardiovascular risk factors, screening, and the management, and the effective and the sustained control of the RA disease activity, provided that we should have high index of suspicion. Now, to conclude my slide, this is the slide to show that the patients of the RA with carotid intima media thickness in the patients, we can prevent the cardiovascular disease. Thank you, ma'am. Thank you.
Thank you. Any questions?
Well-known fact that rheumatoid arthritis is a risk factor for atherosclerosis, and it has been it's a component of many calculator models like URIS-3 and other things. So whether measurement of CIMT has any incremental value over and above the existing risk factors, I'm not sure. Okay, it's a very good presentation and a lot of effort has been put into it.
Thank you, sir. Thank you.
One small comment, in fact, a question from you. Does this CIMT correlate with the activity of disease? Say you have mild rheumatoid arthritis, you have moderate, you have severe rheumatoid arthritis. You mean the severe rheumatoid has more CIMT?
Yes,
Did you study that part also?
Yes, sir. Yes, sir. The disease activity part and the CIMT part was positively and strongly correlated.
No, but you studied the disease duration, not the severity.
The disease activity was measured by the simplified disease activity index. And in one of the slides, one of the results, we have found that as the disease activity increases, CIMT is also on the higher side.
Okay, thank you.
This CIMT led to adding aspirin?
Sorry, sir?
Does this increase CIMT? You have found CIMT to be raised in a patient of RA. So will you modify the patient on aspirin without any other associated CAD risk factors?
So I'm not getting the second part. Is it aspirin you are saying?
Yeah, aspirin. Usage of aspirin.
So, frankly speaking, I do not know about the uses of aspirin on
any
the
paper presentation in the past or any guideline proposed by the paper?
So what I have gone through in the paper is the anti-lipidemic drugs. They are significantly improving the CIMT result. But as far as aspirin is
adding
concerned,
statin, you will like to say that adding statin would help?
so statins will help, definitely. Statins will help. But aspirin, sir, I'm not sure about.
Okay.
Well, I welcome Dr. Amit Johri on the dais as a judge. He came a little late but joined us thankfully. Next presentation is by Dr. Neeraj Yadav from Subharti Hospital. Dr. Neeraj Yadav.
Good morning, dear judges and the members. I am presenting the case of hypogonadotropic hypogonadism, that is Kalman syndrome with obsessive compulsive disorder. Kalman syndrome is a rare genetic disorder with a defect of neuronal migration of olfactory axons and gonadotropin releasing hormone neurons. The estimated prevalence is 1 in 10,000 in males and 1 in 50,000 in females. The clinical features of hypogonadotropic hypogonadism and hyposomnia, anosmia. The Kalman syndrome patients are anosmic at since birth, but this is not apparent, and the diagnosis is usually made in the teenage when the child fails to attain puberty. Usually after 14 or 15 years the diagnosis is made. The MR images of brain is useful in adjuvant in making the diagnosis with characteristic morphological finding of the olfactory tract and olfactory sulcus. Usually the sella is found empty. Obsessive compulsive disorder is a long-lasting disorder which is a person experiences uncontrollable and recurring thoughts, which is obsessions, and engages in repetitive behavior, that is compulsions, or could have both coexisting together. People with OCD have time-consuming symptoms that can cause significant distress and interfere with daily life of a person. OCD is a severe psychiatric condition with global estimated prevalence of 2 to 3%, affecting all age groups and culture groups. The onset of OCD in male population is significantly earlier than in female ones, although it remains unclear there is a higher prevalence in one specific gender, as prevalence female-male ratio ranges from 0.8 to 3.8%. In women, the onset of age is bimodal, with peak between 13 to 16 and second peak almost a decade later, that is 20 to 32 years of age. Case summary: we present a case report of a 23-year-old male who presented to the medicine OPD initially with the chief complaints of delayed puberty with associated anosmia since childhood. The patient gave previous treatment history of hormonal supplements, injection with gonadotropin releasing hormone stimulators, followed by testosterone injections, but he was on and off treatment since last 6 years. The patient was given a history of axillary pubic hair growth and secondary sexual characters post treatment. Physical examination showed small scrotal sac and impalpable testes and small penis size. Ultrasound was performed, which revealed small size of testes. No evidence of hernia was or any other thing was detected. Then patient was referred to neurological and psychiatric department, where neurological examination was considered and normal with a history of psychiatric complaints, predominantly obsessive compulsive disorder, which developed after he started having hormonal supplements and injections of gonadotropin releasing stimulators, followed by testosterone injections. Blood investigation revealed decrease in levels of luteinizing and follicular hormones, stimulating hormones. However, increased thyroid stimulating hormone was present. However, confirmed diagnosis of hypothalamic insufficiency for hypogonadotropic hypogonadism, MRI brain with sella was done, showing absence of olfactory sulcus and atrophy of the bulbar. A final diagnosis of Kalman syndrome with OCD was given to the patient. This is a case report. On physical examination, he had bilateral gynecomastia with galactorrhea. His secondary sexual characters was developed to some extent after starting the treatment, including facial and axillary hairs, but were very still scanned. There was micropenis present. The scrotal content was barely palpated on both sides. Neurological examination present with decrease in sense of smell, and on psychiatric examination there were repetitive thoughts of hand washing, followed by repetitive behavior of hand washing, which was distressing for the patient. Whenever he tries to control his thoughts, he is starting anxiety symptoms, which were perceived as increase in heart rate, sweating, trembling sensation in the limbs, and were difficult to control, for as he feels something would wrong happen if he won't act upon his thoughts. This would lead to the severity of symptoms of hand washing multiple times a day, and was not even able to perform his daily chores because of the fear and distress. These complaints started after the initiation of hormonal supplements of injections, GNS stimulators, followed by testosterone injection, initially from a local doctor, what he usually called it MBBS doctor. He was taking the nearby his house and was on and off on the treatment. Further workup was initiated and referred to psychiatry department for the complaints of repetitive behavior, and was evaluated further and diagnosed with obsessive compulsive disorder, and was started on SSRIs, selective serotonin receptor inhibitors, which are the first line treatment for the OCD, with tricyclic antidepressants, with an adjuvant treatment for the treating of severe obsessive compulsive disorder with psychotherapy. Usually the CBT was started. Cognitive behavior therapy. Along with the testosterone injection, patient was continuously treatment for both OCD and Kalman from last 8 months, and it was noticed that there was significant improvement in the OCD symptoms with the lowest dose possible of the SSRI, and TCS was present. And only took 3 sessions of psychotherapy, and patient was showing significant improvement, that is nearly complete 100% improvement in his symptoms. The Kalman discussion, Kalman syndrome is an isolated form of hypogonadotropic hypogonadism in combination with defect in sense of smell. The cell that differentiate into gonadotropic releasing hormones secrete neuron originate migrate from the embryonic olfactory epithelium and migrate along fascias of voronasal and terminal nerves into forebrain. Kalman syndrome occurs due to defects in olfactory structures and alteration migration of gonadotropin releasing hormone secreting neurons into the preoptic and hypothalamic regions. Neurosteroids can interact in several neural systems implicated in the pathophysiology of OCD, which includes the serotogenic system and dopaminergic system, and the orbitofrontal cortex also, which are the two main important systems involved in actual treatment of the disease. SSRI and D2 blockers, dopamine receptor type 2 blockers, GABA A receptors of neurosteroids in central dopaminergic system of nucleus ambiguous is also affected by the same HP axis usually, which affects the nucleus ambiguous and dopaminergic transfer most commonly. Conclusion is gonadotropin hormones represent an increased risk of OCD onset, with assuming the gonadal hormones may change serotogenic and dopaminergic function. In spite of not knowing the exact mechanism of action, we can observe a period of gonadal hormones fluctuating, coinciding with a worsening or onset of OCD symptoms. Also, other psychiatric conditions like anxiety, depression, and even psychotic symptoms in some patients were observed. Therefore, an aggressive theory is needed to explain and integrate all these findings. The consent was taken from the patient and there was no conflict interest between the patient and the treating doctor. Currently, he is taking treatment from nearby hospital only and not following in our OPD, but over the phone we have contacted and he's reported that there is 100% improvement and his minimum drugs, and the treating doctor has said he would be off medications within a year or of OCD. Only injection testosterone would be continued for his complaints. Thank you.
Congratulations, Dr. Neeraj, for nice presentation. Now, mic to Madam Chairman for any comments.
Audience? From the judges? No. Go ahead.
Okay. So, last speaker of this session is Dr. Mohit Bansal from Savarthi Medical College, Meerut. Please come, Dr. Mohit.
Good morning to judges and here present all the delegates and my batchmates as well. I am presenting a rare case of non-resolving mediastinal lymphadenopathy, which is a dilemma. Initially we see the patient as a tuberculosis, but finally we conclude the patient as a non-resolving mediastinal lymphadenopathy. The introduction. Here we discuss a case of a female 25-year-old presenting with the chief complaint of fever since 2 months, approximately 100 degree Fahrenheit, mostly in the evening time with no history of dry cough. There is a history of loss of appetite and weight also. The positive finding of the patient on auscultation is the bilateral air entry present equally with the normal vascular breathing sound heard, with no added sound heard there. With the oxygen saturation 96% on room air. There is a history of ATT intake present in 2013 for 9 months from government hospital and was sputum positive at that time. Patient bronchoscopy was done outside which was suggestive of Mycobacterium tuberculosis, which are rifampicin sensitive, and was started with HRZD regime since 16 January 2022. After the 2 months of ATT, patient has the same chief complaint and the no gain in the weight. Along with this is a new complaint appear of the patient, that is the dry cough, which was progressive in nature, and the right sided chest pain, which was progressive in nature and increase in supine position. The after 2 month course of ATT, patient was presented to EBUS, TBNA was planned and done in BAL fluid. Mycobacterium tuberculosis was not detected. Then the patient is subjected to CT chest, which was done on 27th of April 2022, which was suggestive of necrotic lymph nodes, which is pre and paratracheal, and the largest measuring size is 36 into 28 millimeter, mediastinal lymphadenopathy. We will kept it as a query tubercular at that time. The size of the lymph node was same as of CT done 2 months back, which was suggestive of no improvement clinically, and radiologically. This creates a dilemma of query modes versus query MDR-TB. This is a CT of the patient 2 months prior to the treatment. The patient was planned for TBNA and was come out to be non-necrotizing chronic inflammatory pathology, and whole genome sequencing was done, which shows no growth. From 8th of July 2022, patient was started on MOTS regime after all the reports, because we are presently on the dilemma whether it is a query MOTS or query MDR-TB. On 10th of October 2022, CT report suggestive of lymph node of size 8.9 into 10.8 mm, and the patient improved clinically and gaining weight. So after the MOTS regime, as we see from July to October, there is a significant reduce in the size of lymph nodes as well as clinical symptoms of the patient. On 2nd of January 2023, patient CECT report shows no obvious lymphadenopathy, and patient is completely cured and clinically fit. This is a CT after the completion of the treatment, which shows normal parenchyma with no distribution of bronchovascular margin and no lung nodules or calcification noted. The conclusion of this study is patient underwent EBUS TBNA procedure thrice and was repeatedly AFB stain positive, with last FNAC AFB positive and culture showing no growth. This lead to dilemma of MOTS versus MDR-TB at the time of the patient present to us in the OPD. The patient was started on the line of MOTS as whole genome sequencing shows no growth, in the view of which the series of CECT chest was suggestive of mediastinal lymphadenopathy, which improved on the treatment, and the finally result we as seen lymphadenopathy is disappeared. On 24th April 2022, mediastinal lymph node size was 36 into 28 millimeter, and after the initiation of MOTS regime in after the reports of July, in October 10th of 2022, mediastinal lymph node size was reduced from 36 into 28 by 8.9 into 10.8 mm, and in Jan there is a no mediastinal lymphadenopathy appear. Thank you.
That was a very short brief. So what was that MOTS regime you gave him?
Basically, as we study, the infliximab regime is now come up for MOTS regime, which are 100% curable, but at that time we used the conventional therapy of ceftriaxone and clindamycin-based anti-regime therapy.
And patient improved after how many days?
After 3 months, we will see the significant reduction from July to October, and then in Jan we will see the patient is completely cured.
Thank you. Any
Thank you,
questions? Okay, thank you very much.
Well, thank you, and special thank to judges for conducting the session so well and finishing well in time. I request you probably have given the grades first, second, third. We give you a minute to conduct that. So, well, I invite all the 5 participants, in fact 6 now, 5 participants along with the 2 who came together, Sahaj and Pradeep, on the dais. They can come on the side dais, the participants. Now we are handing out the participation certificate to all the 5 participants who did so well in presentations. We feel that you can do still better next time, and more content-oriented papers can be presented. So you can continue on this side. Meanwhile, kindly judge. Meanwhile, I also request the judges to kindly come over to the side of this dais to collect their mementos.
Thank you, Dr. Raju Gupta. Dear judges, please, I think we end the session, and please come to the, you give the result to Dr. Raju Gupta. Please come to the session dais for the honor, please. And for the candidates, once the result is announced, we'll give the prizes, gifts, as well as certificate to the participants. So next session, without wasting any time, we are in the right dot on time, 10 o'clock. So next topic is challenges in insulin therapy. And for this session, we have got moderators, Dr. S.K. Mundra. Dr. S.K. Mundra? Are you on the desk? Dr. S.K. Mundra is a senior physician at Saroj Hospital, Rohini, and he has got a very clinic in Rohini. Second chairperson, Dr. Hanish Gupta. Hanish Gupta, well-known diabetologist. He is associated with St. Stephen's Hospital, Delhi. Among the panelists, we have got a very eminent faculty, Dr. Rajesh Rajput. He is a DM in Oncology. He is former senior professor and head department of endocrinology, PGIMS. Doesn't need any introduction. He is very popular, India as well as abroad. He has got more than 180 publications. So, Dr. Rajput, sir, please. The other panelist is Dr. Saket Kant. He is a renowned endocrinologist. He is associated with Max Hospital, Shalimar Bagh, as well as Axan Balaji Hospital. Very popular, and he is always in the conferences and the lectures. Dr. Deepak Khandelwal. Earlier, we used to call him a young endocrinologist, but now he is quite a senior endocrinologist and with a very good practice. He is practicing in Paschim Bihar at his own clinic, as an endocrinology clinic, Paschim Bihar. And Dr. Deep Datta, I think, is on the way. Once he comes, he will join this thing. So I hand over the session to Dr. Mundra and Dr. Hanish.
Good morning, moderators for the session. Today we are going to discuss about challenges in insulin therapy. As you know, initiating insulin is always a big challenge, and the scenario in our country in type 2 diabetes, hardly 25%, less than 25% of our patients have HbA1c less than 7. In spite of the fact that we have a multiple different groups of OHs at our hand for controlling, still only less than 25% of HbA1c we find in our patients. So we need insulin. So when to initiate, how to initiate, who are the patients, and what else, we are going to discuss with our panelists today. Dr. Hanish, please, you start the session.
Thank you, Dr. Mundra, and welcome panelists for this discussion. This has been a regular feature with North Delhi Physician Forum, that every time we had a discussion, we have always had a discussion on insulin. Last year also we had this discussion. It was a really vibrant, interactive discussion, and we would welcome a lot of interaction from all our audience today as well. So we'll try to keep the things at the minimum, keep the we'll just set the ball rolling, and it is up to you to clear your doubts, clear your newer understandings about insulin, because the panelists are here to guide us. We all understand that we can broadly classify the challenges with insulin in 3 major categories. One is clinician-based challenges, where the inertia is the most common reason that we would like to talk about, that why clinicians are not initiating, why they are not intensifying, why they are not individualizing treatment with insulin for their patients. The second is patient-related challenges. Every patient in India, he wants to avoid insulin. Why there are so many myths, why there are so many wrong understandings in the society about insulin. And the last but not the least are the healthcare delivery system-related challenges, where there are so many analogs, there are so many formulations, there are so many delivery-related issues, because of which insulin therapy becomes a sort of a complexity rather than a simplicity for most of our patients. So beginning with the first understanding, we would like to begin with the understanding that when there was a survey done for primary care physicians and specialists alike, there were two major concerns that were paramount amongst the clinicians. One, that there was a lack of experience in initiating and intensifying and further individualizing treatment. And second, that the time to educate the patient was a toll on the hands of the clinicians. They would say that I would start the insulin, but then I would have to titrate it, I will have to individualize it. It's a toll on my practice. I don't have that much time. I can provide only 5 to 7 minutes to my patients for consultation. So my humble question to all the panelists to begin with is that what approach should a clinician adopt to become a regular insulin user for the benefit of his or her patient? And secondly, what are the problems that a new and not so experienced insulin user is expected to encounter when they are going to start the patient on insulin?
Thank you very much. Good morning, ladies and gentlemen. Well, this is not the first time that I have heard this question. Over last 25 years, more than 500 times I have answered this question. Now, when it comes to insulin therapy, he has rightly pointed out there are physician-based inertias and there are patient-based inertia. To me, over years, what I have realized, I am not bothered for patient-based inertias, because patient can be anyone out of us or out of this hall. And they may be physician, they may not be physician, they may be a doctor but may not be a physician. So they does not know about pathophysiology of the disease. They does not know the importance of tight glucose control. They does not know when actually tight glucose control is important and when you are late in the disease it is not important. What is the importance? What should be the target? And we now live in an era which is known as social media era, where we have unsolicited access to lot of information which is never authenticated, so which generate lot of confusions, lot of questions in the mind. So the patient related inertias are bound to be there. But to me, for lack of insulinization, which is actually you have given quite a good figure. We have done our own survey from Haryana, which is one of the well-connected state of this country. Less than 10% of the patients are actually getting insulin in time. And the reason behind that is physician-related inertia. Reasons are many, you have highlighted. Lack of education. If we see our curriculum, MBBS curriculum and MD curriculum, remaining in institute for more than 26 years, Dr. Diwani sitting here, remaining in the institute over so many years, how many hours of teaching for endocrinology is provided in MBBS and MD curriculum? How many trained doctors, which include our own MD physician colleagues, they are confident in starting insulin therapy when they are teaching their students? How many of the physician colleagues who are sitting in these teaching institute with whom our young colleagues are sitting and getting degree, they see them writing insulin right in time. They see them writing 4 drug, 5 drug, 6 drug or different wrong permutation and combination. So the wrong seed is sown right at the young age in our budding physicians. So actually it is a time when we should have full dedicated few hours, and the new NMC curriculum, actually if you have, some of you have seen in new NMC curriculum where there is a different type of teaching material, it is now included that to MBBS students you should teach the art of injecting insulin therapy on models. You should tell them what is a side effect, which is hypoglycemia, how to manage hypoglycemia. So now these are given stress. And then when it comes to MD, we should have some dedicated hours where they should be learning about endocrinology. So there are many deficits, and when these young physicians obviously come to the practice, when they have not treated patient with insulin therapy, when they have not seen how to manage problems immediately, even if patient is coming with a fasting of 280 and postprandial of 450 with an HbA1c of 11%, they are not confident how to start insulin therapy. They actually play with oral drugs, try to develop some excuses. So these things are actually quite, and we have to change our system. So this is from me, which I have observed physician-related inertia. And when I talked to my senior colleagues, who are even senior to me, they are even more hesitant because they does not want their sleep to be disturbed. They fear that their patient should not develop hypoglycemia. They does not have time. And for that, it is needed that those busy clinicians, they should develop paramedic staff who should be trained in giving education about insulin therapy, who should train the patient how to identify symptoms of hypoglycemia, how to treat it. Only then we can improve from physician aspect the degree of insulinization. Otherwise, this question is going to be remain like this, and we can, as I have told you, we have discussed it number of times. Some changes has happened, but much more needs to be done. You know, just 1 year back, I have taken VRS. I have gone to private practice, joined a sort of corporate hospital. When I have gone there, and it's a big hospital, even there, nursing staff working in ICU and other places, they were never told about how to give insulin, which insulin is to be given when, how to monitor blood sugar, what will you do when hypoglycemia happens. So these things needs to be inbuilt, and structured protocols has to be made, which has to be there in every ICU, every ward, and some initial teaching, and then the staff has to follow these protocols.
Yeah, very rightly highlighted by Dr. Rajput regarding physician-related inhibitions, initiating insulin in physicians. So now I comments from Dr. Sakit.
I guess I would absolutely agree with Dr. Rajput in that case. Physicians are more at fault as compared to patients. Once you sit back and counsel your patient really well about insulin therapy, the pros and cons, and that it may just be one of the stages of diabetes that the patient is insulinogenic now, the patient would understand and probably would be ready for insulin therapy. The most important thing is sitting back and counseling the patient. And if you can give the first injection of insulin at the clinic itself in front of you, counsel the patient and the relatives about the symptoms of hypoglycemia and treatment of hypoglycemia, the patient would develop confidence and let the patient participate in his or her treatment. Tell the patient how to up-titrate, down-titrate insulin. Basal insulin is easy to up-titrate, down-titrate. Teach the patient how to do that, and when the patient feels that the patient is participating in his or her treatment, the patient will feel more confident, and as insulin therapy goes on and the glycemic control gets better and better, the confidence would increase because the patient would start feeling better. A patient with a glucose level of 300, 450 started on insulin therapy, and the glucose levels come down, the patient starts feeling better, the visual cues are better. You can see that the glucose levels are 150 now, and overall strength has increased, the weight is increasing. Everyone appreciates that he or she is getting healthy. That is a big boost. So basically, the physicians have to be more and more involved. The counseling has to be more. You'll have to give at least 15-20 minutes of your time regarding everything, regarding insulin counseling, how to store insulin, how to change needles, how many times to change needles, regarding risk of hypoglycemia. And don't teach only the patient, teach one or two relatives also how to give hypoglycemia and tailor the insulin therapy according.
कन्विंस होने की ज़रूरत है. पेशेंट्स को तो हम कर देंगे, हमारे खुद के कोलीग्स ही कन्विंस नहीं.
I know, this is a point very rightly raised by Dr. Rajput. We physicians have to first have confidence in ourselves in initiating insulin.
So I guess more time to be given and counsel your patients. Let them participate in their treatment, but sitting back and counseling is the most important. Most of the patient would agree to insulin therapy when you talk to them, and in fact you can talk to them 1 or 2 weeks before you plan to start insulin, so that you can give time to the patient also to think it over and come back to you.
Yeah, very rightly said. In fact, nowadays we may have diabetic counselors in our clinical practice, but very few, or I think only 5 to 10% of us can afford to have counselors. So we need to have ourselves need to educate our patients and their relatives. Dr. Khandelwal, your comments, please.
I think, sir, most of the points are already discussed. So I think you rightly said counselors, and it's not that we cannot afford. Most of us can very well afford counselors, and they can be sort of taught to do sort of multi-purpose work at our clinic. So not only for diabetes education, they can do diet counseling also, they can do counseling for thyroid diseases also, for other diseases also, for medication compliance, other things. And I remember, 5 years back, I had one lady whom I was struggling for last 4-5 months, and she was like, sir, मैं मर जाऊंगी लेकिन insulin नहीं लूँगी. Then in a one VG clinic, I had one, there was, now I have full-time educator with me. So I called her, said, and told my educator कि आप एक बार इनसे ना 5-10 मिनट लगाओ और इनको इंसुलिन के बारे में समझाओ. And after 15 minutes, that lady came with that educator, and educator told me, sir, इनको इंसुलिन शुरू कर दो. And I was, so surprised कि I was struggling with this lady for 4-5 months, 4-5 visits, and her straight way response was कि sir मैं मर जाऊँगी लेकिन इंसुलिन नहीं लूँगी. And the educator spent 15 minutes with that patient, and patient was very well convinced, and educator confidently told me कि sir आप इनको इंसुलिन स्टार्ट कर दो. And that visit the patient started on insulin. Then I called that educator later कि मैंने कहा तूने ऐसा क्या बोल दिया. Then what I have realized, sometimes there may be certain gaps between physicians and the patients, but the paramedical staff, they can do certain things better. They can teach everything, they can have conversations better, they can address their concerns better. So we cannot ignore their importance.
They are more friendly, maybe they will be more friendly.
एक और एग्जांपल दीपक ने बताया ना, मुझे भी याद आया बहुत साल पहले एक डॉक्टर ही अपनी डायबिटीज़ कंट्रोल के लिए दे केम टू मी एंड वी स्टार्टेड ऑन इंसुलिन थेरेपी. Patient came back after 1 week with almost similar sugar, and in institutes the OPDs are very busy, 300-400 patients. So I said, okay, डॉक्टर साहब एक काम करिए, 4 यूनिट बढ़ा देते हैं. And he went away. Then again he came back after 15 days. Sugars actually are worsened. So again I have done the same thing. Then when he came for the third time, and he said, डॉक्टर साहब I am not getting controlled, मैं तो इंसुलिन भी लगा रहा हूँ, आप सोच सकते हो क्या हुआ होगा. That is my learning for that, and then I actually changed even in institute.
नीडल की कैप हटाई थी?
नहीं, उसने नीडल की कैप नहीं. If you have seen the pen, and I have said to this thing to the pharmaceutical companies many times after that, pharmaceutical companies are not giving needles with the pen. Patient has to purchase needle separately and pen separately. So that gentleman, which himself is a doctor, treating in some periphery, he has purchased the pen, he opened the pen, he dialed the dose, he keep without needle on the abdomen, and then he will turn back to 0.
So sad.
So I was shocked. I said, Doctor Sahab, how needle ka hai, and how you are thinking that sugar will be controlled, which means he himself has not initiated insulin in any of his patient in life.
My God.
This is another learning, that a doctor who is treating patients at periphery from years have not given insulin even to a single patient. And then we have made it mandatory that the first prick of injection, until and unless patient declines, has to be given in front of us with any of the staff, so that at least proper steps are known to the person. When this can happen to a doctor, the patient, this is quite common.
Dr. Deep Datta, your thoughts?
Sir, such beautiful points have been highlighted by all the faculty. एक पॉइंट मैं ऐड करना चाहूँगा कि पेशेंट सोचते हैं कि इंसुलिन एक बार शुरू हो जाए लाइफ लॉन्ग चलेगी. It is addictive. So it is not addictive, we tell them. So another way to convince them is that especially if you are starting basal insulin या premix insulin once a day, we can make a chart on the prescription, tell them, see, if your fasting comes down, say particular value around 70-80, you start reducing the dose. So we tell them, पहला डोज आपने सामने लगाया और ये चार्ट आपके सामने है, आप अपना डाइट कंट्रोल करें, वॉकिंग बढ़ाए, फिजिकल एक्टिविटी बढ़ाए, ठीक आए तो खुद ही घटाना शुरू करना, मेरे पास आने की ज़रूरत नहीं है. सो दैट गिव्स देम द कॉन्फिडेंस, ओके, आई एम स्टार्टिंग नाउ बिकॉज माई ब्लड ग्लूकोज इज़ बैड, बट विद बेटर कंट्रोल आई हैव द ऑप्शन ऑफ सेल्फ रिड्यूसिंग. सो the confidence to start and continue insulin increases exponentially. और जैसा सबने कहा कि also discuss with the family members. Many times patient लेना चाहता है but घर में बुजुर्गों के प्रेशर में नहीं लेने देते, तो चाहे घर के सबसे सीनियर मोस्ट पर्सन, चाहे वो दादी हो या दादाजी हो, जो भी हो, वो भी साथ में आए, उनको भी अगर हम कन्विंस करें, that would be easier.
We learn such things while practicing, because we physicians have to learn to many different methods of convincing or patient as well as the family members. So there are two big risks as explained by our moderators. One is hypoglycemia and second is weight gain. So hypoglycemia we have discussed. Regarding weight gain, how do you manage in such patients? Weight gain, because patients have this fear also.
Sir, देखिए weight gain with insulin has been overplayed by certain medications or group of pharma companies to highlight their products. Ultimately, we have to see it's an anabolic hormone, and we have to see that if we use insulin in the optimal dose, which is defined as the lowest possible dose, weight gain is not an issue. Weight gain becomes an issue when patient is having subclinical hypoglycemias and patient is compensating it by overeating. That typically happens when patient is blindly taking insulin and is not ready to do SMBG. डॉक्टर साहब मैं तो प्रिक नहीं करूँगी, 3-3 महीने में शुगर चेक करूँगी और इंसुलिन लगाऊंगी, उसमें तो हाइपोज होंगे, मोस्टली सबक्लिनिकल्स होंगे जो कि कंपेंसेट होंगे बाय ओवर ईटिंग एंड दैट वुड कंट्रीब्यूट टू वेट गेन.
एक्चुअली जो हाइपोग्लाइसीमिया और वेट गेन है, it is very simple to understand. If there would have been no hypoglycemia, diabetes would have been easiest disease to treat on the earth. So it is duty of us as a doctor to learn the art of insulin therapy, or even for that matter any insulin secretagogues which are oral therapy. So it is a part of the story, it is other side of the coin. So we have to learn. As far as weight gain is concerned, I agree with Deep. We actually overstress actually sometime weight gain associated with insulin therapy. How many of us actually have ever thought we are writing left and right even when it is not indicated pregabalin? Now pregabalin is associated with weight gain from tune of 6 kgs to 12 kgs if you see the literature. And such type of fancy non-usable drugs are written along with insulin therapy, and the blame goes to the insulin therapy that the patient is having weight gain. So sometimes our co-prescription for number of other drugs is playing more havoc as compared to insulin per se. So if there is a proper education, patient is given education about diet and exercise, and then probably with insulin therapy, because it's a potent anabolic hormone, some degree of weight gain is happening there, but then it is not a bad thing. It can be managed.
So let's summarize what are the overriding themes that we discussed and what has come out. Number one, firstly, we should have a staff with us, an educated staff, which is going to overcome the difficulties, the barriers of understanding that our patients are going to have. The second important theme which has come out, which is very important and has been reiterated again and again, that please give the first injection by your own self. It infuses confidence in the patient. It makes the patient learn the steps. It is the best strategy. If the patient is leaving the clinic without an insulin injection, the first shot of insulin, there are 2-3 things that are going to come out. First, he is going to run to another clinician to find out a substitute, because every clinician, every patient wants to hear something which he likes to hear. No patient wants to hear the bitter truth, and medicine is always a bitter medicine. Medicine is always the bitter truth for the patient. So don't let the patient go without the first injection. It is the proper hand-holding measure that you are providing to the patient. It helps the patient to buy the insulin, which is one hurdle. Second hurdle being that the patient has to take the insulin, he learns that. The third step being that somebody, some attendant, now you are giving the insulin to the patient, you are not even coming to know that whether the patient is going to take the insulin himself or herself, or some attendant is going to take. So that hand-holding is also being provided, because you are letting the attendants also learn the process. The chemist is, don't leave it to the chemist that he is going to make the patient how to take insulin. So that's a very important strategy. And the third thing being empowering your patients. When you are empowering your patients with the proper dosage, telling them there are going to be pitfalls like hypoglycemia, there are going to be pitfalls which are going to some kind of complications
ये pitfalls
of the
नहीं
insulin
बोलने
therapy.
boss. They are part. ये pitfalls नहीं है. ये part of the story है. ये husband wife की तरह है.
They become the pitfalls.
Husband wife की तरह एक couple में husband नहीं होगा, couple complete नहीं होता ना. So they are couple.
Without understanding, they become pitfalls. If there is understanding, there will not be any pitfall. That is what I try to imply. And a question from the audience.
Dr. Rahul Bhargav.
Rahul.
Medications which are hitting the market in terms of which are being hailed as peptide-based molecules
Thank you,
and anti-obesity measures, because in India, a lot of metabolic syndromes lead to these diabetes. So do you think that this topic will be irrelevant of using insulin in next 5 years?
Right. I actually totally disagree with you, Rahul. Because if we have to understand the pathophysiology of type 2 diabetes, type 1 diabetes, I think there is no confusion to anyone. Insulin is the treatment of choice. When it comes to type 2 diabetes, there are, as told by DeFronzo, 8 different defects, then 10, then 12, even now 15 different defects. Nobody on this earth will develop diabetes unless he or she will have some degree of beta cell dysfunction. Even in this hall, some of us are obese who are sitting here. Still they does not have diabetes. They have insulin resistance. Why they are not having diabetes? Because beta cells are able to produce excess amount of insulin to take care of that insulin resistance. So the first basic fact to understand is that if somebody is developing type 2 diabetes, there is already insulin deficiency. It's a relative insulin deficiency. Now, as the duration of diabetes increases, as we understand natural history of disease, the beta cell dysfunction keeps on increasing. If we see UKPDS graph, by 10 years, more than 90% of the beta cells are already lost. Although this loss may not be permanent, this is a new understanding. So the newer form of therapy, which are peptide-based form of therapy, they also actually act on pancreatic beta cell and causes glucose-dependent insulin secretion apart from their other pleiotropic benefits, which I will not go into the detail. But then this therapy will be effective when your pancreatic beta cell have some reserve as far as glycemic control is concerned. Now, when their effect on obesity is concerned, now we are going to have dual incretin mimetics, triple incretin mimetics, which addresses other defects also. But then by doing weight loss, this has been proved in bariatric surgery, diabetes remission trial, that everybody by going into weight loss cannot go into diabetes remission. So there is more to diabetes than just simply understanding that it is weight gain, it is excess of weight which is causing diabetes. So these drugs are useful, but they are not going to replace insulin therapy. This is very clear, Rahul. Number two, if we understand the cost of these newer peptide-based therapies, when we as an Indian are very fond of discussing cost of each and everything. How many in our country are able to afford these newer peptide-based therapies? That is also a big question. So there are many issues. Insulin, I think, is going to stay there very soon. Next year, we are part of that phase 3 trial. We are going to have once a week basal insulin also. So the life is going to be simplified more and more. It is only our adoption of insulin therapy which is required.
Dr. Rajiv Gupta, just one point regarding challenges in insulin therapy. I feel one challenge regarding storage of insulin. See, half of India, in fact 60% India lives in rural areas where supply of electricity is very erratic. For 6 hours there is no electricity, for 8 hours there is no electricity, and we have kept the pen in the fridge. I want to know at what time, at what threshold the insulin becomes useless.
Yeah, comments sir, please.
Sir, very relevant question, although the electrification of the country has increased exponentially in the last 10 years. Still, it's a big problem. People might be traveling for festivals, for functions to their villages. So simple things is what we tell while traveling in trains or flights, you can carry ice packs. If patient doesn't have an ice pack also, simple flask, a water bottle flask, if you fill with ice, you can, whatever insulin pen or cartridge or vial, wrap in a plastic packet, tie a rubber band, and you put it in that flask and tight it. You can easily carry it for 12 to 18 hours. And wherever you go, you have access to ice, you can put it. Still, if you are going to a very remote village where you don't have the option of even ice also, simple, there are published paper to show the simple earthen pot, जिसे हम घड़ा कहते हैं, आधा पानी से भर के घर के जो सबसे ठंडा वाला हिस्सा है बिस्तर के नीचे वहाँ रख देंगे और इंसुलिन के पैकेट को बांध के उसको तैरा देंगे, फ्लोट कर देंगे. It can easily stay for 1 month for routine use. That can be done.
मैं बताता हूँ. Actually, if you see the product insert, less than 30 degree, less than 30 degree of ambient environment temperature. Once you have started using an insulin, there is no need of fridge. Now, if ambient temperature is more than 30 degree, then actually we need to store insulin in a cold place and no direct exposure to sunlight. So this is very clearly written on all product monographs. So 30 degree. 1 month is a shelf life. 1 month is a shelf life outside. 1 month less than 30 degree. 1 month is a shelf life of majority of insulins. More than 30 degree, the efficacy of that insulin decreases. It does not become useless. There are studies where they have compared insulin which has been kept at a temperature of more than 30 degree. The efficacy of the product decreases, but it does not become useless. Yeah. And as has been told by Deep, there are many ways. Earthen pots, he has told, nowadays, very recently, last week only, my patient has come, the Cello and other companies, they have come with a small apparatus on the top of the shelf. You keep those, they keep your insulin when you are traveling at an ambient temperature for more than 12 hours. And they are hardly 1,500 rupees cost. And they are once to be purchased and patient can use them for life.
Any questions from the
I
house?
fully agree with that. One of the very important question is that we should try to use less of pre-mixed insulin in the very first go.
ऐसा कुछ नहीं है sir.
Yeah.
It all depends on type of
analogs
glucose
as well
control.
as there are plain insulins. Now the plain insulin should not be used as a pre-mixed insulin.
No, that is all right. But see, which type of insulin, it is rapid insulin, it is basal insulin, it is pre-mix insulin, whatever type of insulins are available, we choose depending on various factors. Patient fasting कितना है, postprandial कितना है, difference between fasting and postprandial कितना है, clinical condition क्या है, GDM use कर रहे हैं तो GDM में कौन सा insulin use करना है, steroid ले रहा है patient तो type of steroid कौन सा है, short acting ले रहा है, medium acting ले रहा है, long acting ले रहा है. So there are many variables which decide about type of insulin.
Yeah, I think that was a wonderful discussion from all our. Dr. Saket, like to comment something?
I guess the insulin companies have to be more, they have to move proactive. Like in the oral polio vaccine, we have got the sticker that is heat sensitive. I made a suggestion to the companies, the big companies, that they should also put up a sticker. It's not very costly. The oral polio vaccine carries the sticker. So if they can put the sticker up and if that can demonstrate the denaturing of insulin, it's going to make our lives very easy. And in fact, the life of the patient also very easy. In fact, if you see many of the chemists, if they store insulin at their place, they would probably be, most of them would be shutting down their refrigerators in the night and the insulin would be denatured. So I always tell my patient, either you buy insulin from a place which has a 24-hour pharmacy or buy it from a hospital. That has made a lot of difference. Patient buying insulin on 40 units from a chemist near the place and getting it from a hospital or a 24-hour pharmacy, the doses have gone down by by around 75%. So that also makes a lot of difference. But I guess the insulin companies would have to come up with a way so that we can know it is denatured or not. And the sticker that is there on oral polio vaccine, it can be customized for insulin also. It should be put and would make a lot of difference for a country, tropical country like India.
एक challenge before, because we close, although it might be known to all of us, although the vials are available 40 IU per ml, but sometimes because of cost हम पेन की कार्टेज को भी यूज़ कर रहे होते हैं उसमें से इंसुलिन ड्रॉ करके और वो 100 IU per ml की कॉस्ट उसमें आती है and the syringe which is used is different. Unfortunately in our country most of the syringes which are available are 40 IU per ml. The 100 IU per ml syringe is not available so easily and in fact is not known to large number of physicians. So it results in insulin dosage mismatch because it is a factor of 2.5 times. So if you are using with syringes, kindly read how many unit per ml that contains and use appropriate syringe. This is also one of the challenge.
Thank you, Dr. Rajput. Thank you our panelists for highlighting the nuances of initiating insulin in our clinical practice. Thank you very much.
Thank you for such a wonderful and interactive session. And now I invite the chairpersons and panelists to come to the session dais, and moderators are Dr. Mundra and Dr. Anish. We will honor them. And I invite Dr. Rakesh Sood to honor the moderators. And before starting the next session, that is quiz session with Dr. Mukesh Bhatia, I would invite Dr. Raju Gupta to announce the prizes for the poster presentation. Dr. Raju Gupta, please.
Well, thank you, Dr. Jha. Say we had a very interesting three paper presentations, and all of the participants did very well. In fact, they all scored more than 75% marks from all the four judges. But as a practice, we have decided to give three prizes: first, second, and third. And the prizes are certificate plus a cash incentive. Of course, that's a very modest amount, but that is given to just motivate them further. Now, I invite the judges, Dr. Richa Diwan, to kindly hand over the first prize to Dr. Sahaj and Dr. Pratik. They presented paper on, I think, hypoglycemia, means autoimmune insulin disease, hypoglycemia. Dr. Pratik and Dr. Sahaj. The second prize goes to Dr. Sachin Kumar. Dr. Sachin Kumar. I'll call Dr. Amit Johari. Please come and hand over the. The third prize goes to Dr. Ritik. Okay, you can come down, Dr. Ritik. Come on this side.
For the third prize, I request Dr. Raju Gupta and Dr. Ram Babu to give to the Dr. Ritik this third prize from Baba Saheb Ambedkar Hospital. Now the next session is quiz session by our eminent quiz master Dr. Mukesh Bhatia. Last year hit the quiz and that was a hit. So repeated this quiz with Dr. Bhatia. And the chairperson Dr. Snehlata Verma. She is new to this our forum. She is Associate Professor, LRR Medical College, Medak. She is a competent member of UPRSDI and she is a new consultant of nursing school. So I invite Dr. Snehlata Verma to come to the dais. Second panelist is Dr. Sunil Khetarpal. Dr. Sunil Khetarpal is one of the most senior member of this North Delhi Physician Forum. He is practicing in Shalimar Bagh. And third is Dr. Hemant Sharma. He is a professor in medicine at HRH, Hindu Rao Hospital. Dr. J.K. Sharma is on the way. Once he comes, he will join this thing. So I request Dr. Mukesh Bhatia to start his blockbuster quiz program. Thank you.
I request all the quiz participants यहाँ आ जाएंगे, teams आ जाएंगी सारी. Can I request the learned senior faculties to go to back side with a request? All the candidates. Candidates सामने आ जाओ. आपको बिठाएंगे ना, कोई बात नहीं, बिठाएंगे आपको. Don't worry, आपको मैं include करूँगा. Teams have been allotted. Team 1 कौन सी है? अरुणा जी, अरुणा इनको डाल दो, किसी टीम डाल दो. All the तो मैं यही करूँगा. Please, hello Sahaj, please come first. ये बाद में करना. अभी वो बहुत फोटो खींचनी है. अपनी अपनी टीम आगे बैठ जाएंगे. Sit down, sit in the front seat. All of you sit in the front seats. Team 1. Team 1, 1, 2, 3, 4, 5, 6. Team 1. Team 2.
Team 1 on first couch.
Team 2, Team 3, Team 4 ऐसे बैठ जाएंगे फटाफट जल्दी से.
Team 2.
Start करेंगे.
Team second इधर आए please. Team second. Where is team second?
Dr. Mukesh, Dr. Mukesh, in the meantime, you announce how to score.
Where is team
how to give
second?
scores.
Team second.
आपको आ जाएगा. जल्दी कर लीजिए. Please speak fast. Hurry, don't waste time.
Please come.
No negative, no negative.
नेगेटिव तो नहीं, जो सेकंड देगा
नहीं कोई पास नहीं.
पास भी नहीं है.
आधा घंटा भी नहीं.
ठीक है.
Team second.
Slide.
Well, all PG students can participate. We have more than 4 so far. We have more than 4 teams. All right. Just let us know.
Team, हाँ जी, जल्दी
Let us know. Just
Team
a
1.
minute. Let them raise the hands.
Team 1, na?
Okay,
Raise your
team
hand.
1, please raise your hands. Team 1, we have 2 people.
Any more? Only
on
2.
Team 1. Team 2,
One
we
more
have
also.
4 on Team 2.
आप सर मोदी जी आप इसमें आ जाओ. You sit this. Team 1 में आ जाओ आप.
नहीं एक one candidate more. तुम्हारा team ये नहीं.
उनको भी
Okay.
बता दो. Team 1 बैठ जाओ. सर बैठ
Team
जाओ.
1, please sit down. It is final. Team 1, Team 2, Team 3. Please raise your hands. Team 3, we have 3 on the Team 3. And Team 4, oh, so many? 5?
कोई बात कोई चलेगा.
We can make it 6.
Time नहीं है.
Okay. Okay, Team 4, we have 5 people. Team 5, we have any Team 5? Okay. Sit down, Team 5, on the back so far. Team 6.
जल्दी बैठ जाओ. सहज.
Are you participating, Team 6? Okay. Any other team? Team 7? They can come on the front so far. Team 7, can you occupy another front sofa? Team 7.
Dr. Savda, can I request all the organizer to please leave the space and go back a little bit so that we can start the program easily? I will request all the faculty to sit down, please.
Okay. We have some.
All the organizer member, please sit down also.
I can take 11 teams.
So we can have up to 11 teams. We
Jaldi
have
sir.
till now Team 7. Okay, Team 8,
Sir.
please go ahead.
We already have a
Team 9, yes. Team 8, okay, your Team 8. I think we should have placards on that. Anyway,
चलो चलेगा.
chalo, anyway.
चलिए let's
Whenever
start.
you answer, you will tell your team, okay? You say Team 8, answer this, okay?
Yeah, there are certain rules you should know. We are having 3 rounds. 3 round होंगे हमारे. 2 questions for each team. Correct answer has 5 marks. No negative marking. There will be question for the audience also. No pass as we have very less time. Prizes for the winner and every participant. In case of controversy, quiz master and judges' decision shall be final. In case of tie, question will be asked only to tie team. Luck also plays the role in quiz. It is not a quiz but also a many extra learning points also. So question. So round 1, there will be 2 questions for each team, 5 marks, and time for each question is 30 seconds. Team 1, ये हाथ खड़ा करेंगे. Yeah.
एक मिनट, have you got mic now? And
mic.
after giving answer, please transfer mic to the another team.
But team
Quickly.
1 इधर. Team 1, yeah. Question 1. During platelet aggregation, 5 marks each, which substance binds platelet with capillary endothelium and which substance binds to platelets? Little louder.
Sound. Mic.
Okay, correct. Both the answers are correct. Von Willebrand factor binds. Von Willebrand factor, not ये bind करता है आपका उससे. And number 2 is fibrogen binds the 2. Okay. So a little bit extra learning point देख लेंगे for postgraduates. ये platelet, this is endothelium and von Willebrand factor जो कि bind करता है. And इन दोनों को bind करने का वाले का नाम है fibrin और ये von Willebrand factor. This is a GP1B receptor और ये GP2B3A receptor है. नाउ इसका अप्लाइड, क्लिनिकली अप्लाइड क्या है? वॉन विली ब्रांड डिजीज में बीटी सीटी दोनों प्रोलॉन्ग होते हैं, क्योंकि वॉन विली ब्रांड फैक्टर प्लेज ए पार्ट हेयर ऑल्सो, जबकि हीमोफीलिया में खाली क्लॉटिंग होती है, बीटी प्रोलॉन्ग नहीं होता। एंड GP2B3 receptor blocking drug like epcoritamab, they are anti-platelet drugs. Okay. Team 2 कौन सी है? Yeah. In 2 congenital liver disease there is increased conjugated bilirubin, but ALP level is normal. 5 marks each. Name the 2 disease. Both disease need to be answered. And which test you will do to differentiate between the 2?
The 2 diseases are Gilbert and Dubin-Johnson syndrome.
और दूसरा?
Gilbert syndrome and Dubin-Johnson
No.
syndrome.
Well, मैंने कहा एक सही है एक गलत है, तो मैंने कहा दोनों ही आने चाहिए. Anyway, I cannot give marks. Dubin-Johnson and Rotor syndrome. Gilbert syndrome में ALP वाला नहीं होता है, and we can differentiate by BSP secretion test. Sorry, I cannot award you. मैंने पहले कहा था 2 need to answer.
Can we give them 2.5
Say
marks?
again?
Can we give
No,
them?
no. Zero. We don't want to create more time. कम है बहुत, controversy हो जाएगी. Well, okay, team 3, multiple myeloma, 5 marks each. Why hypercalcemia occur due to which cell hyperactivity in the bone, and why ALP level is normal in multiple myeloma? Team 3. Up, Mike, please. Mike.
Osteoclast.
एक माइक आगे भी देंगे. हाँ, जल्दी अर्शद.
Osteoclast.
टीम इसका क्या आंसर है?
Osteoclast hyperactivity.
Osteoclast.
Class.
Correct. और इसका आंसर?
Why ALP level is
Why
normal?
ALP level is normal in multiple myeloma? Well, we give the 5 marks. There is increased osteoclastic activity, it leads to hypercalcemia. Osteoclast is a bone resolving cell, and osteoblast is a bone forming cell. Multiple myeloma में osteoblast की activity normal होती है. Clinical applied. इसीलिए multiple myeloma में bone scan normal होता है, क्योंकि osteoblast की activity नहीं बढ़ती है. Team 4.
How many are team 4? 4 people.
Team 4.
Okay.
तो इस टीम को 5 marks to this team. Team 4. Gastric bouillon formation is the side effect of which drug? Which disease is also known as diabetic diarrhea? पहले को जवाब देंगे.
Sucralfate.
Good, correct. और ये quickly.
VI POMA, sir. Vasoactive intestinal peptide.
No, we give 5 marks. The right answer is sucralfate is the right answer. Side effect of sucralfate, it leads to hypophosphatemia, constipation, and gastric bouillon. Solid mass of indigestible material that accumulate in the digestive tract is known as gastric bouillon. और जहाँ तक सवाल है diabetic diarrhea, that is celiac disease. Because again, extra learning point for the postgraduate. It is celiac disease is type 1 के साथ जुड़ी होती है, तो we call it diabetic diarrhea. We use for celiac disease. Dermatitis herpetiformis is often associated with celiac and IgA globulin deficiency. They are 3 important things which are associated with celiac disease. Team 5 कौन सी है? Yeah. There are 2 autosomal recessive conditions which have polyuria, hypokalemia, and increased aldosterone level. Name 2 conditions, both need to be answered. Which urine test we do to differentiate between the 2 conditions? Team 5. Quickly.
Conn syndrome.
Conn syndrome. Oh, no. और Conn syndrome में तो अच्छा और no. Okay.
SIDH.
No. Answer is Gentleman syndrome. It mimics chronic thyroid therapy. Bartter syndrome mimics chronic furosemide therapy. Or extra learning point, in Gentleman syndrome there is hypocalciuria, in Bartter syndrome there is hypercalciuria. If I have to integrate So the thyroid is a cause. Thyroid is a cause of hypercalcemia, and fusamide is a treatment of hypercalcemia. Team 6, हाथ खड़ा करेंगे. Team 6, yeah. In pheochromocytoma, what happened to BP soon after surgery and why it occurs? Both need to be answered. BP will rise, remain normal, fall, or any of the above can happen. Second question, why hematocrit increases in pheochromocytoma? Sir, cameraman sir, थोड़ा सा आगे सटेंगे. Cameraman sir, थोड़ा सा. हाँ जी. Team 6, quickly.
BP rises.
Okay. Or why hematocrit increases? Well, BP will not rise. No, ये answer सही नहीं है.
Vasoconstriction.
No, no, no. BP falls. This is due to reduced intravascular volume, and due to same reduced intravascular volume, hematocrit increases, जो कि dengue fever में भी होता है. But you will never understand unless you know the basic physiology of hypertension. A little extra point. BP depends on physiology. BP depends on 3 parameters: cardiac output, peripheral resistance, blood volume. ये physiology है. जब भी body में BP बढ़ेगा, body will try to control BP. But body doesn't have an effective method to control cardiac output, no effective method to control peripheral resistance. But body can very well control blood volume by diuresis. तो pheochromocytoma में BP हाई होता है ड्यू टू कैटेकोलामीन, पर इंट्रावेस्कुलर वॉल्यूम कम होता है. तो जब ऑपरेट करेंगे, इंट्रावेस्कुलर वॉल्यूम कम है, BP falls drastically. Due to same reason, in pheochromocytoma, although hypertension is a feature, but most of PGs don't know there is a postal hypotension. And due to reduced intravascular volume, there is increased hematocrit also. Right, sir? So, and little bit more physiology. BP is cardiac output multiplied by peripheral resistance. Cardiac output, heart rate, stroke volume. दोस्तों, all postgraduate, remember this line. 3 ही पैरामीटर हैं, heart rate, stroke volume, peripheral resistance, which is जो आपको कंट्रोल करना है to control any case of hypertension. Heart rate, stroke volume, and peripheral resistance. Team 7, हाथ खड़े करेंगे. Team 7. After head injury, a patient comes to you with the hyponatremia, low BP, dry tongue, 5 marks each. What is your diagnosis, and what is the food habit changes in these patients? Quickly.
So diagnosis is cerebral salt wasting syndrome.
Correct answer.
The food habit is here we have to give patient more fluid.
More fluid and more
salt.
Salt. दोनों आंसर सही हैं. Cerebral salt wasting syndrome, and they tend to eat salt. वो आपके घर में आएगा, आपको मिठाई खिलाओगे, वो कह नहीं यार मिठाई मत खिला, तो ये नमक खिला, और नमक की मुट्ठी भर के खाएगा. जब पेशेंट मिल जाए नमक खाने वाला मुट्ठी भर के, think of post head injury, think about cerebral salt wasting syndrome. Little bit extra point, ये क्या चीज़ है? Classically seen in after head injury, hyponatremia and dehydration. Hyponatremia is due to excess renal sodium excretion due to hypersecretion of A and P. And they tend to have a salt craving, as they said rightly, pani or salt craving. Team 8, Team R. In rheumatic fever, 5 marks each. Out of 5 major criteria, which is the most rare and most common feature, both need to be answered. Second question is, which are the 2 late features? Quickly.
Sir, the most rare feature is side chorea, and most common is migratory polyarthritis. And the late 2 features are the side chorea again, and arrhythmia margin.
Sorry, दोनों ही गलत, आधे सही है आधे गलत है, so I cannot give you. 12, most rare is asthma marginatum, and most common is arthritis, ये आपने ठीक कहा, और chorea and nodule are the late. Okay, so आपका आधा सही है, so we cannot, इससे पहले कहा था, no controversy, both need to be answered. 12, team 9 कौन सी है? Yeah, team 9, which is not heard, why it is third sound? Why it is not heard in cardiac tamponade, and in which valvular heart disease S3 is not heard? Quickly. Why it is not heard in cardiac tamponade? Third sound. Quickly. What is the physiology?
Sir, third heart sound is not heard in cardiac tamponade, as for the production of third heart sound, there should be a large volume of blood against non-compliant LV wall. And
Okay.
in the mitral stenosis, S3 is not heard.
Both answers are correct. In CT, rapid filling phase is not there in diastole. Okay, I give you granted. And mitral stenosis is the answer. इनमें third sound कभी नहीं होती, never. Now little bit more to make you subject better. Let's learn little bit more about cardiac cycle. Early diastole में 70% blood come from LA to LB. That's why it's called as rapid filling phase. Right side में we get J, Y descent. और third sound is heard. जब ये आनी होती है वो rapid filling phase में आती है. That's why this is known as filling sound. Y descent corresponds to third sound. Now, in late diastole, 30% of the blood comes via atria because of atrial contraction. This is known as atrial kick. And A wave is produced in JVP and S4IG. That's why S4 is called as atrial sound. And S4 corresponds to A wave or atrial fibrillation में ना S4 होगी ना A wave होगी. So now you understood कि cardiac tamponade में कभी rapid filling phase नहीं होती और mitral stenosis में rapid filling phase नहीं होती है. So you got 10 marks. Team 10. Team 10. Team 10 कौन सी है? Okay, yeah, team 10. Team 10. Yeah, in Cushing disease there is an increase in the midnight salivary cortisol level. Question 1, why does this occur? And what is the most accurate test to diagnose Cushing disease? Team 10. Mic देंगे? Any staff? Mic? पास में माइक फटाफट यार आगे 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 बोल दे
ले लो फटाफट.
हाँ.
ACTH increases.
Say it again.
ACTH aldosterone will increase in this case.
No. Question 2. ये वाला.
Sir, ये ना dexamethasone suppression test है.
No. No. Anyway, I appreciate your answer, लेकिन answer सही नहीं है. पहला, disturbance of circadian rhythm is the earliest manifestation of Cushing syndrome or Cushing disease. Normally, cortisol level is maximum in the morning, minimum in the night. और इसमें ये circadian rhythm disturb होती है, and we can collect cortisol level from saliva also. इसलिए the first thing to happen is increase midnight salivary cortisol. And most accurate test is inferior petrosal sinus venous sample. So dexamethasone suppression test is a screening test, not a confirmatory test. Even MRI is not a confirmatory test. So there are two good questions. Question for the audience. These questions are only for resident, not for the senior learned consultant के नहीं है, only for the, anybody can answer, resident doctor, not for consultant. In diabetic retinopathy, what is the pathophysiology of hard exudate and pathophysiology of cotton wool है. In the meantime, score. My score कितना है? जल्दी से. Any of the resident can answer. Anyone. ये audience का question है. Anyone can answer, not for senior consultant. Only for resident doctors. Yeah. Hard exudate, there is lipid residue and ये hard exudate है और ये cotton wool, they are due to damage to the nerve fiber. Yeah. So I request my learned judges to give the score.
Thank you, Dr. Bhatia, for completing the first round. And after the first round, Team 1, Team 7, Team 9. These three teams got 10 marks. And a very clapping to
Don't worry,
for
अभी
these
अब
teams.
बहुत है. Don't worry, don't get.
And
चलो आगे. Round 2. Same rules. Team 1. Team 1. We give which vitamin in the treatment of sideroblastic anemia and why we give glucose in the treatment of porphyria. Yeah.
Vitamin B9.
B9. Sorry, it's not correct. और ये don't worry. This is the gray area for most of the postgraduates. So इसमें ज़्यादा टाइम लगाएंगे. Well, आंसर B6 है और ग्लूकोज इनहिबिट ALA synthase. ये जवाब क्यों है? This you will never understand unless you know the biochemistry. Well, थोड़ी सी biochemistry लगाएंगे. Porphyrin combined with iron to make heme. This happen in the mitochondria of RBC. ये जाके globulin जोड़ेगा और hemoglobin बनाएगा. लेकिन what is more important? Look into this slide. जब ये प्रोटोपोरफायरिन बनता है, it combines glycine with succinyl coenzyme में, यहाँ पे हमें B6 की जरूरत होती है और यहाँ पे we need a enzyme delta aminolevulinic acid synthase. This is the rate limiting step. Sideroblastic anemia can be congenital or acquired. The only thing that we can do something for these patients is give B6 देंगे. That's the because we want more and more delta aminolevulinic acid बने और ताकि प्रोटोपोरफायरिन बने, क्योंकि ये नहीं बन रहा है. That's why we are getting sideroblastic anemia. लेकिन यही के ये कहानी आती है पोरफायरिया में भी. Look into this. Here, point to note it again. I want more and more delta amino ALA should be made. Now look into this slide. अब जैसे आपके पोरफायरिया है, बड़े सारे स्टेप्स हैं, एंजाइम की डेफिशिएंसी है. मान लो यहाँ पे एंजाइम की डेफिशिएंसी है, तो ये सारे बढ़ जाते हैं. तो पोरफायरिया में ALA का लेवल बढ़ जाता है. ALA is a toxic molecule and all the porphyria feature are due to ALA. तो मैं पोरफायरिया में चाहूँगा कि ALA ना बने, जबकि सिडरोब्लास्टिक में मैं चाहता हूँ ALA बने. तो now इसका I want to suppress this enzyme. This enzyme is suppressed by glucose and hepatin. इसलिए ग्लूकोज और हिमेटिन दिया जाता है इन द ट्रीटमेंट ऑफ पोरफायरिया. ओके, आई होप यू कुड गेट ये बेसिक कंसेप्ट की क्या चीज़ है. पॉइंट टू नोटिस, ये एक आयरन ओवरलोड टाइप ऑफ एनीमिया है. सो देयर इज इंक्रीज आयरन स्टोर इन द बोन मैरो इन सिडरोब्लास्टिक एनीमिया. ओके, एंड पेशेंट में फीचर ऑफ एनीमिया, फैटीग प्लस हीमोक्रोमेटोसिस. तो कई बार हमें ब्लड ट्रांसफ्यूजन देना होता है और कई बार हमें वीनिंग सेक्शन भी करना होता है इन सिडरोब्लास्टिक एनीमिया. ओके, दिस इज गोल्ड मेडल क्वेश्चन है ये वाला. चलिए आगे बढ़ते हैं.
टीम 7.
टीम 2. ये टीम 1 थी. ये राउंड 2 है. राउंड 2 शुरू हो गया हमारा. टीम 2. हाँ जी, टीम 2 हाथ खड़ा करेंगे. Which antihistaminic drug are also known as pro-arrhythmic drug and why amiodarone is not a pro-arrhythmic drug?
Lidocaine.
Say again.
Lidocaine.
Lidocaine. No, sorry. इसका क्या आंसर है? Well, class 1A drug are pro-arrhythmic drug. Lidocaine class 2 है. Because they prolong QT interval and they predispose to torsidae pointis, although they themselves are antihistaminic drug. Amiodarone causes prolonged QT, but a unique चीज है. DA mentor का क्वेश्चन है ये वाला, लीड एसएस का. But it has got other activity also. So despite causing prolonged QT, it does not lead to torsidae pointis. Little bit of pharmacology. ये हमारी साइकिल है. स्टेज 0 जहाँ पे सोडियम की एंट्री होती है. अभी मैं इसी पे फोकस करूँगा. दोस्तों, जब कभी ग्राफ आए, अगर ये स्टेज 0 दाएं शिफ्ट हो रही है, ये क्लास 1A ड्रग है. तो पहले देखो कि स्टेज 0 कहाँ जा रही है. Then you look into this. अगर ये prolonged QT interval है, तो ये क्लास 1 है. क्लास 1A. राइट साइड शिफ्ट हो गया है, क्लास 1 ड्रग, लेकिन QT इंटरवल छोटा हो गया है. क्लास 2 ड्रग लिग्नोकेन. और यहाँ पे ये शिफ्ट हो गया है क्लास 1 ड्रग, लेकिन QT इंटरवल नॉर्मल है. दिस इज क्लास 1C फ्लिकन. Simple. I think I made the subject very easy for you. This again very confusing for the postgraduate. Why amiodarone is not a pro-arrhythmic? क्योंकि इसके अंदर और भी इफेक्ट है, 1, 2, 3, 4 सारे इफेक्ट हैं. Due to combined effect is doesn't lead to arrhythmia. Okay, now question only for resident, not for a consultant. In actual practice, what the commonest cause of prolonged QT interval? Hypokalemia, the most common cause of prolonged QT interval. Team 3, हाथ खड़ा करेंगे. Broadband sign is seen in which condition? Why any condition where there is a secondary, name any condition where there is a secondary hyperaldosteronism but without edema feet. Edema feet नहीं होता है, पर secondary hyperaldosteronism होता है. या ये किसके लिए? टीम माइक कहाँ है? हाँ जी, quickly, no problem. पहला है constrictive pericarditis and condition where we see gastroenteritis, Bartter syndrome, Gentleman syndrome. They are the condition where we have secondary hyperaldosteronism without edema feet. Team 4. Name any, team 4. Name any congenital kidney disease where hyperkalemia occurs due to chloride shunt. Name any drug which causes hyperkalemia due to chloride shunt. Quickly.
Gentleman syndrome, sir?
Well, no. Okay, second question. चलिए, answer is Gordon syndrome. Our second is cyclosporin. Gordon syndrome, familiar hyperkalemia, hypertension, low renal hypertension, hyperkalemia, metabolic acidosis, and chloride shunt operation. Team 5. Team 5. Name two important conditions where there is thrombocytopenia but there is increased clot formation.
DIC.
Okay? अब ये एक और सवाल किया. हाँ बोलेंगे?
DIC.
Say again.
DIC, disseminated
DIC.
intravascular coagulation.
Increase, no, DIC is not a good answer. हाँ, bleeding ज़्यादा होती है.
Heparin-induced thrombocytopenia.
Heparin-induced thrombocytopenia. We can give 5 marks. PNH and APLA. PNH, first morning urine sample black and whole day urine clearance. ये patient मिल जाए, वो PNH है. Complement mediated intravascular hemolytic anemia at night. Team 6. इनको 5 नंबर मिलेंगे. Team 6. Infection by which bacteria can cause endocarditis in carcinoma colon? What the pathology of Ross spot in endocarditis? Quickly.
First one is Streptococcus gallolyticus.
No. Second one.
Immunological factor is responsible for rod spots.
आगे 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 क्या मिलेगा आपको? फंडस में क्या मिलेगा?
In the retina, we'll find a reddish, a pallor and a reddish area we'll find.
Well, no. Streptococcus bovis है, not galactus. Silent colonic carcinoma. जब भी इसका एंडोकार्डाइटिस मिले, कोलोनोस्कोपी should be done और ये hemorrhage है with pale center. ये hemorrhage है. Team 7. Team 7. Which antibody are seen in primary membranous glomerulonephritis and which type of glomerulonephritis can occur in Hodgkin lymphoma? Team 7. Yes. Say यहाँ पे. Quickly.
Sir, first is PLA2 receptor antibody.
Correct.
And second is membrane or minimal change disease.
है?
Minimal change disease.
Both answers are correct. बिल्कुल ठीक है. Antibody are seen, antibody to M type, PLA2R, and minimal change occur in Hodgkin disease. Both correct. Well, इसको skip कर सकते हैं. Time कम है. Team 8. Team 8. हाथ खड़ा करेंगे. Team 8. Yeah. In basal ganglia, lentiform nucleus is made of what? Both B2 answer or striatum is made of what? For a basic anatomy question.
Striatum is made of chordate nucleus and the
plus
putamen.
Okay. और ये striatum, ये किसकी बात कर रहे हो आपने?
Sir, striatum.
Striatum, ये बोला आपने. ये वाला?
globus pallidus and putamen. And sorry sir, putamen and globus pallidus.
Well, दोनों आंसर सही हैं, correct. Lentiform nucleus, globus and putamen, and striatum is caudate and putamen, correct. Just a quick recap. Caudate, this is globus pallidus, putamen, ये दोनों अलग हैं और ये दोनों अलग हैं. Yeah, team 9. Team 9, yeah. About rifampicin, we use rifampicin in which hepatic condition? And we use rifampicin in which type of bacterial pneumonia? Quickly. No. We use it to treat itching in primary biliary cirrhosis, and we also use for staph pneumonia. Just to inform you, drug like linezolid, which is primarily developed for staph pneumonia treatment, is a anti-tubercular drug. इसका मतलब है कि इनकी दोनों की माइक्रोबायोलॉजी में बहुत कुछ सेम है, which is not yet clear. Maybe after 10 years we have a clear कि दोनों सगे भाई हैं, staph and mycobacteria. Team 10, हाथ खड़ा करेंगे. Team 10, yeah. About folic acid deficiency, how alcohol causes it and how phenytoin causes this.
It will decrease the absorption.
Which one? Alcohol or phenytoin? पहले alcohol का बताओ.
It will decrease the absorption.
Okay, and what about phenytoin? Well, just to the conjugates, we have it inhibited by phenytoin, and absorption is inhibited by alcohol. तो आपने उल्टा बोला है, okay, right? तो थोड़ी सी basic physiology बता दूँ आपको. Folic acid metabolism, polyglutamate is there in the plant. It is converted to monoglutamate by the conjugase. This conjugase is inhibited by phenytoin, and alcohol reduces absorption of monoglutamate. It's the alcohol which reduces absorption. But I appreciate your answer. Question for the audience. Judges, please score. Venous sinuses in the brain are present in which of the following spaces?
Subdural space.
Subdural space is नहीं सर आपके लिए सवाल नहीं ये वाला. Only आपके लिए नहीं. Only सर द्वारा देख लेंगे. Only for resident. Only for resident.
None of the above.
हाँ, हैं जी.
None of the above.
None of the कौन सा किसी का none of the above? कहाँ होते हैं? Yes, the right answer is ये कहीं नहीं होते. They are in the between the two layer of dura mater. They are not in any other space. किसने कहा? Who answered? Give a big hand to him. Give a big hand to him. Hi sir, score.
Team 7 is 20, and team 1, 8 and 9 tied up with 10.
Okay, fine. So now we move on to the last round. Same rules. Team 1, non-heme iron absorbed in enterocyte via which channel? Vitamin B12 is absorbed internal via which receptor? Team 1.
DMT1.
Okay, or second? आंसर है DMT1 करेक्ट है, और ये क्यूबैम सेंटर पे जाके टर्मिनल आइलम पे लगता है, एंड देयर इट इज टेकन इन. एंड जस्ट टू इन्फॉर्म यू, एक और सवाल फॉर ऑडियंस. सलाइवा में B12 गेट अटैच टू विच मॉलिक्यूल? R फैक्टर सलाइवा के. टीम 2, in which cardiac condition protein losing enteropathy occur? Which cardiac condition is important DD of cirrhosis of liver? Answer is constrictive pericarditis, classically hepatosplenomegaly, ascites and edema. Ascites out of proportion to edema in CP, this is known as ascites precox. And most important DD of cirrhosis of liver is constrictive pericarditis. Team 3, which is not a feature of Kluver-Bucy syndrome, and what are the clinical findings in thalamic syndrome? Well, hyperactivity is not a feature. The feature of clover-bucy, placidity, orality, hyperphagia, hypersexuality. इन पेशेंट के बारे में जब भी कोई सवाल पूछेगा, इनमें hypersexuality due to bilateral temporal lobe injury, और classically when patient taking पंगा with the nurse, जब nurse pulse BP check करने आती है, जब ये सवाल मिले, he talking about clover-bucy syndrome, and thalamic syndrome there is contralateral heavy anesthesia, you all sensation they all go to thalamus. Thalamus is the relay station. Team 4. Upper GI endoscopy, what is C? And one hematological investigation which we can differentiate alcoholic fatty liver from non-alcoholic liver. ये क्या है पहला आंसर? Little louder.
Feline esophagus.
In which condition we see? Which disease?
Eosinophilic esophagitis.
Right. Correct answer. और ये क्या है? इसका क्या आंसर है?
And can differentiate from hematological.
Try.
Hypereosinophilia.
No. ये सही है eosinophil और ये है serum ferret. Alcoholic liver disease is a iron overload stage. Classical feature. Don't miss this question. Okay. Eosinophilic corrugated appearance. ये Candida, herpes simplex, sponge out ulcer and linear ulcer, CMV esophagitis. Team 5. Tubercle bacilli, what is the function of cord factor and sulfite? Team 5.
Attachment, cord factor.
Well, cord factor protect mycobacterium from the defense of the host, and जो दूसरे वाला है, it allows bacterial intracell proliferation, macrophage में proliferation, ये proliferate करेगा और ये इसको बचाएगा. It is just like a helmet or just like a Excel में. Team 6 हाथ खड़ा करेंगे या? Vertical gaze is affected in which syndrome, and which syndrome lateral gaze is involved in stroke cases? Quickly.
Progressive supranuclear palsy.
उसमें डाउन गेज पाल्सी होती है. उसमें डाउन गेज पाल्सी होती है. और ये क्या है?
MS, multiple sclerosis.
No. Well, Paranoid syndrome, mid brain का लीजन है यहाँ पे आपका, और ये जो है locked in syndrome in pons, क्योंकि lateral gaze is in the pons और upper gaze is in the mid brain. Team 7. Well, these are the site of hypertensive bleed. Now, question 1, if treated early, हमारे पास 5 patient हैं ये वाले. If treated early, which will have the best prognosis? If not treated, which will die the first? किसकी बारी है? Little louder. Karan Kayama. No.
Sir, this is our chance, no?
हैं?
हमारी बारी है ना? 7, team 7.
जो भी है, जो भी टिकट कर
बोल रहे हैं.
क्या आंसर है? आंसर इज सेरिबेलम. दोनों का सेरिबेलम है, क्योंकि जितनी भी ब्लीड है, एक सेरिबेलम ही ऐसा पार्ट है जहाँ पे वी कैन डू सर्जरी और किसी में सर्जरी नहीं हो सकती. जल्दी निकाल देंगे ब्लड, पेशेंट ठीक होगा. नहीं निकालेंगे, cerebral tonsil, patient will die. Now, team 8. Which murmur is heard in very small BSD? All left-sided sound and murmur increase in expiration, and all right-sided sound increase in inspiration. What is the exception to this rule?
Sir, in small VSG we see early systolic murmur.
तो ये वाला?
Sir, HCM and MVP.
No. Well, एक सही है, ये वाला ठीक है. We see early systolic murmur, and pulmonary ejection click is the exception to this rule. Give 5 marks to this rule. Team 9. हाथ खड़ा करेंगे या? Paradoxical bradycardia is in which condition? Stone heart is in which condition? Paradoxical bradycardia. Quickly.
Sir, paradoxical bradycardia is seen in case of brucella.
Okay, और stone heart?
Stone heart is constrictive pericarditis.
No, दोनों गलत हैं. This is seen in pulmonary embolism. Tachycardia is the most common finding, but कुछ में bradycardia, paradoxal bradycardia, and उसके बाद reduction toxicity में we get stone heart. और एक चीज और gold medal question. Normally hyperkalemia में we give calcium gluconate as the first choice. लेकिन if hyperkalemia is due to digoxin के अंदर होता toxicity में we never give it contraindicated.
Excuse me, sir.
The last question. Last team. Mechanism of action of support viewing, mechanism of action of time preview. Last question. Team 10. Last question of the quiz. Hanji. No problem. It is a protease inhibitor. और पहली वाला जो है RNA polymerase and दूसरे वाला protease inhibitor. So I request that this should be scored as a question for the audience before they. Carbonocyan is seen in which of the following conditions? Answer TR है. But if you read 11th edition, उसमें लिखा है carbonocyan is seen in tricuspid stenosis. If you read 15th edition, उसमें लिखा है it is seen in early TR. But you read 2021 edition, उसमें लिखा है TR. तो इसलिए आंसर फिलहाल TR है.
Excuse me, sir. सर वो
हाँ.
सर वो मर्मर का एक्सेप्शन कॉज पूछा था, तो कॉज वाज हुकम एंड MVP only.
I said it's the paradoxal bradycardia seen in which condition?
नहीं जैसे पहले वाला पहला
ऐसा नहीं फिलहाल टाइम खत्म हो गया. We'll talk. हाँ जी सर.
First still is number 7.
टाइम का.
Team number 7 20.
सर टीम 1 कौन सी है?
20. Team number 7.
7 नंबर टीम कौन सी है? Okay, ये था first. Congratulations.
They got 20 marks.
And second is first and 8 15 marks.
There is a tie between team 1 and team
8 15.
with 15
Okay,
marks.
दो टीमें हैं.
हाँ
तो
दो.
इनसे एक सवाल पूछ के खत्म करने को. टीम 3 में कौन है?
तो दोनों में से एक कर लो.
दोनों में से एक आ जाएगा. हाँ जी.
हाँ.
Now only one question.
This is the question for team 1 and team 8.
Okay, team 1 क्या आंसर था?
Crohn disease.
Crohn disease correct answer. और which अब दूसरी टीम कौन सी है? हाँ. Which team act at site number 2? यहाँ पे कौन सा डायरेक्टिक एक्ट करता है?
सर हमने अभी आंसर किया था.
हैं?
अभी हम
क्या है?
पहला क्वेश्चन हमने ही आंसर.
लूप डाययूरेटिक.
दूसरी टीम कौन सी है?
सर
हाँ.
सर
Number 8.
लूप डाययूरेटिक.
Loop diuretic is the most common wrong answer. यहाँ पे खाली वाटर absorb होता है. यहाँ पे कोई भी डायरेक्टिक एक्ट नहीं करता है. Sorry. So we got a team.
Team 8 is on second and team 1 is third number.
Okay. All the best. I hope you learned a
Excuse
lot.
me, sir.
And one more thing.
Sir, we just wanted to ask about our previous murmur question.
Say it again.
We can talk later on. Dr. Bhatia.
Epicon
We are already
आ रहा है
started
हमारा.
time.
Thank you so much, Dr. Mukesh, for
Chalo,
conducting such a nice
I think
session.
we are getting late for the inauguration, so
And congratulations to all the
Thank you.
team for the participation.
Bhatia, sir.
A
Thank you
big
so much.
applause to Dr.
Prize
Bhatia,
will be
please.
announced after the inauguration.
Big applause to
Prize
Dr.
will be
Bhatia,
announced
please.
and given the prize after the inauguration ceremony. So just please wait and bear with us. Now I request the chairperson, Dr. Bhatia, to.
But I
chairperson to
think
honor Dr. Bhatia
everybody should get up to give a
and
big applause to
Chawda
Dr.
to honor
Bhatia.
the chairperson.
Please
Definitely.
get up to give a big applause to Dr. Bhatia.
Dr. Chawda and Dr. Anil Gombar, one of the most senior members of NDPF, to give him. Now I invite Dr. Rakesh Gupta. Dr. Rakesh Gupta, he is a very senior physician. He will be conducting the inauguration ceremony. Dr. Rakesh Gupta.
Okay, good morning friends, and going to be afternoon very shortly. Let's start with the inauguration ceremony. May I request the President of the North Delhi Physician Forum on a dais, Dr. Malhotra. Dr. Malhotra, Dr. A.K. Malhotra on a dais, please. Then I can request Dr. Secretary, Mr. Dr. Meglani on a dais, Vice President Dr. N.N. Jha on a dais, and the Treasurer of North Delhi Physician Forum on a dais, Dr. S.K. Mundra. And last, I would like to invite the Nokia connecting persons, Dr. Chavda on a dais. Well, first of all, I'll call upon Dr. Miglani. Can I have the slide of Dr. Miglani with me? Dr. Miglani is the Secretary of North Delhi Physician Forum, the Senior Consultant Physician, Government of Delhi and NCR. More than 20 years of experience, who is heading this post of a Secretary of North Delhi Physician Forum to present his report for the last 1 year. Dr. Miglani, please.
Warm welcome to all of you and thank you for coming to this conference. Most of the people are regular member in our annual conference. Our NDPF was formed in 2001 and it's almost more than 2 decades. We are running it very successfully. We have around 150 members and we are doing lot of activity. Monthly meeting, an academic meeting is going on almost for inception of our NDPF, and there are every member they are doing social activities also and education activities, and there are other various platform of API, North Delhi Physician Forum, and other issues like violence against doctor, social programs, community participation, health awareness, health camps. Every members individually are also doing these type of activities. We are involving young doctors also, like resident doctors, involvement of the FEMA, the Joint Confederation of the Associations of Doctors, involvement of the DMA also. In addition to our monthly meeting, we are doing academic activity with the API, Delhi chapter, national chapter, RSSDI, and various other bodies, and DMA, Rohini and DMA, North Delhi DMA, and there's a wider participation, and the other issues like violence against doctors and issues of like bonds, NMC, almost in all the issues related with the doctor, we have given the representation. Even in the NMC, when the draft bill was prepared, we made our representation. And like these, and now we are enrolling young doctors also, postgraduate MD medicine, and even many postdoctoral doctors are our member. And I thanks all the cooperation extended by our doctors fraternity in this North Delhi. North Delhi is a very large area. It's not the district-wise of like NCT Delhi. It's involving from the Narela to all the borders, from Ring Road to the Rohtak Road and to the neighboring borders to Haryana. All is North Delhi Physician Forum. I thanks all of you to coming to this place, participating in this national conference. Thank you. Thank you.
Thank you, Dr. Miglani. Thank you for your kind words, and I hope that society keep on progressing the way it has been doing for last 1 year. Now, may I have the first address from the President of Association of Physicians of India. He is going to be on live, and I'll request audiovisual people, please connect Dr. Grish Mathur from Kota for his live address on the screen. Thank you, Dr. Grish Mathur, for your kind address. We are really obliged with the good words. And I'm sure, like all your teachings, all your saying will be followed by this North Delhi Physician Forum. Thank you very much for being part of this inaugural ceremony. May I move forward to call upon the none other than Dr. Jyotirmay Paul from Kolkata. He is Dean of Indian College of Physicians as on today, and I'm sure in time to come, going to achieve much bigger position. And Dr. Jyotirmay Paul is a person who is always on a move. And I'm sure today is also on a move again. And he's there, right on the move, sitting in a cab and delivering his lecture. Dr. Paul, please go ahead and address the gathering. Thank you very much for being on the platform. Thank you, Dr. Jyotirmay Paul, and I hope your car will reach to Delhi by the time we finish our conference. That's what we look forward for your kind presence. Thank you very much. Let's move on to the next address by none other than the President of Indian Medical Association, Dr. Sharad Agrawal. May I request Dr. Sharad Agrawal be on the line, sir?
बॉस उनकी फ्लाइट टेक ऑफ हो रही है, वो लेट हो गया.
Okay.
अब फ्लाइट में वो.
Thank you very much.
Sorry आ गया उनका.
All right, sir. Thank you.
Announcement सुनाया उन्होंने मेरे को.
We move on now. We have one of the dynamic president with us, working day and night for this conference. He is Dr. A.K. Malhotra, and I'll request Dr. Malhotra to address the August gathering, and along with it, deliver the conference is open. Thou is already open, but we need the official opening of the conference by Dr. Malhotra.
Thank you, Dr. Rakesh, and thank you everybody. Dear friends, on the behalf of North Delhi Physician Forum, I welcome you all and thank you for sparing your time on busy schedule on this Sunday morning. Before starting further, first of all, I would like to convey on behalf of North Delhi Physician Forum and all the delegates our best wishes to our Honorable Prime Minister Shri Narendra Modi ji on his birthday today.
डॉक्टर राकेश गुप्ता का भी आज बर्थडे है.
Dr. Rakesh Gupta.
Happy birthday.
Happy birthday to you as well.
ये मोदी से कम थोड़ी है.
May God give him long and healthy life to everybody born on this day. Friends, our forum has entered 23rd year now, and it was started in 2001 by very few like-minded people for academic and knowledge exchange. And over a period of time, we have around 150 registered lifetime members only from the north part of Delhi. It is due to the hard work and support of our members that we are organizing monthly CME without fail since inception. And we exchange new trends in the field of medicine among esteemed members through reputed and talented experts in the arena. As everybody is well aware, scientific developments are regular ongoing part of our medical profession, and aim of NDPF is to impart knowledge in the field of medicine, to update new trends, and to enhance clinical skill to treat the patient. And this is our one step in the same direction. I hope we succeed in our motto, and in the future as well we continue to do so. Friends, I must thank our mentors, all the participants and delegates, and our core members for giving us strength every time. No doubt, it is the collective approach and hard work of every NDPF member that we have reached at this juncture. But I would not be doing justice if I don't mention our founder president, Dr. Chabda's name, who has given his contribution towards North Delhi Physician Forum. And friends, for the first time, we are having online streaming of this 6th annual conference right from morning till evening, so that doctors in the remote area, they can also access to the developments in the field. We have one stall from the Dichi Dehadan organization as well this time, and I would request everybody to just pay a visit to them to encourage them for their noble cause. And now I offer you the academic feast for next few hours, and we have tried to keep our program for clinical interest and useful in the day-to-day practice, but shortcomings might be there, and we welcome all the suggestions so that we can improve upon it in future. Thank you very much.
Thank you, Dr. Malhotra. Two important things what he said was, one is that all like-minded people. So that's a take-home message, you know, like all like-minded people join together. So those who are not like-minded, they are likely to become like-minded. Second, he said Dr. Chabda is a core person. I always say him a Nokia connecting people. That's what Dr. Chabda is. Well, with this, I'll request everybody to let's move on for a lamp lighting ceremony. I'll request all sitting on a dais, along with a very important couple of people, like I'll request Dr. Rajiv Gupta, Dr. Gombar, and another like-minded person, Dr. Atul Gupta. Please come and join all of us. All NDPF members.
all members.
Every one of you to join.
परख हम नहीं जाने जननी पूजन वंदन ध्यान को आदि
Friends, we'd like to call upon certain very important people for their achievement awards. And first of all, I'll call upon Dr. Preetham Gupta. Can his award for Dr. Preetham Gupta? And I'll request Dr. Mangla to receive his award on behalf of Dr. Preetham Gupta. Dr. Mangla, can we get the score? अतुल उधर सामने दे दो. Let's give a big round of applause for Dr. Preetham Gupta. Next, I'll call upon Dr. Wadhwani. Dr. Wadhwani is over here. Dr. S.P. Gupta is over here. Dr. Wadhwani is not there. Dr. R.S. Gulati. Can I request Dr. Rajiv Diwan receive award on behalf of Dr. R.S. Gulati? Dr. Manish can collect. Dr. Manish. Manish can collect on behalf of Dr. Nanak Wadhwani. Next, I'll call upon Dr. Amardeep Sachdeva, the past president of IMA Delhi North Zone, Delhi Rohini Zone, family physician in Rohini, more than 20 years of experience. Dr. Amardeep Sachdeva. Anybody who has presented the e-poster, please go on the back side of this auditorium. Dr. Rajiv is there already to take care of all your poster presentations. Dr. Amardeep Sachdeva, already seen over there. Dr. Amardeep Sachdeva. Next in the line is Dr. Vikas Sharma. Dr. Sharma, get ready. NDPF Appreciations Award. First goes to Dr. Amardeep Sachdeva. Wonderful. Can I have Dr. Vikas Sharma on a he is a consultant physician in Rohini for more than 20 years of experience. Dr. Vikas Sharma. I'll request Dr. Abhishek Kumar, the past president of IMA Delhi North Zone, and he is in MCD, Municipal Corporation of Delhi, for more than 15 years. Please be on a dais. Next, may I call upon Dr. Girish Tiwari, the Vice President of IMA Delhi North Zone. Dr. Girish Tiwari. Dr. Amarpreet Pal Riyar, President Dwarka Physician Forum. Amarpreet Pal Riyar, to be received by Dr. P.K. Goel. Next, I'll call upon three very important persons from FIAMA, Dr. Rohan Krishnan, Dr. Rishi Raj Sinha, and Dr. Nandita Thakkar. Please be on a stage to receive the awards. The young dynamic brand force of India. We are all retiring, and as Dr. Malhotra said, all like-minded people. We have a new brand, firebrand people, firebrand Dr. Rohan Krishnan, Rishi Raj Sinha, and Dr. Nandita Thakkar. And next honor to be done by none other than Dr. Atul Gupta. Our old firebrand person to new firebrand person. And finally, I'll call upon our Vice President of North Delhi Physician Forum to pay a vote of thanks to all the organizers, all the contributors, all the receivers of this particular conference. Dr. Jha.
Thank you, Dr. Rakesh Gupta. First of all, I must thank Dr. Rakesh for organizing such a good inauguration ceremony. Then thanks, though the session is still there. So I thank first the founder president, then the president Dr. A.K. Malhotra, secretary Dr. Sandeep Miglani, treasurer Dr. S.K. Mundra, and all members of the North Delhi Physician for sparing this valuable time and organizing the conference. And last but not least, all the delegates, I'm honored to have them in the conference. The conference will last till 5 p.m., so I request all the delegates to please bear with us and stay till the end. So thank you everybody.
And next I'll call upon the most important part of any ceremony, which I'm going to request is, please stand together for this Bharat National Anthem.
पंजाब सिंध गुजरात
Thank you very much. Thank you, everybody. And, Jai. Mera Bharat Mahan. Thank you very much, and let me hand over this ceremony now to Dr. N.N. Jha to conduct the complete scientific program. Thank you very much.
Thank you, Dr. Rakesh. Now we'll be moving to the next scientific session. Further informed that e-poster presentation will be concluded in a separate room. So those who want to put the posters, please go to the next room. And prior announcement, we have promised that after this inauguration ceremony, with the prize, Dr. Sandeep Irani, please come to the stage and announce the prizes and the name of the team for the quiz competition.
First prize is for team number 7.
Team number 7.
They can come on stage.
Then come on the stage and Dr. Mukesh Bhatia. Dr. Mukesh Bhatia. Anyway, you announce the thing. Okay, second prize is?
For team number 8.
Second prize is team number 8.
And third prize is for team number 1.
Third prize is team number 1. And Dr. Malhotra will coordinate about the prizes and the prize giving ceremony. Dr. Mukesh Bhatia, please give the prizes to them. Now we are going to have a very eminent hematologist, hemato-oncologist, Dr. Rahul Bhargav. He is not new to this forum. Every year he comes and gives a very wise lecture which is enrich our knowledge. He is Director of Hematology and BMT Fortis Hospital, Gurugram. And the chairperson is Dr. Yoginder Gupta. Dr. Yoginder Gupta is there? No. Dr. Jagdeep Chugh. Jagdeep Chugh is a senior consult physician at Fortis Hospital, Shalimar Bagh, having his own center, Satya Medical Center in Gujranwala town. Dr. Rajiv Dewan, very academic person. He is a senior consultant at Saroj Hospital, Rohini. Dr. Amit Jindal. Amit Jindal is also senior consultant, Department of Medicine, Fortis Hospital, Shalimar Bagh. Now I request the chairperson to start the proceedings.
Good afternoon, everybody. Dr. Bhargav doesn't need any introduction. Okay. Let's come to the point.
Yes,
Today he will be talking about blood cancer made easy. Dr. Rahul, please.
Thank you, sir. Thank you. छावड़ा सर, जितने लोग बाहर हैं उनको अंदर बुला लें. People standing outside can come inside, and next 10 minutes they can listen to what I have to speak. Thank you, North Delhi Physician Forum, for giving me this opportunity. It's always like a homecoming. Believe me, the warmth which I get from here, though I mean, my mother stays in Shalimar, Lawrence Road, and I was supposed to come every week, but it makes an every year opportunity, thanks to Dr. Chavda, to come and deliver a talk to you. So, ब्लड कैंसर बहुत सारी चीज़ें बदल चुकी हैं. ब्लड कैंसर से बहुत सारे लोग जिंदा रह रहे हैं, और मेरे फैमिली फिजिशियंस और फिजिशियन फ्रेंड्स, प्लीज़ बिलीव इन दैट पावर राइज इन योर हैंड्स टू डायग्नोज देम अर्ली. सो सिंपल सी चीज़ क्या है, सोचना ज़्यादा है. जैसे हम डायबिटीज़ और ब्लड प्रेशर, हाइपरटेंशन के लिए इतने तहे दिल से सोचते हैं, वैसे ही हीमेटोलॉजी के बारे में सोचना थोड़ा सा ज़्यादा है. तो अगले 15 मिनट में हम यही बात करेंगे. सो ब्लड कैंसर मेड ईजी में 5 केसेस हैं. जितनी जल्दी जल्दी अपन आंसर करते जाएंगे, उसको आगे बढ़ते जाएंगे. ओके सर, आ जाए. ओके, स्टूडेंट्स कैन ऑल्सो सिट. यार, ये आप लोगों को ब्लड कैंसर आगे बहुत देखना है, क्योंकि अपन 75 साल तक सब जिंदा रहेंगे. ऑडियंसेस में वैसे कोई बूढ़ा तो नहीं है यहाँ पे, सभी जवान हैं, बट जिनकी एज बाय चांस 60 से ऊपर हो गई है, उनके लिए कुछ क्वेश्चंस हैं. 60-year-old presented with pedal edema, breathlessness and some frothing in urine. मतलब बहुत ही कॉमन चीज़ है. कंस्ट्रक्टिव पेरिकार्डिटिस नहीं है भाटिया सर, ये हार्ट की में TRMR, थोड़ा बहुत TRMR है, और कोई 2-4 साइंस हैं इसमें. first investigation was cardiac as usual, which was normal. No history of alcohol, smoking. Echo outside done was normal. So बहुत commonly echo हम जब बाहर से करा के लाते हैं तो वो normal होता है. और आज कुछ हम अलग बीमारियों के बारे में बात करेंगे जो normal नहीं है. AML, CML, CLL आप सबको पता है. कुछ अलग बीमारियां हैं जिनके अपन बारे में बात करेंगे. हिस्ट्री ऑफ डायबिटीज एंड हाइपरटेंशन फॉर 10 ईयर्स. हीमोग्लोबिन 8.7 है, TLC 5600, प्लेटेड 2.5. मैंने कल भी एक पोस्ट डाला था कि जब भी सर आप लोगों के पास हीमोग्लोबिन की CBC की रिपोर्ट आती है, ट्राई टू एक्सट्रैक्ट एज मच एज पॉसिबल फ्रॉम दैट CBC रिपोर्ट. इस डेंगू के समय में बहुत सारे लोगों को CLL डायग्नोस होता है. इसी डेंगू के समय में बहुत सारे लोगों को थैलेसीमिया डायग्नोस होता है, क्योंकि हम देश में बहुत कॉमनली ब्लड इन्वेस्टिगेशन कराने लगे. सो इसका MCV MCH नॉर्मल था. टोटल प्रोटीन 7.2 था, एल्बुमिन 3 था, ग्लोबुलिन 4.2 था, क्रिएटिनिन 1.4 था, अप टू 1.2 नॉर्मल था, यूरिया 76 था. ऑन डायरेटिक्स एंड मेटफॉर्मिन एंड टेल्माई. अब मैं देखो स्पेशलिस्ट नहीं हूँ कि टेल्मा ए देना चाहिए नहीं चाहिए, वो अपन बाद में बात कर सकते हैं कि क्रिएटिनिन बढ़ा हुआ था, टेल्मा ए दे ना दे. व्हाट इज द नेक्स्ट ब्लड टेस्ट? सो देखो एको नॉर्मल है, 60 साल के बंदे को पीडल एडिमा है. इस बार उसको पीडल एडिमा भी उतर रही है, मतलब एसाइटिस नहीं है, सिर्फ पीडल एडिमा है और ब्रेथलेसनेस है. एंटीप्रोबियन भी बहुत सारा बढ़ा हुआ है मैडम, 5000 10,000 है. सो परफेक्ट. इसमें एल्बुमिन नॉर्मल है, फिर भी ग्लोबुलिन बढ़ा हुआ है. और एक ऊपर हिस्ट्री बहुत कॉमन है, फ्रॉदिंग इन यूरिन, जो हम बहुत कॉमनली मिस कर जाते हैं कि जब हम पूछते हैं कि फ्रॉदिंग इन यूरिन तो नहीं होती. सो नेक्स्ट इन्वेस्टिगेशन में PS वाज नॉर्मल, ESR वाज 78. सो यूरिन में 4+ प्रोटीन था. नेक्स्ट इन्वेस्टिगेशन में 24 आवर यूरिन प्रोटीन 3 ग्राम था, इन स्पाइट ऑफ क्रिएटिनिन बीइंग 1.4. डायबिटीज है तो ये डायबिटिक नेफ्रोपैथी हो गई, पर बेचारा हिमेटोलॉजिस्ट केस लेके आया तो डायबिटिक नेफ्रोपैथी तो नहीं होगी, है ना. आंखों की चेक करवा लिया, डायबिटिक रेटिनोपैथी भी नहीं थी. मतलब इतना आपने इंसुलिन अच्छे से कंट्रोल किया सर के माध्यम से, लॉन्ग एक्टिंग शॉर्ट एक्टिंग मिक्स करा के आपने अच्छा कर दिया, तो उसकी डायबिटीज कंट्रोल थी. डायबिटीज के बाद भी क्रिएटिनिन बढ़ा हुआ था. तो सर ऐसे केसेस आपके पास बहुत कॉमन आते हैं, क्योंकि आपके पास अब 20-20 साल 25-25 साल वाले डायबिटिक नॉर्मली आते हैं. तो इसका डायग्नोसिस क्या निकलेगा सर? इम्यूनोफिक्सेशन करवाया 24 आवर यूरिन प्रोटीन पे, जो 3 ग्राम का प्रोटीन था. आपका डायबिटिक किसी का क्रिएटिनिन लो चल रहा हो, नॉर्मल चल रहा हो, हाई चल रहा हो, सडनली वो जंप कर जाए, उसमें प्रोटीन आने लगे, तो इम्यूनोफिक्सेशन टेस्ट करवा लीजिएगा सर. इम्यूनोफिक्सेशन पे कापा, लैम्डा और IgG-M पता चल जाता है, जिससे हमें पता चल जाता है कि ये मोनोक्लोनल तो नहीं है. सो ये IgG लैम्डा की जगह सिर्फ लैम्डा रिस्ट्रिक्शन आ गया. इसका बोन मैरो में 5% प्लाज्मा सेल्स थे. जो इसका जो एको था, इसमें रिस्ट्रिक्टिव पैटर्न था और स्पेकल्ड पैटर्न था. इसकी फिजियोलॉजी में रिस्ट्रिक्टिव फिजियोलॉजी के साथ स्पेकल्ड पैटर्न था. तो डायग्नोसिस क्या बन गया? एक बहुत ही कॉमन जो मिस डायग्नोज होता है सर, वो अमाइलोडोसिस होता है. अमाइलोडोसिस का पेशेंट डायग्नोसिस, बोन मैरो में 5% प्लाज्मा सेल्स, डायग्नोसिस एंड अमाइलोडोसिस. अमाइलोडोसिस 25 प्रकार का होता है, उसमें से 3 प्रकार का अमाइलोडोसिस काम करता है. उसमें A, जो आपके ट्यूबरक्लोसिस के पेशेंट है या डायबिटिक के पेशेंट है, उसको AA अमाइलॉइड हो जाता है, या दूसरा AL अमाइलोडोसिस जिसमें लाइट चेन रिस्ट्रिक्शन होती है, या तीसरा ट्रांसथायरेटिन, जो कि अब दवाई के माध्यम से ठीक हो सकता है, जिसमें कार्डियक, नर्व, GI, ये किडनीज ये इन्वॉल्व होती हैं. रीनल अमाइलोडोसिस अकेला काम कर सकता है, जिसमें प्रोटीनूरिया होता है. तो प्लीज अगली बार अगर आपके पास कोई प्रोटीनूरिया के साथ आता है तो इन्वेस्टिगेशन में इम्यूनोफिक्सेशन, सीरम प्रोटीन इलेक्ट्रोफोरेसिस जरूर याद कराएं. जो स्मॉल फाइबर न्यूरोपैथी के साथ जो टिंगलिंग नमनेस के साथ में आते हैं, अगर वो डायबिटिक कॉज नहीं है, वो भी अमाइलॉइड या पैराप्रोटीन इंड्यूस न्यूरोपैथी हो सकते हैं. और बहुत कॉमनली है बैक पेन, हाईएस और एनीमिया. इतना तो बेचारा स्लिप का चरित्र खराब नहीं है ऐसा, जितनी बार हम उसको डिस्क को स्लिप करा देते हैं. स्लिप डिस्क इज नॉट ऑलवेज स्लिप डिस्क, बट इट कुड बी मल्टीपल माइलोमा. सो बैक पेन, हाईएसआर एंड एनीमिया इज मल्टीपल माइलोमा. सो अमाइलोडोसिस का ट्रीटमेंट 3 ही टाइप का अमाइलोडोसिस का ट्रीटमेंट होता है, जिसमें माइलोमा की तरह ट्रीट करते हैं और पेशेंट ठीक हो जाता है. ठीक तो क्या, कंट्रोल हो जाता है. मतलब हम क्योर नहीं कर सकते पर कंट्रोल कर सकते हैं. सो ब्लड कैंसर इज नो लॉन्गर अ डेथ सेंटेंस. केस 2 सर, बहुत सारे आपके पास डेंगू के पेशेंट आते होंगे. डेंगू के पेशेंट का TLC रिकवर नहीं करा, प्लेटेड रिकवर नहीं करा. 4 हफ्ते हो गए, उसका प्लेटेड 20,000 पे अटका हुआ है. TLC उसका जो बेचारा 5,600 पहुंचा था, वो 2,000 पे आ गया. लिम्फोसाइट बढ़ गए. नेक्स्ट टेस्ट कौन सा कराओगे सर? हिमेटोलॉजिस्ट को याद करोगे, सीरम फेरेटिन टेस्ट करा लोगे. अगर सीरम फेरेटिन 12,000 आ गया तो उसका डायग्नोसिस HLH का हो जाता है। सर एक HLH नामक बीमारी भी आज की तारीख में बहुत कॉमन आती है, जो PU पायरोक्सी ऑफ अननोन ओरिजिन में पता चलती है। सो केस 2 डेवलप पैनसाइटोपेनिया आफ्टर 2 वीक्स ऑफ वायरल इन्फेक्शन, हीमोग्लोबिन 5.6, MCV 102, TLC 1200, न्यूट्रोफिल 30, लिम्फोसाइट 70, प्लेटेड 12। नेक्स्ट टेस्ट, नेक्स्ट इन्वेस्टिगेशन। सो नेक्स्ट इन्वेस्टिगेशन में LDH कराया, LDH नॉर्मल था। सो LDH इज अ मार्कर ऑफ सेल टर्न अराउंड। जब भी आपके दिमाग में हो कि सेल टूट ज्यादा रहे या बन नहीं रहे, टूटने के लिए पकड़ लीजिए LDH को। अगर LDH नॉर्मल था तो इसका मतलब सेल ज्यादा नहीं टूट रहे, वो बन ही नहीं रहे। सो LDH नॉर्मल था, बोन मैरो एस्पिरेशन बायोप्सी पे डायग्नोसिस एप्लास्टिक एनीमिया निकल गया। सो ये बहुत कॉमन सिनेरियो है जहाँ पे पैनसाइटोपेनिया के पेशेंट आते हैं। बट करना क्या है, डोंट गिव स्टेरॉइड्स। तो हमारे को प्राइमरी फिजिशियन को क्या करना है, हमारे को बोन मैरो ट्रांसप्लांट नहीं करेंगे, हमारे को उसको उस जगह तक पहुंचाना है जहां ट्रांसप्लांट पहुंचे, पर उसको फंगल निमोनिया ना हो और उसको बैक्टीरियल निमोनिया नहीं हो, क्योंकि जब तक वो पहुंचेगा टर्शियरी केयर सेंटर पे वो मर ना जाए। एक स्टडी कहती है बिहार से आदमी को जब पहली बार डायग्नोस होता है और एम्स तक पहुंचता है तो वो 1.5 से 2 महीने लगा चुका होता है और 1.5 से 2 लाख रुपए खर्च कर चुका होता है मल्टीपल एरियाज में जाके। तो इसीलिए प्राइमरी फिजिशियंस के लिए बहुत इंपॉर्टेंट चीज है पैनसाइटोपेनिया, जहां पे न्यूट्रोफिल काउंट 500 से नीचे हो, उसको एक एंटी फंगल वोरिकिनाजोल की टैबलेट दे दो। लिवर पे ध्यान रख लीजिएगा, वोरिकिनाजोल से लिवर पे फर्क पड़ता है और उसको हेलुसिनेशंस होते हैं। बोन मैरो कैन बी डन एट एनी प्लेटेड काउंट्स एंड रेफर टू द हेमेटोलॉजिस्ट एट द अर्लीस्ट। जीरियाट्रिक एनीमिया, सर मैंने क्या कहा था, यहाँ पे कोई बूढ़ा नहीं है, पर कुछ की उम्र तो 60 साल से ऊपर चली गई होगी। तो जीरियाट्रिक्स में बहुत कॉमन चीजें होती जा रही है, क्योंकि आपके पास अब लोग 75 साल तक जिएंगे, 80 साल तक भी जिएंगे, और जो रोज ड्रिंक करते हैं वो खुशवंत सिंह की तरह 95 साल भी जी जाएंगे। ठीक है, तो नॉट प्रोमोटिंग एनीथिंग। 65-year-old फीमेल प्रेजेंटेड विद वीकनेस एंड टायर्डनेस एंड ब्रेथलेसनेस, तो कॉमन चीज है। सो टायर्डनेस हो गई, ब्रेथलेसनेस हो गई। हीमोग्लोबिन 6.8, MCV 102, MCH 26, रेटिंग 0.6। इसका मतलब सेल बड़े हो गए, मैक्रोसाइटोसिस हो गया, रेटिक बढ़ा नहीं, इसका मतलब हिमोलिटिक नहीं था। तो अपने एनीमिया के वर्कअप में CBC के साथ में रेटिकुलोसाइट काउंट जरूर करवा लीजिएगा। 2 मिनट बचे। प्लेटेड 1,20,000 है। नेक्स्ट इन्वेस्टिगेशन PS ऑन बोन मैरो एस्पिरेशन, बायोप्सी इन NGS, नेक्स्ट जनरेशन सीक्वेंसिंग, क्योंकि द रियल की नॉट लाइज इन योर डॉक्टर, नॉट इन यू, बट द की इंपॉर्टेंट थिंग विच लाइज फॉर अ राइट ट्रीटमेंट लाइज विद इन योर ओन जीन्स। तो अगर आप अपने जीन्स को पहचान जाते हैं और आपका डॉक्टर आपके जीन्स को पहचान जाता है तो वो अच्छा इलाज कर पाता है। डायग्नोसिस निकला इसका 5Q सिंड्रोम। बोन मैरो पे इसके जो मेगा कैरियोसाइट्स दिख रहे हैं वो 5Q जैसे हैं, बड़े बड़े मेगा कैरियोसाइट, मोनोलोबेटेड। ट्रीटमेंट क्या था, लिनालेडमाइड की एक गोली खा के ठीक हो गई। इसको बोन मैरो ट्रांसप्लांट की जरूरत नहीं थी, एक गोली खा के ये ठीक हो गई। लास्ट केस 80-year-old रिकरेंट फीवर, वीकनेस एंड रिकरेंट ब्लड ट्रांसफ्यूजन। 80 साल का आदमी अलास्का के क्रूज से आया, उसके बाद उसका हीमोग्लोबिन गिरना कम हो गया, स्टार्ट हो गया। हीमोग्लोबिन 4.5 रहा, MCV 98, MCH 27, रेटिंग 1.2। इसका मतलब बोन मैरो बनाने की कोशिश जरूर कर रही थी, प्लेटलेट नॉर्मल था। सिंगल लीनिएज इन्वॉल्व है, एक ही लीनिएज इन्वॉल्व है, आयरन डेफिशिएंसी दे दिया, B12 दे दिया, कुछ नहीं हुआ। नेक्स्ट इन्वेस्टिगेशन बोन मैरो एस्पिरेशन, द डायग्नोसिस वाज रिंग सिड्रोब्लास्ट, MDS विद रिंग सिड्रोब्लास्ट। मैं क्यों हाईलाइट करना चाहता था, क्योंकि रिंग सिड्रोब्लास्ट आज की तारीख में बहुत कॉमनली पाए जाते हैं। माइलोडिस्प्लास्टिक सिंड्रोम, तो आज की ट्रीटमेंट का क्या मुद्दा था, एक अमाइलोडोसिस, एक माइलोडिस्प्लास्टिक सिंड्रोम और तीसरा एप्लास्टिक एनीमिया के बारे में चर्चा करना, क्योंकि ये कॉमन बीमारियां हैं। अगर किसी 60 years old में आपका हीमोग्लोबिन नहीं बढ़ रहा, थिंक माइलोडिस्प्लास्टिक सिंड्रोम आफ्टर गिविंग B12 एंड आयरन। It is very important to investigate geriatric anemias. Common cause IDA nutritional, myelodysplastic syndrome, myeloma, colon cancer, renal dysfunction and drug induced. एक और फ्रेंड्स, एक और चीज ध्यान रखिएगा, कभी भी किसी पुरुष का हीमोग्लोबिन कम होता है तो एंडोस्कोप, कोलोनोस्कोप जरूर करवा देना, क्योंकि या तो हीमोरॉइड्स होंगे या उसको 1 in 1000 में कोलन कैंसर निकल जाएगा। And with this we come to an end. Proud to be this part of this team who does almost 250 bone marrow transplants, one of the largest transplants unit after CMC Vellore in the country. With your blessings and with everybody's blessings, we are trying to create these bone marrow transplant networks. Thank you, everybody.
Thank you, Dr. Bhargav, for excellent and crisp to the point clinical presentation. If anything, any question there from audience?
Yes, sir.
Mic, please.
Yes, sir. So myelodysplastic बहुत ही किसी भी प्रकार से आ सकता है सर। वो लो TLC से आ सकता है, लो हीमोग्लोबिन से आ सकता है, लो प्लेटलेट से आ सकता है। सर इंपॉर्टेंट चीज़ क्या देखनी होती है उसमें, न्यूट्रोफिल लिम्फोसाइट रेशियो सर इसमें जो पेपर इसमें था लिम्फोसाइट ज़्यादा थे। सो माइलोडिस्प्लास्टिक सिंड्रोम में तीनों लीनिएजेस कैसे भी एक्ट कर सकती है। अभी और कंफ्यूज करने के लिए मैं आपको नहीं लेके नहीं आया, आइकस होता है इडियोपैथिक साइटोपिनिया ऑफ अनडिटरमाइंड सिग्निफिकेंस, फिर एक CCS होता है साइटोपिनिया क्लोनल साइटोपिनिया विद अनडिटरमाइंड सिग्निफिकेंस, मतलब आपका काउंट स्लो है, क्लोनल एब्नॉर्मेलिटी मिल गई पर वो MDS में कन्वर्ट नहीं होगा। सो सर अगर मेरे को दोबारा एग्जाम देना पड़ता तो मैं फेल हो जाता, पर मोटी मोटी बात यह है कि हमारी हीमेटोलॉजी में रोज नए नए इनोवेशंस हो रहे हैं, जिसके माध्यम से हम वो 0 से 60 की जर्नी पहुंच गए। 60 से अब 80 की जर्नी पहुंचने में एक दशक और लगेगा, बट एक बात ध्यान रखिएगा कि हाँ 60% लोग आज बोन मैरो ट्रांसप्लांट से और हीमेटोलॉजिकल मैलिग्नेंसीज में क्योर हो जाते हैं।
I have no question but a comment.
Yes,
It was an excellent presentation.
Thank you
very
sir.
much.
So we have learned from the best like you, sir.
Thank you.
Thank you.
Dr. Bhargav, for
Thank
your
you
best
very much.
presentation. Thanks a lot.
Thank you.
Thank you, Dr. Bhargav and our chairpersons. I will now request our chairpersons to please honor Dr. Bhargav. And I request Dr. P.K. Bhardwaj, Director of Saroj Hospital, to honor our chairpersons. In the meantime, we should start the process of next lecture. Lecture is set announces renal cell carcinoma. And the speaker is Dr. Atul Goswami. He is the Chief and Senior Consultant, Department of Urology, Uro-Oncology and Renal Transplant at Sri Balaji Action Hospital. Dr. Atul Goswami. And the chairperson, Dr. Suchin Bajaj, Senior Physician in North Delhi, and he is an entrepreneur. He has got a lot of hospitals. He is a director of a lot of hospitals. And then Dr. Sunil Mangla, I think is left. Dr. Sunil Mangla, Dr. Birat Chabra. Dr. Sunil Mangla is Senior Consultant Physician at Fortis Hospital, Shalimar Bagh. Dr. Birat Chabra, he is also very senior consultant in medicine, practicing in Rohini. And Dr. Rajiv Diwan. Dr. Rajiv Diwan. And now request our organizers to honor Dr. P.K. Bhardwaj. Request the chairperson to start the proceedings.
Hello. I welcome Dr. Atul Goswami to come on the dais and please deliver his lecture. He is a senior consultant in Action Balaji. I request him to please start his session.
Thank you, Dr. Mangla and Dr. Chabra. So we are starting our lecture, and I want to thank all the physicians of this North Delhi Physician Forum also, who have shown a lot of trust in me, and they have supported me all the way in my journey of this 28 years. I have started my practice from Sundarlal Jan Hospital, and most of the people knows me very well, and they showed a lot of faith in me so that I could perform a lot of big surgeries also. And I just want to show some what are the latest thing what we are doing. And as you know that this renal cell carcinoma has got only 3% of majority of the cancers, and it is more common in male patients than in the female patients. And as the age increases, the incidence increases, and it is more commonly seen in the patients who are having a risk factor like obesity and hypertension, and they are the smokers. The classical triad which we used to learn was pain in the loin and lump in the abdomen and hematuria. This pain was due to the clots basically. It used to be clot colic, and the lump was of the renal masses. But this was basically in the old time. Now these days we are getting ultrasound for any minimal problem to any patient. So most of the renal tumors now we detect on the ultrasound examination. And on the ultrasound examination, it shows there is a mixed echogenicity of the lesion which is arising from the kidney. And then to confirm whether this lesion is a neoplastic lesion or it is a benign tumor, we get a contrast CT scan. So this contrast CT scan is called as CT KUB, which includes the kidney, ureter and bladder. And the characteristic finding is, if we find that the Hounsfield value of this tumor after giving the contrast increases by 20 units, that means it is a diagnostic of the malignant tumor. So if we are knowing that it is a malignant tumor, so ideally this investigation should be done in the form of a CT angiography also. Because of the latest treatment which has changed, especially for the smaller tumors, it is important to know the vascular anatomy of these patients, and so that we can see them. Like in this patient, you can see there is a lower polar tumor which is arising from the lower pole. And these patients who are having a smaller tumor, they are these days subjected to the partial nephrectomy, not to the radical nephrectomy. So if we have to do a partial nephrectomy, it is better for us to understand that vascular anatomy of the kidney, so that we can sometimes selectively clamp those vessels and then we can remove this tumor completely. This is another patient who is showing another upper renal mass. This is CT finding. And this again is the CT renal angiography which I was telling. It generally tells us how many arteries are there, how many basically veins are there, because whenever we have to do the surgeries, we should know, so that we don't, like majority of these days, we are doing a laparoscopic surgeries, especially if the tumors are not very big in size. And for that, if the anatomical knowledge of the renal vasculature is available to the surgeon, he can definitely do a good job, and it is almost neat and clean. Invariably, there is no need for any blood transfusion also. Like MRI, when should we get an MRI done in the patient who is having a renal tumor? There are very limited indications these days because of the high resolution spiral CT scan that gives a lot of information which we can now, which we can give us a lot of decision making features. So MRI is basically useful when the disease is advanced, it is infiltrating into the muscles or the surrounding structures, and especially it is useful if it is the renal tumor has extended into the veins, like it has extended into the renal vein or into the IVC, or in the patient who are having a CKD, or in fact in pregnancy patient where we don't want to subject the patient for a CT scan. So in this patient, like you can see, this is a MRI film. This was a tumor in the left kidney, and the tumor was extending into the IVC. So for this patient, it is helpful, and we can know the extent of the tumor, whether it, at what level this tumor is extending, so that we can plan our surgical decision. This again is an MRI film which shows a tumor in the basically patient who is having a CKD, in which we don't want to give any contrast. So these patients can be assessed with the MRI scan, and then we can operate these patients. These are the routine investigation. I think all of us knows very well. And I would like to just highlight a little bit of things like kidney anatomy is important, little bit of it for everybody. Like this is the adrenal tumor which is attached to the upper pole, and the kidney is basically covered by a fibrous tissue which is called as Girota's fascia. If the tumors are limited within the Girota's fascia, invariably the prognosis is very good, and these patients survive 90% of the time for approximately 10 years, 20 years they can survive, depending on the histopathology of the renal tumors. So staging is again depends on the tumor size, whether it is invading the Girota's fascia or renal veins, or there are lymph node or distant metastasis like metastasis into the lungs and other stuff. I am not going in the details of all this, but I just want to share, in most of the patients who are having a T1 tumor, which is basically if the tumor is limited to the kidney, we divide the tumors into if it is less than 4 centimeter or if it is more than 4 and 7 centimeter. So if the tumors are less than 4 centimeter, we should always do a partial nephrectomy in these patients, because that will save the renal, that will save a lot of nephrons, and ultimately the patient will not go into the CKD. In some of the patients who are having a tumor more than 4 centimeter but less than 7 centimeter, and especially in the exophytic tumor, if the majority of the tumor is exophytic, even then we can do a partial nephrectomy in these patients and we can save the kidneys. This is important because these patients have to live without a kidney. If we'll remove the kidney the whole of their life, and they will have a CKD, that problem. And then PET scan. Again, I would like to just say one thing. PET scan invariably is not required in the preoperative assessment of the patient. We do it, we follow up. PET scan is done if we have to find out if there is any recurrence in this patient or not. This is this is mainly for the investigation part, which is we take into consideration whenever we are operating these patients. And then we have the treatment option, wait and watch. I have written wait and watch. This is again a question mark, especially in the very small tumors. If the tumor is less than it with 2 centimeter or 3 centimeter tumor, sometimes some of the patients, they can go for wait and watch policy also, especially if it is a papillary tumor. Although right now we don't have the investigative or diagnostic tools which can tell us what is the histopathology of this tumor, but in future maybe we will be able to get the some of the features which can tell us whether it is a clear cell carcinoma or it is a papillary cell carcinoma, which has got a better prognosis, and those patients can wait for some time for these tumors to be operated. I know one of our urologist chief, who is very respectful person in our urological association. He himself was harboring a small tumor, and he got operated after 6 years, and his son operated, and I witnessed that case very well. So otherwise, in majority of the patients, we do a partial nephrectomy, and which can be done with the open technique. We should not hesitate in going for an open surgical technique also if there are technical problems, or we can do it laparoscopically or robotically. So the tumors which are basically bigger in size, in those patients we do a laparoscopic nephrectomy. So I'm just showing you this short video in which you can see there was a lot of adhesion in this patient. So we could remove all those adhesions with the help of laparoscopic instruments only. And this is the basically colon which we are reflecting. It is right-sided tumor, and we are reflecting the colon from the kidney. As we know that the kidney is covered with the colon, especially right-sided, and it is covered with the duodenum. This is the duodenum what we are separating now, and we can see the IVC. Just after reflecting the duodenum, we can see the IVC, and then we lift the kidney laparoscopically. It is almost bloodless. You know, even the surgery what we do open, we have to lose a lot of blood doing that surgery, in even opening only. So here we can see the vessels. This was an artery, you can see, and vein, and we can clip the arteries with the wet clips, which are very good clips these days, and it secures the vessels completely. And we put 2-3 wet clips there, and we divide the renal artery. As soon as the renal artery is cut off, then the most of the bleeding will stop. That is why it is important to know the renal vasculature anatomy, which I was talking. And now this is the renal vein, and once the renal vein is there, we are dissecting the renal vein, and all the accessory lymphatics and other things we divide after putting the clips, and the renal vein is also clipped in the same way. In this patient, there were some lymph nodes also. So we wanted to be sure whether the lymph nodes are showing any metastasis or not. So after dividing this vessels, we could, this was a lymph node. It was a big lymph node. So this is the ureter which we were dividing, and then the whole of the kidney is also mobilized and it is removed. And we give a very small incision, in fact in the pelvic area, and we can remove the complete this kidney from that area, and which is cosmetically very good. And this is the lymph node which we are removing with the help of a laparoscopic instruments only. And you'll see there is hardly any bleeding, and we can get some diagnosis whether there is a metastasis into the lymph node are there or not. Because if there are metastasis, we can sometimes give these patients pasopnip and other treatment. This is again a small clip. Again, I will show you a partial nephrectomy, how we do a partial nephrectomy, I think. This I'll just try to run because we are running short of time. So anyway, these are the vessels which we loop and we clip these, we put a partial clamps, which are laparoscopic clamps we have. We can put our clamps there, and we can stop the blood supply of the kidney for maybe 20 minutes or 30 minutes. And during that time, we have to remove this tumor. This is the tumor which you can see in the kidney. It was lying just above the vessels. And this is back is the artery, and these are the two veins. So out of the two veins, we ligate one of the vein, and then we did a partial nephrectomy. This is the 1 year post-surgery. These are clips are seen in the kidney. And this is again 5 minutes or more. I will just show you. Sometimes this patient will come with a problem on the other side also. This is a patient who was having a multiple stones on the other side, and there was a tumor in the left kidney. So what we did is we did a RIRS, in which in the same sitting, first we did a RIRS, we broke all the stone with the laser, and we put a DJ stent, which was removed after the clearance, and then we did a laparoscopic nephrectomy to this patient. This is a few things. One more clip I would like to show. Only thing is, once this tumor is there in the IVC, even those patients can be saved very well, and we have removed the whole tumor from this IVC, and then this patient was subjected to pasopnip treatment, and he was having a solitary liver metastasis which was also excised after 6 months, and then patient is doing very well. This is in a one rare case which we did in our institution, which is with the help of our CTVS team. This patient was having a tumor thrombus which was extending up to the atrium. So this is the echocardiography which they are doing, and there was a thrombus in the atrium, and we opened the heart, and simultaneously we removed the kidney also, and the whole of the thrombus in the IVC was removed, and the CTVS team removed the thrombus from the right side, and then they closed it, and the patient was walking next day. After 2 days, the patient was seen walking around, and he was doing very well. Thank you very much. We are running short of time, and thank you. And I would just want to share, keep your hobbies up. Thank you, Dr. Singh. Any question?
Thank you, Atul, for the wonderful presentation.
Thank you.
And
Thank you.
If there is any question from the audience, you're most welcome. Okay.
मेरे को पता है. I knew it. There will be less question.
Thank you.
Thank you, Chairperson and Dr. Atul. Now request Chairperson please honor Dr. Atul Goswami. I request Dr. Anil Gombar to honor the Chairperson. And next is a very interesting session, cardiology and sexual health. So the speaker is Dr. Naveen Bamri. To recapitulate, last year Dr. Bamri did a very good session, Kaun Banega Crorepati style, Kaun Banega cardiologist. And that was a wonderful, and we all liked it. This year is almost similar, he is doing this type of session. So yes, by team of cardiologists, sexual health and cardiovascular diseases. Dr. Naveen Bamri doesn't need introduction. He is a senior interventional cardiologist, director, head of the department cardiology at Max Hospital, Shalimar Bagh. And the chairperson, Dr. G.S. Kohli. Okay. Dr. Chandrasekhar, eminent cardiologist associated with Max Hospital, Shalimar Bagh. Dr. Pankaj Janeja. Dr. Pankaj Janeja. Dr. Manish Mathur. Dr. Manish Mathur. Okay, now I request the chairperson to start the proceedings. Dr. Alok Joshi. सब बाहर ही हैं, इधर कोई नहीं है.
Hi everybody. It's my privilege and honor to introduce a person who does not need any introduction. A very close friend, a dedicated cardiologist, and mind it, now an upcoming sexologist. So he's none other than Dr. Naveen Bamri. Let's give him a big hand of applause. Dr. Bamri will be talking about sexual health and cardiovascular diseases.
Give me 2 minutes, sir.
afternoon, everyone, and thank you, sir, for the sexy introduction. So around the world, people love. They eat for love, they dance for love, they sing for love, they make monuments for love. In fact, we all are victims of love. Sexual dysfunction are on the rise. And why? Because most of the time it is a vasculogenic in origin. So the new definition for the sexual dysfunction, it is psychogenic, vasculogenic, endocrine and neurogenic problem. In younger population, it is mostly a psychogenic, but once you cross the 40 years, it is mostly a vasculogenic in origin. Why vasculogenic? Because you know the innermost layer of the vasculature is endothelium. And once there is endothelial dysfunction, which is the heart of the vascular system, there is reduced production of nitric oxide, which is responsible for the vasodilation. So I am going to talk and I am going to give some nuggets of wisdom in next 15 to 20 minutes about the sexual health and cardiovascular disease. So with your kind permission, shall I go ahead? We all know the cardiovascular disease is the #1 killer, and when you talk about the cardiovascular disease, it means disorders of the heart and the blood vessels, commonly referred as the heart disease and the stroke. Now the very important question what we encounter every day in our OPDs after the angioplasties, after the bypass surgery, after the unstable angina or the medical management, is sexual activity beneficial for the cardiovascular risk? So sex is the best prescription for good health according to the study, whether you talk about the cardiovascular system, respiratory system, immune system. It acts as an antidepressant, anti-anxiety, mild sedative, and people live longer who are regularly doing sex. These are the study, Duke longitudinal study that shows that the frequency of intercourse is a significant predictor of longevity in men. Swedish study says that early cessation of sex is associated with the premature death. There was a study published in BMJ 1997, 50% reduction in cardiac death with more than 2 orgasms per week. So, I would like to say that it's my disclaimer, don't take it, otherwise there are some few pictures and songs, so this is just for the, to make it more funny and interactive. So did you know men who have sex twice a week and a woman who have satisfying sex life are less likely to have a heart attack? It is a form of exercise that strengthens your heart, lower your blood pressure, reduce the stress and improve the sleep. Around the world, 40% men and 62% women are dissatisfied with their sex life, and 50% of the men face erectile dysfunction over the age of 50 years. If you Google Viagra, there are 196 million web pages. But if you Google aspirin, there are only 56 million web pages. So what is more important? Is it sex or cardiovascular disease? So people, because the strongest urge is the sex, it's the most important urge for the human being, it is the sexual life, satisfying sexual life. So it is always better to use it, otherwise you will lose it. So what are the criteria? The criteria goes from the mild, moderate and severe. Are you able to get an erection sufficient to penetrate? And question number 2, are you able to maintain that erection till orgasm? So sometime, always, never, by inserting these formulas, sometime, never, you can calculate the mild, moderate and severe type of erectile dysfunction. Most people do not complain. They don't complain about the erectile dysfunction and all. There is significant effect on the quality of life, whether it is mental, physical and sexual health. So this is the song I can dedicate for this. I would love to get treatment, but I don't. लोग सोचते हैं कि ऐसे ऐसे निकल जाएगी गाड़ी, क्या डिस्कस करना इस बारे में? कट जाएगी. Cardiovascular disease and sexual dysfunction, CVD can directly impact sexual function through various mechanisms. It is endothelial dysfunction, hormonal imbalances, psychological factors. These highlight the importance of addressing the sexual health in patients with cardiovascular disease. What happens during normal sex? During the foreplay, there is a mild increase in systolic and diastolic blood pressure, moderate increase during intercourse, but maximum during orgasm, but that lasts only for 8 to 10 seconds and returns back within 8 to 10 seconds, that the BP and heart rate returns to normal after the sexual act. So heartbeat stays at normal rate when one beds down with a legal mate, but roosting in another's nest flirts with cardiac arrest. This is a very important point. The majority of coital death occur with unfamiliar partner in unfamiliar setting after excessive alcohol and food intake. लोग सब चुप बैठे हुए हैं, पता नहीं क्यों. The sexual activity angina, the coital angina that occurs within minutes and hours of sexual activity is less than 3% of the total angina attack. Sedentary post-MI patients had higher risk of MI with sexual activity. Physically active post-MI patients had lower risk of myocardial infarction, and the relative risk is only 0.7%. If you talk about the arrhythmias and sudden death during sexual activity, annual autopsy of 5,599 patients with sudden death showed. So this was through the telephonic calls after the death with their partners, their younger girlfriends and all. Only 0.6% patient died during sexual intercourse. 93% out of which 75% were having extramarital sexual activity with the younger partners in unfamiliar settings. So calculate the risk. बिल्कुल risk नहीं लेने का. So calculate your risk whether you are in the low risk, intermediate risk or high risk. I am going to highlight the points of high risk: a patient with unstable angina, uncontrolled blood pressure, NYHA class 3 heart failure or class 4 heart failure, myocardial infarction with high risk arrhythmias, AICDs with frequent shock, poorly controlled cardiomyopathy with symptoms. There are mild and low intermediate risk patients also. The most important questions come into the mind of the patient, and they ask when to begin sexual activity. So post-MI, if you had managed him medically, after 6 to 8 weeks, you can say that you can begin your sexual activity. Post-PCI, post-angioplasty, just after 6 to 8 days, you can resume your sexual activity. Post-bypass surgery, 6 to 8 week time is the healing time of the wound, so you can resume, and post-robotic surgery after 3 to 4 weeks. Because they only ask about the sex, but this is again very important. Cardiovascular drugs that can improve the symptoms and survival should not be withheld because of the concerns about the potential impact on the sexual function. Sometimes patients see that I am taking beta blocker, that is why I am not having the proper erection and all. So diuretics, beta blockers, phenofibrates may cause erectile dysfunction. If you want to give beta blocker, nebivolol is the drug of choice. If you want to give diuretics, among the diuretics, indapamide is the best drug, and the olmesartan goes well with all PDE5 inhibitors. So 70% of the men with erectile dysfunction is associated with comorbid disease like cardiovascular disease. So erectile dysfunction is not a myth, it is a harbinger of cardiovascular disease, and that is a reality. Now, what is the connection between the ED and CVD? Erectile dysfunction may be the first sign that one has a heart or vascular issues that require medical attention, and it occurs as early as 3 to 5 years before a major heart attack or any cardiovascular event. And there are two theories behind it. One is the artery hypothesis, and the another is endothelial dysfunction, which is proven role. So why ED is considered an early sign of a warning sign of cardiovascular disease? One theory is that early atherosclerosis, because atherosclerosis is a generalized process. So narrowing in the arteries can trigger the ED. When plaque builds up in the arteries, it can reduce the blood flow throughout the body, including your genitalia. This can make it more difficult for men to maintain an erection. So what is the theory behind? Whenever there is an endothelial dysfunction, so erectile dysfunction starts even before. If you do an intravascular ultrasound of the coronary arteries, there is no detectable plaque. But if the patient is complaining of erectile dysfunction, the chances of getting cardiovascular disease in next 3 to 5 years is very high. So it is always important to ask any patient with metabolic syndrome or a diabetic whether you are having any problem while making love. If he is saying that he is having some problem in erectile dysfunction, because this is the best time you can incorporate a new lifestyle measure. Tell him to exercise more, reduce your weight, keep your BMI under control and all, because this is the earliest sign and the marker of the cardiovascular disease. So endothelial dysfunction precedes the structural disorder, plaque buildup, and the clinical event. So you can see there is an undetectable structural disorder in the arteries, but you know, at this moment of time, the patient start complaining of the erectile dysfunction. So if you go to the artery hypothesis, penile artery diameter is 1 to 2 millimeter, coronary artery diameter is 3 to 4 millimeter, carotids 5 to 6, and the femoral artery 6 to 7 millimeter. So same type atherosclerotic deposit in the coronary artery. If there is a 50% occlusion in the coronary artery, it means there is a 90 to 95% occlusion in the penile artery, and that can cause erectile dysfunction because of the reduced flow in the penile artery. So what is the normal erection process? When aroused, the nerves surrounding the penis become active, muscle around the arteries that relax, and more blood flows into the penis. Additional blood makes the penis stiff and hard or erect. This erection tightens the veins, so the blood cannot leave the penis, enabling the penis to remain erect. This is the normal erection process. So what are the diagnostic tests to detect whether patient is suffering from the arterial insufficiency or the venous insufficiency? So you have, there is a scoring system, there is a Doppler, penile Doppler. You can inject the drugs like phentolamine, papaverine, and the phosphodiesterase PGE1 cocktail. So you have to inject into the corpora cavernosa and wait for 5 to 10 minutes for the erection. If there is an erection of 80%, then you apply a Doppler and calculate the velocities. If the end systolic velocity is more than 25 millimeter second and the end diastolic velocity is less than 5 centimeter, that means there is an erectile dysfunction because of the arterial insufficiency. In the venous leakage, his peak systolic velocity is more than 25, EDV more than 5 centimeter. So there are two theories. One is venous, because the most common reason after the age of 50 years, it is the venous leaks that cause erectile dysfunction rather than the arterial insufficiency. So first line of treatment for venous erectile dysfunction is always, for both, it is PDE5 inhibitor. But the second line in venous erectile dysfunction is always, you can give the injectable therapy like papaverine injection. But if there is an arterial insufficiency, you can go for the balloon angioplasty of the penile artery with the drug-eluting balloons, and sometimes there are theories or there are literature where pudendal artery angioplasty was also done. The question is sex safe? Is sildenafil safe? Most of the patients in my OPD ask. So these are the treatment modalities, but the first and the foremost for all the level, first, second, and third line, it is always the counseling, and the lifestyle modification. That is very important. Lifestyle modification means take proper sleep, don't take any stress, eat lot of fruits, do exercise, keep your BMI less than 23. This is a very important aspect of any modality, whether first line drug fails, second line drug fails, third. But this is, you have to incorporate the lifestyle measures at every stage. So oral therapy is the first line treatment, vacuum therapy or intraurethral injections or suppositories, second line, or phentolamine injection, and third is surgery that includes implants or transplants. So all 4 PDE5 inhibitors, sildenafil, vardenafil, tadalafil, sildenafil. So the fastest acting is the vardenafil that acts within 15 to 25 minutes, and the duration of action is 4 to 5 hours, but the longest acting is tadalafil that can last up to 36 hours. Now the question is, do all the patients respond to PDE5 inhibitors? No. 30 to 40% of the patients on PDE5 inhibitors do not respond because it increases the arterial flow, but these drugs do not increase your desire. So what increase your desire? It is your lifestyle modification that increase your desire. So always lifestyle modification is the first and the foremost way. ये जैसे बोलते हैं ना कि आपका जो है बादशाह क्या है? ट्रीटमेंट का बादशाह आपका एक्सरसाइज है. एक्सरसाइज इज योर बादशाह because it improves the endothelial function, it increases the nitric oxide. People can live without oxygen but not without nitric oxide. So if you stop nitric oxide, he can live only for few seconds. So why PD inhibitors fail? Most of the time it is the dosage of the drug. Sometimes you use with full stomach just before the sexual activity, within 5 minutes. People don't know that it has to be taken at least 1 to 2 hours before your sexual activity. And it used without stimulation. That is because stimulation is the first and the foremost process of sexual dysfunction. So sildenafil, cardiac effect. We all know that there are PD11 enzymes, PDE1 to PD11. And the most prevalence is PDE5 around your genitalia or the penis, and the PD11 is most in the your back, and the PD6 in the eyes. So because PD5 inhibitors can intermingle with the PD6 and all, so that is why with sildenafil there are some ocular changes, or some people say that there is a headache. With tadalafil, most of the time people say there is a back pain because it inhibits the PD11 also. So PD11 is most on the back side of your it's more in the backbone. So cardiac sildenafil has a very low affinity for PDE3 because in the myocardium it is PDE3 dominant. Hence no effect on the cardiac myocytes. Because we are using sildenafil everywhere, pulmonary hypertension, heart failure, endothelial dysfunction doesn't harm the heart, does not increase the risk of myocardial infarction. So men at risk of cardiac complication during sexual intercourse, so these are the patients where cardiac evaluation is advisable. Elderly, physically inactive, sexually inactive since long time, or stable ischemic heart disease or cardiac risk factors. If multiple cardiac risk factors are there, must go for the cardiac evaluation before starting the sexual activity. So whatever may be the good for your penis is good for your heart. Why? Because both erectile dysfunction and the cardiovascular disease shares the same risk factors. If you talk about the metabolic syndrome, diabetes, high blood pressure, obesity, smoking, tobacco chewing, physical inactivity, so all the risk factors are same. That is why ED and CVD share the same, that is good, whatever good for your genitalia is good for your heart. So there is a well compelling evidence that ED is a risk factor, or it is a sentinel sign of the silent MI, can be a predictor of cardiac events including death in men who are otherwise asymptomatic from the cardiac perspective. So my new definition is penile angina, that is the time when there is erectile dysfunction. If you incorporate the lifestyle measures, counseling and all, and keep your penile healthy, you can prevent the penile attack that can lead to heart attack. So ED is a silent sentinel marker of silent ischemia. If there is a penile attack, there is a chance that you will get a heart attack sooner or later. So treatment is avanafil. It is a newer drug. Avanafil is the new drug which is now available in India. It is the shortest acting within 15 minutes attack. The most important property of avanafil, you can start with the nitrates also. So you just have to stop nitrate for 24 hours. With other PD5 inhibitors, you have to stop nitrate for at least 3 weeks. With avanafil, you can stop for 1 day, and you can start, if there are certain patients that they don't want to stop nitrates, then you can switch over from the nitrates to the ranolazine. There are topical glyceryl nitrates available. Transdermal gel of sildenafil nitrate is available. There are films of sildenafil and tadalafil that you can apply on the shaft. And L-arginine or nutraceuticals, L-citrulline, again a very important component of the nitric oxide donor. So what are the newer therapies? Stem cell therapies. Stem cell, it helps in the neoangiogenesis. It is the most important therapy for the patient with the, prosthetic surgeries. So stem cell therapy incorporates the neoangiogenesis, shock wave, that there is a trance, and there is a handheld device. You can apply the shock wave for 1.5 hours to 2 hours every day on the shaft of the penis. And there is a new medication which is approved just now around a month back, which has got FDA approved also. That is a topical gel of Eroxon, gene therapy, and there are some studies with the platelet-rich plasma injections. So honor of the patient lies with us physicians, because we generally don't ask the history. Because it is our duty to ask whether you are having some problem. Any patient who is having metabolic syndrome, diabetes, or the obese, must ask the history of erectile dysfunction, because onus lies on us. And the Raja of all is regenerative medicine, cell-based therapy, and lifestyle modification. So all the diabetic patients must prescribe metformin and SGLT2 inhibitors, because now there is a data with the dapagliflozin that it improves the erectile dysfunction. Sleep 6 to 8 hours a day, smile and show gratitude to all. L-arginine and fenugreek has some, there are very good results with these nutraceuticals. Reduce salt intake, be mindful what you do, avoid beta blockers and diuretics, Mediterranean diet, and the most important is have realistic expectations. So my message is increase your romance. If you increase your romance, because if you are suffering from a cardiac disease and you are very much, there is a fear, you are very fearful that कैसे होगा, कब होगा, क्यों होगा, मैं नहीं कर पाया तो, but it is not. Your partner is, you are depriving your partner of the, their rights. So woman is a masterpiece of God. She is the best phenomenon in the world, not to be compared. Your partner is your heart and your garden cultivates your garden. So if you are, you have to decide whether you are in a monogamous relationship or a polygamous relationship. If your wife, if you are, dedicated to your partner, you are into the monogamous relationship. You have to cultivate your garden. You have to fertilize it, give water, and you have to cultivate your own garden. But if you are in polygamous relationship, you are like a jungli. So you have to decide whether you are a gardener or you are a jungli. Right? No? So the untold truth is erectile dysfunction is the earliest marker of coronary artery disease. Sexual activity after any cardiovascular event can be resumed after 2 months. Sildenafil is safe. L-arginine supplement is a boon. Lifestyle measures can reverse any lifestyle disease. A heart that always loved remains young. Age, weight, height are just numbers. Sex has no expiry date. So don't go to the quacks. वो केवल बीन बजाएगा. So go to a doctor who can give you a better treatment and the better, your sexual life, make your sexual life healthy. So don't go to the quacks. So, thank you.
Real excellent deliberation, Dr. Bhamri. He deserves a bigger round of applause. Now, my question to you is, what I learned from you is the atherosclerosis which leads to sexual dysfunction as age advances. That is the only factor, or there's something more contributing to erectile dysfunction as age advances?
So once you there is an aging process, there is a fibrosis and atrophy of the cavernosa muscles. Corpus cavernosa muscle starts once you cross 50 years. A mild or little fibrosis. For erection, you need a proper dilatation of the blood vessels. So there is a veins at the, if this is the tubular structure and the veins is around, when the blood goes in, it has to compress all the veins. But once you age, the venous leakage starts, and the venous leakage is the first and the foremost primary pathology. So अगर 20 ml blood अंदर जा रहा है और 5 ml आ रहा है, you will got a proper erection. 15 जा रहा है, 10 आ रहा है, तभी भी erection होगा. But 10 अंदर जा रहा है और 20 बाहर आ रहा है. When the venous leakage is more, then it is a problem. So what PD5 inhibitors do? They will increase. 20 आ रहा है, 25 अंदर डालेंगे blood को. So this is why PD5 inhibitors are the first choice, and it happens with everyone. So after 50 years, there is always a mild erectile dysfunction in everyone, whether he say yes or no, but yes, it is there because of the natural process. But if you are maintaining your lifestyle measures, you can keep it around there. 80% erection with, it's good enough for you. So there are some questions. If you, I can ask you multiple choice questions also.
Yeah, Dr. Bhamri, just
Yes.
one point. You said the very common issue is that people on nitrates, they ask whether they can take sildenafil or not. What we normally say is that they have to miss that particular dose of, say, glycerol trinitrate, 8 a.m., 4 p.m. To miss that 4 p.m. days, the day you want to take sildenafil, so that if both are taken, they can cause hypertension. That is. But you just said you have to stop for 3 weeks. I couldn't understand.
So, even before this presentation, I was under the impression कि 1-2 दिन बंद करो nitrate or you can start the. When I was going to the literature, you have to stop it for 3 weeks before any sudden untoward event. So avanafil is the only drug where you can stop it for 24 hours. Otherwise, with all PD5 inhibitors, ideally you should stop it for, because वो एक जो है ना उनका level nitrates का body के अंदर आपके blood stream में रहता ही है up to 3 weeks.
Yeah, avanafil is not available. And
Avanafil is available now. Now it is available. Now it is available.
You used it.
Not myself.
Even we use it
यार,
no.
I think no meeting is complete without Dr. Gombar asking a question. So, Dr. Gombar.
excellent lecture. See, our diabetic patient, if you ask them, mostly they don't complain, but if you ask them, they have some problem with the sexual dysfunction.
Yes, sir.
And many of them are having CAD as well because the long-standing diabetes. So what is the exact thing you will want to advise us to tell them how to go about it? Huh? So what practical terms, what is that?
In practical terms, if you want to rule out the arterial insufficiency or the venous leak, which is a major cause of the erectile dysfunction and metabolic syndrome in diabetes, must go for the Doppler ultrasound. Ideally, which is available in in our hospital also, and most of the ultrasoundologists are doing. If they don't want to get injected into the corpora cavernosa because we have to inject.
But nobody wants that.
Nobody wants. Then you can give a trial of PD5 inhibitors and ask them, but must educate them how to take this drug, when to take this drug, what are the side effects. You must tell each and everything about the PD5 inhibitors. And the role of nutraceuticals like L-arginine, citrulline, there is a very important role. And most important is counseling, because psychogenic cause you cannot rule out. If there is you have to ask him whether there is an early morning tumescence is there or not. If it is there, it is mostly a psychogenic cause of erectile dysfunction. If it is not there, give him a trial of PD5 inhibitors. Most of the time they work. Most of the time they work. Sometimes sildenafil is not working, then you have to switch over to tadalafil, because sometimes we generally ask the patient, will say, take 5 milligram tadalafil every day for a month, because it causes hypertrophy of the muscles, and once it is there, it will remain forever. So once that erectile dysfunction goes away and he is on, because 5 milligram daily means in the system it is 8 milligram every day, which is a good dose for the treatment of erectile dysfunction. So if patient is suffering from the severe erectile dysfunction, you can start 5 milligram tadalafil every day. If there is a mild, you can say SOS basis, you can have this sildenafil or tadalafil. But if there is an erectile dysfunction, it is almost 70 to 80% chance that he is going to have coronary artery disease. So start statins and all the measures you have to follow the guidelines.
Is it not related to neuropathy? Huh? Most of them have neuropathy
no,
also.
It's not at all.
Not at all.
Very, very, very. So, yes, sir. Yes, I would like to grasp something from you also.
We have sexual dysfunction in females also, equally the same after 45, I suppose that, because there is a chronic CVD is also in the females also. So I say that you have done the half the story, so please make it full.
Okay. Done, sir.
Dr. Bhamri.
Yes, sir.
I had a patient who was sexually active till one dark night. He found that he had developed ED. Won't do it. So what is the likely cause? Penile artery thrombosis or what?
Most of the time it is psychogenic.
Sudden onset of ED.
Sudden onset ED one night, one day before he was absolutely all right. It is most likely a psychogenic cause, nothing else. There is a performance anxiety and all, whatever it is. But in future also, if he is not able to perform, then you have to go for the Doppler and all. You have to check for any thrombus and all. But suddenly one night, you have to ignore it.
From that day onwards,
So then get his CT angiography of the genital vessels, that the genital, the pudendal arteries, penile vessels. Get your CT angiography of that patient, because if there is a block, we can open it with the help of balloon angioplasty.
So, Bhamri, one thing you
Yes,
just
sir.
mentioned, there are two aspects of male sexual dysfunction. One is erectile dysfunction, second is premature ejaculation.
Premature ejaculation.
And that is equally important part of the process. So we have just not.
So premature ejaculation is not related to coronary artery disease and cardiovascular. So I was, if I talk about the premature, that off the track ho jata thoda sa.
Because we were talking about sexual health.
Sexual dysfunction.
Yeah.
So there are few questions for the audience. The patient Shahrukh Khan, 55-year, who had previously undergone PTCA with ejection fraction of 35%. He is on antiplatelet drug, metoprolol 50 milligram, ramipril 2.5. Patient report to the clinic after 2 months with erectile dysfunction. What you will do to the audience? Change the metoprolol 50 to nebivolol, reduce the metoprolol dose, stop metoprolol, and reassure the patient without any change. What is the No, 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 not stop, because his ejection fraction is 35%. So the answer is A. So one of the boyfriend of Mrs. Sunny Leone diagnosed with HOCM and erectile dysfunction. All other treatment options except PD5 inhibitors, testosterone therapy, intraurethral medication, penile injection. Anybody? Hypertrophic obstructive cardiomyopathy. So it is PD5 inhibitors. So we all know that there is only one contraindication of PD5 inhibitors, that is nitrates. The HOCM is again a very important contraindication.
This can go for the whole day, but the time is over.
Okay, sir. Okay, fine. Last question.
We'll have a conference on this for whole day.
Okay, okay, okay. Done. Thank you. Thank you, sir. Thank you.
A very interesting talk. I think our chairpersons were very happy with the questions and this thing, deliberations. So next, I request our chairpersons to honor our speaker, Dr. Bambri, and I request Dr. Yogendra Gupta to honor our chairpersons. Next is a very interesting session. As we all know, eco is being done all over the places without having proper knowledge of eco. So, how can a perfect eco make difference in clinical practice? Dr. Rakesh Gupta, the owner of Giraffe Healthcare Center, we know is one of the best eco center in the country. So he'll be speaking about how can a perfect eco make difference in clinical practice, which is very, very correct. So Dr. Rakesh Gupta, please. And the chairpersons are Dr. Goel, I think is there, Dr. N.K. Goel. Yes, Dr. N.K. Goel. He's a director and HOD, unit head in cardiology at Fortis Hospital, Shalimar Bagh. Dr. Anish Sharma is there. Dr. Anish. Dr. Manish Mathur. Dr. Manish Mathur is senior consultant, Max Hospital, Shalimar Bagh. Before starting this, I request Dr. Praveen Bhatia sir, to honor Dr. Balwant Singh. Dr. Balwant Singh is IMA Rohini President. Dr. Balwant Singh, Dr. Bhatia, please. I request the chairpersons to start the proceedings.
Good afternoon, friends. First of all, I thank you to North Delhi Physician Forum for having this wonderful topic of usually not discussed, that is sexual dysfunction, and particularly pertained by a cardiologist, to explain all these things, because there is a lot of fears and a lot of points which need to be clarified. Now after that, let's come to again an interesting topic, because nowadays a lot of patients do come with a report, and when they have kind of a problem, they go for an ECG and echocardiography, and how to interpret an echocardiography and what are the parameters, how we go about. For that, we have an eminent echocardiographies like Dr. Rakesh Gupta, who doesn't need any kind of an introduction. Probably he is a pioneer in this North Delhi for different things, 3D echo, 2D echo, and lot more things. So I will not waste much time. I request Dr. Rakesh Gupta to please start the session.
Can I have the slides, please? Good morning, and thank you very much for allowing me to talk on this platform. And I'm sure well, this topic is not going to make much difference in everybody's life. But I can tell you, you can look for an erectile dysfunction by looking at endothelial dysfunction by flow-mediated dilatation. So people who are diabetic, hypertensive, aging population, a very simple technique, how our blood vessel reacts in clinical practice by ultrasound, we can do that and let you know what is endothelial dysfunction is. And once you have an endothelial dysfunction, that is a surrogate marker, the first marker for having subsequent atherosclerosis. Very simple, about a half an hour test, and that's no injection, nothing of that sort. Only thing you have to be fasting. And I always say Dr. Naveen Bhamri as a Jeho of cardiology. And that's what he has proved today. Let's move on to a couple of things in a clinical practice. What we do is, that's case number 1. This is a patient of hypertension on irregular medicine. BP appears to be uncontrolled, presented with a routine echo evaluation on demand by his physician. Patient was not interested. Pulse 80, when he presented, was BP was 200 by 100, right arm supine, no definite murmur, and no evidence of congestive cardiac failure. If you look at his investigation, lipid profile was a little disturbed. X-ray chest normal, and now the most important part is look at his ECG. All of us will understand, possibly lead 2, 3 AVF and V1 to V6, could be ischemia, could be something else also, but he is hypertensive. We went on to do echocardiography. Can have this light a little down, batti kam ho sakti hai to kam kar dijiye. We look at his echo, look absolutely good contracting LV, not significant of a mitral regurgitation, but there is significant of a left ventricular hypertrophy. As per 2016 guidelines, patient classifies into a concentric left ventricular hypertrophy. If we go further, we look at a systolic function. We look at a systolic function, and that's what a bread and butter of every echocardiologist, every physician, what he talks of only one thing, that is what is the ejection fraction. And I said, what is the erectile dysfunction and what is the ejection fraction? And if you happen to see the ejection fraction, look, it's very good, maybe more than 66% of ejection fraction, though this patient is okay. And let's look at the thing in a forward. We look at a diastolic function, which is a very important part of today practice. We look at a mild mitral regurgitation, variable pattern of a mitral Doppler spectral flow, then significant tricuspid regurgitation with a normal tricuspid flow pattern. Grade 2 diastolic dysfunction based on JACE 2016 guidelines. So if I look at the findings, patient has got a dilated LA, concentric hypertrophy, LV systolic function normal, grade 2 diastolic dysfunction, mild MR, normal pulmonary artery pressure. Is that the echo you are looking forward? Is what we can manage with this echo, or do we need more? Are we done with the echo? Hypertensive, 210 blood pressure, left ventricular hypertrophy, grade 2 diastolic dysfunction. Is that okay? Can you help in managing this patient? And that's what the most important part is. We want more out of this echo. What is that echo is? We want a dil mange more. And what's that dil mange more is? Complete evaluation of a systolic function by looking at the global longitudinal function. This GLS tells you what? This GLS tells you about subclinical LV dysfunction. As our heart becomes more and more stronger with left ventricular hypertrophy, over a period of time, its function starts reducing, which our eyes cannot pick it up. And that's what is being seen by this polar map. And this polar map classically says that the GLS is less than 20, and this is categorically seen in this particular picture. What does it mean by my heart is contracting well, but it's already going into dysfunction which we cannot analyze? Something like somebody has got into endothelial dysfunction, but he has not really gone to atherosclerosis, and that's the time to react. And this classical pattern of apical sparing, this classical pattern of apical squaring is very important. I'll come back to it. Now look at a diastolic function. We don't only look at diastolic function of the mitral flow pattern, we look at an LA volume index also. And based on this LA volume index, he belongs to grade 2 diastolic dysfunction with normal LA volume. Now, further, what are the complete findings now? Look, we change from dilated LA to index LA, which is dilated. Now, concentric LVH with apical squaring suggestive of amyloidosis by GLS. Reduced LV systolic function by GLS. And grade 2 diastolic dysfunction, which was by ASC 2019 guidelines, became at least grade 1 with normal LV penetration, mild MR and normal pulmonary artery pressure. If you look at the latest guidelines of 2021 published by Jack, where do we belong to? We belong to stage B heart failure. What is stage B? We have a structural heart disease, abnormal cardiac function. So this patient is not only hypertensive, he already gone to stage B heart failure, which is asymptomatic, likely to become symptomatic if we don't take care of it. And on top of that, his LV function is already down because of a reduced global longitudinal strain. Not only that, look at this pattern published in JACC in 2013-14, talking of the various pattern of LV function by global longitudinal strain. This is all the pattern, and majority of this pattern which is seen in our patient was apical squaring. This apical squaring is suggestive of amyloidosis. And if this patient has got an increased urea and creatine, along with the left ventricular hypertrophy, we should investigate for this patient for amyloidosis as well. Now the final outcome is concentric LVH, pattern suggestive of amyloidosis, normal LV systolic function, reduced GLS, at least grade 1 diastolic dysfunction with normal LAVI and stage B heart failure. And our therapy has to modify it very strictly for these subset of population. We are not only dealing with the LV hypertrophy, we are already dealing with much more than that in LV hypertrophy, a patient presenting with hypertension and uncontrolled systolic. This is a paper talking of importance of LVH. Look at the cumulative mortality incidence as our LVH keeps on going. Survival event, it keeps on going. So LV hypertrophy itself is, we have to look at many factors, and that's what it is important. Its importance is, look at the echo. How does the echo help in your clinical practice? How can you diagnose, prognosticate, and treat those subset of patients? One. Case number 2, elderly patient with hypertension or regular medicine referred for echo evaluation by a physician. When we heard both the murmurs, systolic and diastolic, BP appears to be controlled, presented with routine evaluation as asked by physician. Again, blood pressure is high, both murmur were seen, occasional crept, no evidence of a congestive cardiac failure, nothing significant but borderline deranged urea creatinine dyslipidemia. XHS, a very good evidence what atherosclerosis is happening in our body. We don't put emphasis on XHS. Look at an X-ray, its aortic calcification is present, but ECG is almost normal. Nothing significant in ECG. And look at an echo. Now look at this echo very category. Neither RV is dilated, nor LA is dilated, nor LV is dilated. No significant mitral regurgitation is present. LV contraction is very good. Ejection fraction is excellent. But when we look at an echo in 4 chamber, 2, 3 chamber, 2 chamber, and subcostal, very one subtle significant finding which is present over here. Look at the amount of calcium which is deposited in these valves, mitral, aortic, everywhere the lot of calcium which is seen in this. There are hyperechoic structure which are seen subsisting on these valves itself. What does it mean by it? We look at the flow velocity, mitral flow velocity is increased, is more than 1.3 meters per second. On top of that, his aortic flow velocity is increased. What does it mean by? It means by my valves have become thick, calcified, leading to atherosclerotic disease, which involves the valves leading to increased flow velocity. If I go further and look at this, answer would be normal LV systolic function, normal diastolic function. Then why diastolic and systolic murmur? The diastolic murmur is because of an increased flow across the mitral valve. The systolic murmur is increased flow across aortic valve. Can we manage this patient with echo? Is that all we need to do? No. Let's look at this echo again And if you look at this echo is, we have a flow velocity which are increased, and we went on to look at the LA volume index. LA volume index is almost 35 ml per meter square area, which means it's more. And this LA volume index is a surrogate marker for heart failure with preserved ejection fraction. Let's see what all we can do. Significant atherosclerotic calcification valve annulus, increased flow velocity across these valves. And look at this paper published in JACC Imaging 2015. We can see the prognostic value of echocardiography calcium score in patients with clinical indication for stress echocardiography. If we have a calcium increase or the mitral aortic ascending aorta papillary muscle, this ascending aortic calcium was seen for the first time in X-ray chest itself, which we always ignore, saying that it does not have any value. And if you look at the other side of the slide, the people who carry more of a calcium, their cumulative mortality and morbidity is significantly high. And here's the slide. E score 0, that is green, and the pink, the score is 1. This is a planned event-free survival curve. And this is the follow-up of a normal valve motion abnormality, abnormal valve motion only. If the thickened valve is present, put them on a stress. If the stress develop a valve motion abnormality, it means they are not only carrying atherosclerotic disease in the valve, they are also carrying atherosclerotic disease on the coronaries also. And if this coronaries is, look at the event-free survival is dramatically different. So it's not the thing. This electronic calcium scoring or echo calcium scoring helps you to diagnose the preventive aspect, whether this patient has got a significant coronary artery disease or not. And on top of that, the couple of papers appears and available in the literature is vitamin K2 availability in our country, which helps in reducing the calcium deposition on these valves. And most of the thing, when we prescribe calcium to these people is, we often prescribe with this calcium of calcium and calcitrol along with vitamin K2-7 soft gel capsules to reduce the stiffening of these valves as well as other structures. So the calcium, the final take-home message is calcium on the valves, papillary muscles, echo findings are more important, and today the echo calcium scoring can really tell you about a diagnosis, prognosis, and helps you in treating these subset of populations. So alone echo is not going to make a difference. You have to spend time in making an echocardiography. So that's what possibly the perfect echo is. And next, the last case, 62-year-old male, history of hypertension, diabetes on irregular medicine, occasionally smokes, occasionally takes alcohol. And this is what population of patients which present every day virtually in your practice. And this is 100 pulse, 150 by 100 millimeters of mercury blood pressure, and there's evidence of a congestive cardiac failure in this patient. Many of you sitting over here can say, look, he smokes. Possibly that's the coronary artery, this bronchitis which are present. Borderline deranged, urea creatinine, dyslipidemia, borderline elevated SGPT, thyroid profile is normal, hemoglobin is normal, partially hyperinflated lungs, bony cage is normal, ECG is more or less the same, and now spend time on echocardiography. Very simple, flash window showing a good LV systolic function. Colors almost showing the same thing, nothing significant. Not significant amount of mitral regurg. We go on to see an apical window, which is the most important thing. We look at a very good LV contraction. Normal, both in 4-chamber as well as 2-chamber view. And if I go further, look at the 3-chamber view. Look at the things which showed previous. There's some amount of calcium specks, not the one which I showed in previous cases. Most important thing is mild or insignificant trace mitral regurgitation. Then this is the most important thing is what we often see a report of diastolic dysfunction present. Mild diastolic dysfunction is present. Grade 1 diastolic dysfunction is present. What does this mean by mild, grade, and this thing is? We have to say whether it's there or not there. If it's there, what category of a diastolic dysfunction is present? And what does this diastolic dysfunction in fact reflects to? It reflects to LV filling pressure. Higher the filling pressure is, more the chances of having breathlessness. Look at this patient. He has got EA wave, here E prime septal, E prime lateral, and the TRZ. TRZ is almost more than 3 meters per second. Patient is in congestive cardiac failure. Now the most important part comes to left ventricular, left atrial volume index. Index is 37 cc per meter body surface area, and which is pretty high as we subject in this patient. So my findings is normal LV systolic function, grade 2 diastolic dysfunction, raised LA volume. Are we done? Do we need more? Do we have to do something different in this patient? Yes, that's what important thing is. We move further, go ahead. Look at this LA stain. This is one new modality which is available in the armamentarium today. What this modality tells you, what is my furling pressure as on today in this subset of patients. And these patients, they often present to you despite normal LV systolic function with breathlessness. And many people, they label after getting a CT scan, pulmonary angiogram, coronary angiogram, lung function tested, mild coronary artery disease. What is mild coronary artery disease? Is there or not there? And this exactly tells you, look, the patient was in grade 2 diastolic dysfunction, raised LA volume. It means his LV filling pressure is almost 15 to 20 millimeters of mercury, which are further confirmed by looking at the LA stain. This is the reservoir stain is only plus 29, when the normal value is almost 38 to 39. And this is what the comparison of this patient. Normal 39, patient has got 29. Then comes 29, over here the conduit stain and the contraction stain which is contributed by A wave. Look at the normal volume is 34 and patient volume is almost 65 ml per body. And look at the GLS, the same GLS which was abnormal earlier, this GLS absolutely normal, almost 63% ejection fraction and a GLS of 21, more than 20% of a GLS. RV GLS, again normal, it means RV systolic function, even the subclinical LV RV systolic function is normal. So what exactly we are looking forward? We are looking for normal LV function, normal RV function by 2-dimensional echo and by global longitudinal stain. So what exactly the problem is? Patient is in heart failure with preserved ejection fraction. That's what it implies. And this is one of the most important things in diabetic hypertensive subjects today, apart from sleep apnea syndrome, obesity, hypothyroidism, and aging population. And these people, they present with what? They present only with a features of dyspnea on resting pace or on exertion. And the LA volume index or the two-dimension LA stain becomes very, very important. Many of you can say, by LA pressure बढ़ गए तो क्या हुआ? How does it make a difference in our life? What do we do about it? Look at this paper published in JAC 2013. Very simple paper published about 10 years down the line to determine the prognostic importance of left atrial volume index or dilatation in type 2 diabetes with no history of a cardiovascular disease. Diabetes, hypertension, no history of cardiovascular disease. DM is associated with development of a cardiovascular disease and morphological changes in heart may appear before the symptom rise. And if you look at the conclusion of this study says, increased LA volume index is an independent and incremental predictor of cardiovascular mortality and morbidity in type 2 diabetes with no history of a cardiovascular disease. Simple one investigation is telling you, look, this is what which is more important than anything else. Let's move further. Paper of 2021 published in JAC Cardiology Imaging. What it says? It says the pathophysiology of diabetic cardiomyopathy with proposed role of metformin. I'm not going to talk of metformin. Look, what exactly the myocardial dysfunction comes leading to diabetic cardiomyopathy. Enlarged LA, very simple parameter. Impaired myocardial relaxation, that's filling pressure, elevated filling pressure, and the impaired GLS. So these 4 modalities, out of these 4 modalities, even one of them is positive, then patient is heading towards what? Diabetic cardiomyopathy. It could be us, it could be patient also, it could be our family member also. So in just to say that, we were dealing with not with anything else systolic dysfunction, we were dealing with diastolic dysfunction. If you happen to go to a literature today, believe my words, 50% of patients presenting with heart failure, Dr. Goel is a leading heart failure specialist. Sitting right over here, you can ask him 50% of the patients who present to a patient as in hospital with heart failure they have a normal LV systolic function. And the management of these heart failure with preserved ejection patient is more difficult than reduced ejection fraction. And that's what diabetic cardiomyopathy, the patient is in stage 3 heart failure again with diabetes. Little bit of a treatment point of view. When we make a diagnosis, we have to treat them. Use diuretics judicially. Beta blocker only when specific indications are present. You cannot use beta blocker to a large extent. SGLT2 inhibitors deliver both emperor preserved trial, class 1 indication. MRAs, TopCat trial showed both effects depending on certain important issue. Given to class 2B indication. ARNI Paragon HF trial shows class 2A indication in ARBs where ARNI is not tolerable. So echo does make a difference. And look at this heart failure preserved ejection fraction, just published a couple of weeks back in 2023 JACC Imaging Journal. What does it say? Look, you treat this patient with the loop diuretics, MRAs, ARNI and ARBs. And it all depends in what stages of various definition of systolic function as well as the diastolic dysfunction is present. In turn to say that, we have to look at certain important factors. Don't look at an ejection fraction. Look at an echo which is a complete echo, which helps you in making a diagnosis, which helps you in making a treatment, which helps you in prognosticating your patient. And anybody, if a echo walks in, the simple language is normal LV systolic function and grade 1 diastolic dysfunction. All of us carries that. That's not an abnormality, and it's absolutely normal echo is. So echo is just a perfect echo, and I'll stop by showing this last slide is, this is not a perfect echo. Look at the echo till the end and look at this picture till the end, what is the true echo is. And that's what the perfect echo is. Don't look at the glamour of echo, look at the complete imaging. Thank you very much for your patience.
Thanks for the wonderful talk, Dr. Rakesh Gupta, and thanks for elucidating on some of the finer points that we should be looking at while reading the echocardiography report. And I think looking forward to questions from you.
I think if there is no question, probably I'll just ask one thing that, and what Dr. Gupta has said, there is a heart failure with preserved ejection fraction. What we were talking about, there is a lot more patients come with the heart failure and with the dyspnea basically, and we see the echo and just as briefly or that as a superior or just a superficial glancely we say, okay, its heart function is normal, LV systolic function is normal, or ejection fraction is normal. But normal ejection fraction doesn't mean heart function is normal, and that's what you have perfectly illustrated about that, how to take care of the patient whose ejection fraction is normal and still the heart can be the cause. What we do in mostly in the patient, if the ejection fraction is normal, we may go for a stress echocardiography and do an angiography. If it's normal, okay, heart theek hai. But no, it's not normal. This is the subset and most difficult subset, which is diagnosed as a HFpEF or a heart failure with preserved ejection fraction. And for that probably we need much more clarity about the GLS and LS strength, and probably the very good blood marker which is also available like an NT-proBNP is helpful in diagnosing these patients. That is a HFpEF, and we can use, and what Dr. Gupta has already told about the treatment, that SGLT2 is that wonderful molecule which has been now can be used at across all the process of the HFpEF where you can use it. And these diastolic function is really important to measure in most of the patient, particularly if you have a mid-range EF, because you don't know how to go about. And the most important point what you told in the management is the diuretic to be used judiciously. We are using the diuretic like randomly, okay, start with the diuretic, but once patient is euvolemic, I think we should hold the diuretic, otherwise there is a lot of problem in the dyselectrolytemia, cramps and the renal dysfunction can occur. So I would like to ask one question, like you asked about the calcification of the valves is this thing. So how to diagnose this calcification and how it can be correlate, or how in what kind of a patients we should do and look for it?
basically calcium from the scoring is like there's a chart with which can really calcification scoring, echo calcification is positive now. Like based on the thickness and calcification, we measure the size, and then we say this is the scoring of this echo calcification. And if you happen to see a calcification of wall, subject those patients for a stress echocardiography. Because calcium scoring, what is seen on top is the same calcium must be there inside the coronaries also. So the management issue changes. If somebody is carrying a significant coronary artery disease and his calcium is seen on an X-ray chest or echocardiography, there are people who have a substantial amount of a coronary artery disease associated.
So probably that is the point where we should start the lifestyle modification to prevent the further coronary
This is
artery
what
disease.
exactly I was looking at the papers. Vitamin K27 is the one molecule which helps in reducing the calcium. Like it was a new thing for me only.
So thank you, Dr. Rakesh Gupta.
And before I say only one thing, I happened to meet recently the global CEO of GE came to our center, and you know, he expressed how the echoes are done in India. The global CEO of General Electrical, which makes the best echo machine in the world. Mark Anderson was in our center for some discussions, and he said how the echoes are done in India. He said, Dr. Gupta, that is the echo done in India. Postal SEP department. Patient लेटा, echo हुआ, probe लगी, बाहर निकला. And that's what his observation was when he went to GB Pant Hospital. That's how he explained how the echoes are done. Thank you very much for your patience.
Thank you, Dr. Gupta. Such a wonderful interactive session with the chairperson, Dr. Dinesh Goyal. Dr. Goyal, please honor our speaker, Dr. Rakesh Gupta. And I request Dr. Mangla to honor our chairpersons. Now, next session is very interesting, ECG workshop, not by a popular cardiologist other than Dr. Aparna Jaswal. She is a director of cardiology, Department of Cardiac Patient Electrophysiology, Fortis Scott Okhla. She has been very regular with our conferences and she is one of the star speaker. And the chairperson is Dr. Samir Mehrotra. Dr. Samir Mehrotra, please. He is also electrophysiologist and a very renowned cardiologist. I think he is in Artemis now. He is in Artemis Hospital, Gurgaon. Dr. S.K. Arora, our pillar in the North Delhi Physician Forum. He is a senior consultant physician in Max Hospital, Shalimar Bagh, as well as his own Aurora nursing home. Dr. Yogendra Gupta. Dr. Gupta is senior consultant physician in Paschim Bihar, I think in New Saigal Hospital. And fourth is Dr. V.K. Bindal, sir. Sir. Dr. V.K. Bindal, he is a very renowned physician in North Delhi and very popular person. Now request the chairperson to start the proceedings.
You are the senior person. You are the senior person. You are the senior person. Boss के सामने मैं नहीं कर सकता.
Good afternoon to all of you. With the permission of chairpersons, shall I start?
Good afternoon, everybody. And I think this is going to be one of the most interesting sessions of today. Dr. Aparna is a renowned electrophysiologist, and she will be showing us various interesting ECGs. And I think the house will be involved in answering the questions. So, Dr. Aparna, over to you, ma'am.
Thank you so much. Thank you so much, Dr. Samir. And it's nice to see Dr. Samir and sir and be here. I have been associated with this forum for a long time, thanks to very dear friends like Dr. Chabra, Dr. Jha, and Dr. Sood. So I think without coming in between you and the lunch, I think I must quickly be swift in the time that I have been allotted. And I'm happy to keep it interactive. Please stop me whenever you wish to. And without much ado, I think I must start. So I think I can't start any session without actually discussing this animation, which makes the basis of an EKG. We have to understand that ECG is nothing but an electrical representation of all the myocardial cells within the heart. Every ECG is a compilation of the electrical circuit which actually begins from, can I have a pointer please if possible, which begins from the SA node. The SA node has a unique property of automaticity. Our normal impulse should be between 60 to 100 beats a minute. So what we see is that the electrical impulse emanates from the sinus node. It first goes via a special tract called the Bachmann's bundle, which is present on the roof of the right atrium, the left atrium. It's not working, I think. It goes from the roof of the right atrium, the left atrium. Alongside, it enters a very specialized electrical conduction system, the AV node. From the AV node, the electrical impulse enters the bundle of His, and subsequently it enters the right and the left bundle. You can see that the left bundle, as soon as it comes out, it bifurcates into a left anterior fascicle and a left posterior fascicle. You can also see there is a right bundle. I will be showing you in the ECGs as we come along, but it's a good idea that we understand now. All of you as physicians would see several ECGs with a right bundle branch and a left anterior fascicular block. RBBB with LAFB. But you don't often see RBBB with a left posterior fascicular block. So why does that happen? If you understand the electrical circuit, it is so interesting. So this left anterior fascicle is a very thin fascicle. The left anterior fascicle receives single blood supply. The left anterior fascicle, as Dr. Gupta also showed in his echo pictures, if you notice, is very close to the aortic valve. So the calcifications from the aortic valve enter the left anterior fascicle. So to keep it simple, the left anterior fascicle is very easily injured. Hence you see a right bundle with a left anterior fascicular block. We are all well aware about the EKG. It's very simplistic to remember that you have to look at two leads ideally to know what is the axis and to know where is the electrical axis emanating from. Remember, a normal sinus P wave going down to the normal electrical axis will have a positive axis in lead 1 because the activation is from the right to the left, and in the leads 2, 3 and AVF it will be all positive because the circuit is going downward. I've already told you how an ECG is done. The electrodes, the ECG electrodes are very far away from the heart, right? The right arm, left arm, that's what you get in ECG. They're very far away from the heart, but they encompass, they see the entire heart. So they make a collective action and tell you what is happening in the myocardium, and that's what we're trying to tell you. The electrodes are far away and ECG is a compilation of that. With that, I think I will move to a few cases with ECG. The history is actually telling you what's wrong. This is an elderly lady. She's on ACE inhibitor. I think we've largely moved away today from ACE inhibitors, but yes, she was on Ramipril 5 mg/BD. She sustains fracture neck of femur. She's oliguric, and this is the ECG that you see. We are happy to have some answers. So this is the ECG that you see in the ICU. This is an ECG which should not be missed. The reason being, this is a completely corrective ECG, and if you do not act on time, the patient can potentially die. So this is a patient you think on an ECG has hypokalemia. It's a wide complex rhythm. Is it a ventricular tachycardia? Is it a hyperkalemia? Is it a ventricular flutter? Because it is a wide complex rhythm which is happening there. So this is, look at the history now. The patient is elderly. She is on AC inhibitors. She is oliguric, and this is the ECG, and it is self-explanatory that this you're dealing is with hyperkalemia. The reason I started with this is hyperkalemia is a very often finding because more and more is the penetration of the usage of AC inhibitors, ARBs and ARNIs today. We are using it so much. We are bound to find more and more of hyperkalemia in the elderly in the ICU room. You should know that what are the ECG changes. Remember, potassium is an ion which is largely intracellular. So what is the potassium that we normally see? A normal potassium is 3.5 to 5 millimole per liter. Sodium is largely intravascular, less cellular. So largely the way should the potassium be? Within the cell. And the range is very small, 3.5 to 5 millimoles per liter. You should remember the first telltale sign of hyperkalemia, we are well aware, is tall tented T wave as soon as it begins to increase beyond 5.5 millimoles per liter. Subsequent to a tall tented T wave, the next change you see is the P wave becomes shallow, the PR interval increases. Subsequently, you see that the QRS changes and the QRS becomes a sine wave pattern. In the ECG that I showed you of that elderly lady, it was like a sine wave pattern. You need to act aggressively and correct the hyperkalemia. It's important we understand this. This next video is something which is very important to see. It's a medical professional addressing medical professionals like all of us. She was a professor of radiology, and this is of last week from Chennai, and she was in the dais welcoming young medical students. So just like me, she was in the dais beginning her lecture, and you will see what happens to her bang on the dais. And that's no more of her. So what she had was a syncope which culminated into sudden cardiac death. Her ECG was taken. What did her ECG tell us? So there are no points for guessing here. When you see an ECG with tachycardia, meaning rate more than 100 beats per minute, and if it is wide, means more than 120 milliseconds, it is a wide complex tachycardia. When you see a wide complex tachycardia, shut your eyes, shut your mind, and say this is a ventricular tachycardia. There is a 80% chance that you will be correct. Here is a patient who had undergone a bypass surgery. She had LV dysfunction. She's had a syncope. Her ECG is showing this rhythm, and this is called ventricular tachycardia. So again, tachycardia, wide complex, just call it a VT and treat like a VT. But there would be a lot of interest. Why is it that VT occurs? So this is an animation from none other than William Stevenson, who is the father of electrophysiology. So what you see here, the red color, is the healthy myocardium. Between the healthy myocardium, certainly you're seeing ugly things, that white colored, that is the fibrosis that you're seeing in between. I don't know if this thing stops working intermittently. So this white structure is the fibrosis or a scar. Why did that happen? This happened because somebody had a previous myocardial infarction and the person knew he has MI. It can happen a silent MI, he never knew he had an MI. It can also be smaller mid-myocardial scars because of dilated cardiomyopathy. It can be because of post-COVID. But remember, a scar means trouble. Why? Because whenever there is a scar, you will see what happens. It sets a perfect electrophysiological milieu for bringing out abnormal rhythms like ventricular tachycardia, and which can be fatal. So that's why we as cardiologists always say, if a patient has LV dysfunction, why do we worry? We worry because why is there LV dysfunction? The muscle has gone away, it has been replaced by scar. If there is a scar, as you can see here, that scar forms a perfect place for arrhythmias to arise. So sudden cardiac arrest, sudden cardiac death is going to be far more higher in patients who have left ventricular dysfunction, primarily because of this scar. While I'm saying we should distinguish between sudden cardiac arrest and sudden cardiac death. Remember, when a person has a ventricular tachycardia, he falls on the ground. For a momentary time, it is sudden cardiac arrest. If you and I or a fellow standing by intervenes, gives a thumb, gives CPR, we can make it aborted sudden cardiac arrest and the person can live. But if we do not act, that results in irreversible stoppage of all biological functions, and that is sudden cardiac death. This month is extremely important, and the last week of this month is actually a sudden cardiac arrest awareness week, where we are doing a lot of CPR campaigns just to create awareness about this. So moving on from there, what will you do, which was not done for that lady when you see something like this? For the younger people who work in the ICUs, remember, whenever you have a ventricular tachycardia, which you just saw when this circuit is there, and you have the access to a defibrillator, which every ICU has today, you are supposed to cardiovert the patient. The cardioversion, you are seeing this patient is having a VT, and I will cardiovert, I will show you, I select energy. I press the synchronize button on, I charge the defibrillator, and I press shock, and I deliver energy, and you will see the patient will come back into normal sinus rhythm. You have to understand, there is very little time for you to act. So you should know what are you to do at that point in time when you see this rhythm. Remember, we always cardiovert the patient, means we always synchronize the delivery of the energy to the peak of the R wave. But if your patient has ventricular fibrillation, you just give maximum energy and give the energy without synchronizing the energy to the patient. And of course, in the long term, you need to consider the implantation of defibrillators. I don't want to spend time here being an ECG workshop. This is the next case. This is a 72-year-old gentleman. Coronary risk factors, has undergone myocardial revascularization. The ejection fraction is preserved. There is no evidence of any reversible myocardial ischemia. The ECG shows something which I'll just show you. The patient has had syncope. So this is the ECG. I told you, what is the ECG most common you will see in a bifascicular block? A right bundle branch block, wherein you see an RSR dash pattern in V1 and a left anterior fascicular block. Look at lead 1, it is largely positive. Look at lead 3, it is largely negative. So you will get left axis deviation. Remember, RBBB and LAFB are very common. RBBB with LPFB is very uncommon. Why? Because they often present to you already as complete heart blocks. So whenever you see RBBB and LAFB, and I told you why LAFB is common, because the left anterior fascicle is thin, single blood supply, calcium enters, it gets spoiled. So this is a patient who's 72, who's not old, has had syncope with a bifascicular block. He was told to go in for a pacemaker, but he refused, and he's put on an external loop recorder. And while on an external loop recorder, this is in fact one of my dear friend Amardeep's patient, while on the external loop recorder, his recording is coming to us throughout because he's on a live external loop recorder. You will see what happens to him while he's taking a walk on his own terrace. He feels dizzy and he falls down. So this has been captured by the CCTV camera. His son immediately calls us that something happened. So we open up his external loop recorder immediately. Clearly we see at that point in time he has gone into a complete heart block. You can see there are only P waves, there are far and few R waves. Okay, you can clearly see that there are all P waves, far and few R waves. So this patient deserved the implantation of a dual chamber pacemaker because he had a bifascicular block, he had syncope, so he has been given a dual chamber pacemaker. Now this is something, the next ECG, which has been actually captured in our OPD room. This patient comes who's elderly, he's about 85 years of age. He says that since he was 30 years of age, for the past 50 years, he's been having these tachycardias, but it has never been recorded on an ECG, but he knows how to treat them. And he says, he comes and sits on the OPD and he says, I'm having it right now. Now, I have two choices. One choice, I'm sitting in my clinic and we check pacemakers there. So we have a pacemaker clinic. One choice is I say, okay, go down to the basement, take the lift, get an ECG done and come back to me. I thought to myself, for 50 years it's not been captured. I don't want to waste a moment. I want to capture it right now. So I immediately put him on the pacemaker monitor because the pacemaker monitor can pick up the ECG and show me. So this is a pacemaker monitor. You can see the ECG has been picked up. And the patient says, he's 80 plus, he says, I know how to make my rhythm all right. Okay, don't worry doctor, I know how to make it all right. So this is what has happened. We saw his permission to do this. So this is what you see. So this is his rhythm going on. He's having, so the first thing we all understand, this is heart rate, the speed is like an ECG paper. So the heart rate is more than 100 beats per minute, all of us agree. It is narrow complex because it is less than 120 milliseconds. This is a tachycardia which is going on, which is regular, and we've connected him to this monitor, and here he is. He says, I can terminate it. Hang on, don't worry, I'll do it myself. He terminates it, look, and his tachycardia terminates. So what did he do? He gave himself carotid sinus massage. He knew I have PSVT. He's grown old for 50 years. He's been living with that. So I said, okay, let's do an answer. Let's do your ablation and let's get you rid of it. He says, doctor, I'm 80 now. For 50 years I've been treating it myself. Why do you want to do it now? I said, okay, fair enough. Go home, eat your medications, provided you don't have any coronary artery disease. Because if you have coronary artery disease, the problem is, if you have CAD and your heart rate spikes up from 60 to 180, it can cause myocardial ischemia at that age. So we just tell him, do two things. We just look, you should not have any carotid stenosis because you know how to do your carotid sinus massage. You can have emboli going and do a stress echo. If you're fine, live your life. And he's actually not gotten it done. This is about at least 2-3 years old video and he's doing fine. Another reason that he didn't want, he's actually also a post-aortic valve replacement in the past. So this is an interesting case. Remember, anybody who comes to you and tells you that I can terminate my rhythm by carotid sinus massage or I can terminate by coughing means it is a node-dependent tachycardia. It's a very simple answer. And node-dependent tachycardias are only two, AV nodal or AV reentrant, means PS, common garden variety of PSVT. If time permits, we will reach there, otherwise we will not. So this is a young girl, 14-year-old. History of pre-syncope and syncope. Her echo is normal, absolutely normal. And this is what you see on the ECG. Please spend a moment. Whenever you want to discern the rhythm, the ECG you need to see is long lead 2. So focus on long lead 2. It's very interesting. So whenever you focus and you're trying to identify what is the problem, look at the RR. That's the first thing you will see. RR. The RR regular. You will see the RR are dot regular. You agree with me? The RRs are dot regular. Then you try to focus. What is happening to the P wave? Is the P wave along with it or the P wave is not with it? So look, there is a P here, PR, there is a PR, there is a PR, there is a PR, something came out here, a P peeping out, there is a PR, a P peeping out, P peeping out. Now look, the PR is reducing. It never reduces. What happens in the Wenckebach AV block? The PR interval increases. Here the PR interval is reducing. The P and the R are not related to each other at all. This is what we call complete heart block.
So one thing I would like to, that black dot, if you can see on the T wave.
Absolutely.
Focus on the T wave. The
Yeah.
T wave in the first 2 beats is very pointed. When you go gradually from the left to the right, you see that the T wave, the third beat shows a normal T wave. That is a rounded T wave. So the first 2 waves where you see a pointed P wave, they are having a P on T.
Absolutely. So he's
Always
very right.
look at the T wave whenever you are seeing such
So
a ECG.
what he is trying to say is very, very important. So whenever you look at the QRS, a QRS I showed you in the first photograph of activation forces. What is QRS? It's ventricular depolarization. It is ventricular systole. It does not change with every beat, right? The QRS remains the same with every beat. Similarly, the T wave is ventricular relaxation, repolarization. It also must not change. So he's saying, look with more astute observation to what's happening to the T wave. The T wave here is distinct from the T wave here, implying there is a P wave sitting on the T wave. So this child has a congenital complete heart block and she is a symptomatic congenital complete heart block. The red dots are the R waves, the black dots are the P waves, the P are so many more than the R, they are no relationship. So this is a complete heart block, and the complete heart block, the answer is again a dual chamber pacemaker. Those of you who practice pediatrics, we can discuss later when to give a pacemaker in these children, but remember it is symptoms. And this will be my last case because I'm going to spend time on this particular part, which is very interesting, and I think we've all been talking about this. So this is a young lady. So the first question is the ECG abnormal? Do you find anything abnormal on this ECG? Look at the first 2 waves, the next 2 beats, the next beat, the next beat, and the next beat, and the last beat. So do all of us agree that there is something abnormal on this ECG? It's not not a normal ECG. Look carefully again. There is something happening there. So the questions are, it can be pre-excitation, yes, because the PR is short and there is the presence of a delta wave, but it is not there in every beat. It could be intermittent pre-excitation, yes, or it could be fortuitously timed PVC. What is the meaning of fortuitously? Just looking like at the right time PVC, or is it normal sinus rhythm with an aberrant conduction like a right bundle branch, which is not, because the morphology is not like a right bundle branch block in B1. So this is a beat which, so look here, this animation you've already seen. This is the normal sinus rhythm. This normal sinus rhythm, I told you there should be only one electrical gateway from the upper chamber to the lower chambers. But in this, you are seeing there are two gateways from above to down. So there should only be one gateway from the atrium to the ventricle in a normal human individual. Whenever there is an additional gateway, it is called accessory pathway. It results in an ECG finding of pre-excitation. It is not WPW syndrome. Wolf, Parkinson, White, three doctors who came together, the Dr. Wolf, Dr. White, Dr. Parkinson came together and identified and named the syndrome. It is not WPW syndrome unless the patient complains of tachycardia. If the patient complains of tachycardia, it becomes a syndrome. Otherwise, it's only pre-excitation. So clearly, this patient has pre-excitation. This is the animation telling you how a normal conduction system must go from above to below. I think we have learned by now there should be only one electrical gateway which will result in a normal beat. However, when there is an additional pathway, this is what it causes. It bypasses the AV node, it pre-excites the ventricle, diminishes or shortens the PR interval, excites the ventricle via a non-specialized conduction system, resulting in the formation of a delta wave, and this is what is called a pre-excitation ECG, which is because of the presence of accessory pathway. If this young lady is asymptomatic, it's a chance finding, she had to go for hernia surgery, she comes to you with this ECG, what will you worry for her? She says, I've never had any problem, doctor. Why are you worried? Will you worry for her on this ECG? The answer, the clear answer is no. You don't need to worry for this ECG. Why should you not worry? You should not worry because her accessory pathway is a very sleepy pathway at a rate of 60 beats per minute. Her rate is approximately 60-65 beats per minute. Sometimes the accessory pathway conducts and sometimes the accessory pathway does not conduct. That means it's a very weak performing accessory pathway. A weak performing accessory pathway, you don't need to worry. But if this patient had an accessory pathway all along, there were two tests you should have done. One, a TMT to see the conduction through the accessory pathway, and a Holter to see how is she doing. But in this particular patient, you don't need to worry because of this accessory pathway unless you send her home and the next day you say don't worry, and the next day she comes with this ECG. So do we all agree it's a tachycardia? Rate is more than 100. Do we all agree it is narrow complex? It is less than 120 milliseconds. Do we all agree it is regular? There is no aberrance, there is no RR variability. So this is a narrow complex tachycardia in a patient whom you saw who had an accessory pathway. So you know what you're dealing with is actually an AVRT. I don't want to go into the intricacies of this, but remember this is AVRT, and the answer to AVRT treatment is radiofrequency ablation. So only point, the time is running out. All I want to say is why do we have accessory pathway, and I'll conclude there. Embryologically, when we were growing in our mother's fetuses, we were a cardiac tube. This cardiac tube changes its axis and moves between the atrium and the ventricle. When it does so, between the atrium and the ventricle, there is only supposed to be a fibrous ring. The conduction system is inside the AV node. It's a fibrous ring. So there should not be any myocardium between the atrium and the ventricle. when they are turning around. However, embryologically, some myocardial tissue may remain connecting the atrium to the ventricle, and that's the causative factor for the presence of accessory pathways. I think with that, I'd like to conclude. Thank you very much for your patient listening.
Thank you, ma'am. That was quite an informative lecture and quite crisp. So, for the purpose of the house, there are few things from the point of physicians which I would like to stress. You mentioned about right bundle branch block and left anterior hemiblock, plus right bundle branch block and left posterior hemiblock. So sometimes we see that patients come to you with prolonged PR interval, RBBB, LAHB. So for at times they are being labeled as trifascicular block, but in reality that's not a trifascicular block. RBBB, LAHB with prolonged PR interval is not an indication for a pacemaker. That is something which is very important. For a RBBB, LAHB to call as trifascicular block, we have to do an electrophysiology study and we have to check the interval from his to ventricle. It is only when that is extended then we call it a trifascicular block. So on the basis of ECG, it's not the right thing that RBBB, LAHB, prolonged PR should be given a pacemaker by labeling it as a trifascicular block. So that was the first thing. And the second thing, in the first or second slide, ma'am had very beautifully shown about the components of the PR interval. So PR interval constitutes 2 or 3 components: activation of the atrium, atrium to his, and his to ventricle. The time from his to ventricle is a very small component of the PR interval. So many times you see 2:1 AV block on the ECGs with a narrow QRS complex. In that cases, if you are finding a prolonged PR interval, the probability is very high that the patient might be having AV nodal conduction issues. You give that patient atropine, sometimes that conduction will become 1:1 AV conduction. While if you are getting a 2:1 AV block with a normal PR interval and with a bundle branch block morphology, that is more likely to be infrahesian and that will require a pacemaker. It's very important to discriminate between the two. A simple way to do that is either you do a CSM, carotid sinus massage, or you can give atropine to your patient, or you can make the patient run fast. So if you see that with increased sympathetic activity the conduction improves, that means it was just at the level of AV node, it doesn't require a pacemaker. And regarding the third thing, the slide in which ma'am showed, that was a bifascicular block, patient had ELR and patient had a syncope. One option could have been, ma'am, that we could have taken that patient, had the patient agreed. I believe the patient didn't agree. We had the patient agreed, we would have taken the patient for a EP study. That would have immediately demonstrated that the conduction system is diseased, and that would have been more objective evidence of giving the patient a pacemaker, rather than waiting that the patient develops a fall, because sometimes it's not the rhythm which causes more problems, it's the fall-induced head injury or fracture neck of femur, especially in the elderly. That is more debilitating in such cases. So with that, I think otherwise it was a perfect talk.
Thank you very much. We come across LDH quite often in our ECG. Is it alone any significance?
Yeah,
And
so
second
whenever
is that, WPW syndrome, there is a tachycardia. We can't use beta blockers here because it will worsen the things. So, what are your opinions about
I think I'll answer them quickly. So the LAFB is a common occurrence and more often associated with hypertension. It is sine qua non with certain amount of loss of the left anterior fascicle. So it should not be just overlooked. One needs to see why is it there. And to answer your second question, when somebody has WPW, the choice of therapy in those patients is actually catheter ablation. That's first choice. If the patient is unwilling for catheter ablation and the patient has no structural heart disease, then the choice becomes class 1C drugs, that is flecainide or propafenone. You may want to combine them with a beta blocker. The only combination possible is flecainide with the beta blocker, but what is most contraindicated is giving calcium channel blockers to take orally. So please, if anybody of your patient has an accessory pathway, has WPW, do not give them Dilzem or Verapamil.
And as usual, Dr. Aparna has done a wonderful job with the ECG workshop. So I request the chairpersons, Dr. Sameer, to honor Dr. Aparna. And I request Dr. Naresh Chawla to honor the chairpersons. Dr. Naresh Chawla is Vice President, Delhi Medical Council, and past President of before lunch there is some prize for the poster presentation will be given after the lunch. And in the meantime, sir, please. Hello. Sir, please. Sir, please the podium. Hello, Dr. Malhotra, sir. Dr. Malhotra, sir. Sir, Dr. Malhotra, sir, please. Please clear the podium, sir, for the award ceremony. We have some eminent personalities. We are going to be honored. One is Dr. Naresh Chawla, he is Vice President DMC. Dr. Subhas Giri, he is the Director, LHMC Hospital. Dr. Meenakshi, she is CDMO. And Dr. Ram Avtar, he is the Director of ESI, Vasai Dharapur. I request Dr. Chawla, Dr. Meglani and Dr. A.K. Malhotra to honor all these dignitaries. Dr. Naresh Chawla. Dr. Chawla, please honor direct Naresh Chawla, Dr. Ramaptar. Stop किया भाई क्या? Off it. Dr. Subhas Giri. Dr. Subhas Giri. Dr. Ramavtar, अब इधर ही हैं. Dr. Meenakshi. After this, going for the lunch, we will be back by 2:45. Half an hour lunch, 2:45 start post-lunch session. Thank you.
किसी को बताया नहीं
जी।
लगभग 50,000 लोग हृदय की बीमारियों से दम तोड़ देते हैं। देश में हर साल लगभग 1.5 लाख लोगों को किडनी ट्रांसप्लांट की जरूरत पड़ती है, लेकिन 5,000 लोगों को ही किडनी मिल पाती है। लगभग 10 लाख लोग कार्डिया की वजह से नेत्रहीन हो जाते हैं और वो दूसरों के द्वारा नेत्रदान के इंतजार में इसलिए रहते हैं ताकि इस दुनिया को देख पाएं।
बहन डॉक्टर ईशा वर्मा दिल्ली विश्वविद्यालय के ही किडनी कॉलेज में पढ़ाती है। वो सिंगल पेरेंट है और उसका एक ही बेटा है जो अभी 24 साल का दिसंबर 2014 में हुआ। जनवरी 2015 में हमें पता चला कि उसकी दोनों किडनी फेल हो गई हैं और हमको उसको ट्रांसप्लांट कराना पड़ेगा। हमने रजिस्टर कराया कैडेवर डोनर के लिए और हम तब से इंतज़ार में हैं कि हमको कोई कैडेवर डोनर मिले, क्योंकि इमोशनली, फिजिकली एंड फाइनेंशियली इट इज़ रियली वेरी ट्रॉमेटिक फॉर द फैमिली, होल फैमिली। कि बच्चे को ऐसे देखना कि वो दिन पे दिन इतना उसकी हेल्थ ख़राब होती जा रही है, और हम सुबह भी और रात को रोज़ ये प्रे करते हैं कि हमको कैडेवर डोनर।
मृत्यु के पश्चात अपने शरीर के ऐसे अंगों का दान जो किसी अन्य व्यक्ति के शरीर में प्रत्यारोपित किए जा सके, ये अंगदान कहलाता है। आज विज्ञान ने इतनी उन्नति कर ली है कि हृदय, लिवर, गुर्दे, पैनक्रियास, आंखें, फेफड़े, हड्डियां आदि अंग किसी अन्य व्यक्ति में प्रत्यारोपित किए जा सकते हैं। देहदान, अंगदान के फायदे। आज लाखों रोगी अंगों के अभाव में मृत्यु की राह देख रहे हैं और उनके परिजन इसी पीड़ा को अनुभव करते हैं। लेकिन आज ऐसा भी संभव है कि आप और हम ऐसे लोगों की मृत्यु टाल सकते हैं, उनके परिजनों की पीड़ा कम कर सकते हैं। आज ऐसे लाखों सैकड़ों देहदानी हैं जिन्होंने इस महायज्ञ में अपने अंगों की आहुति दे दूसरों की जीवन की लौ को जलाए रखने का महापुण्य अर्जित किया है।
आज से लगभग 10 वर्ष पूर्व हमारी माताजी का स्वर्गवास हुआ था। उससे कुछ समय पहले ही हमारे पिताजी ने अपना नेत्रदान का फॉर्म भरा था और हमारी माताजी ने तब कहा था कि मेरे भी नेत्रदान करवाइए। कुछ समय बाद ही उनकी मृत्यु हो गई और हमने उनके नेत्रदान करवाए।
उन्होंने बायोलॉजी से BSc की और वो डॉक्टर बनना चाहते, और ये उनको तब आभास मिला कि जो मेडिकल के स्टूडेंट हैं उनको ठीक से मानव संरचना का ज्ञान नहीं होता, और इसी प्रकार से उनके मन में था कि जीते जी जो काम कर सकते हैं करेंगे, लेकिन जाने के बाद भी लोक उपकार के लिए अपने शरीर का दान करने का उन्होंने संकल्प किया था।
आंखें तो खुद ही मेरे पति दान कर गए थे, मैंने भी फॉर्म भरा हुआ है, पर उनकी किडनी और लीवर दिए जा सकते थे। तो बच्चों ने कहा, मेरे को उस समय निर्णय लेना बड़ा ही मुश्किल था, पर बच्चों ने मेरी इतनी हिम्मत बंधाई कि मम्मी अगर आप अग्नि में डाल दोगे तो क्या होगा, 2 चुटकी राख तो फालतू मिलेगी, इसलिए अच्छा है किसी को जीवन मिले। तो जब हमें पता चला कि उनका लीवर जो है 28 वर्ष के एक बच्चे को दिया गया, तो उससे मुझे बड़ी तसल्ली हुई कि किसी माँ का वो बच्चा होगा, किसी पत्नी का पति होगा। तो मुझे अच्छा लगा कि मेरा पति किसी का पति को जीवन दे गया है।
इच्छा की बिटिया की कि भाई कोई ना कोई दान करना, तो हमारी एक रिश्तेदार यहीं डॉक्टर थी, उसको बुलाया और उसको कहा कि भाई ऐसी इसकी इच्छा थी आँख दान हो जाए तो बहुत अच्छा है, और भी अंग। तो आँख दान के लिए उसने उसकी माँ को याद रहा, उसने फटाफट उस डॉक्टर ने जो हमारी रिश्तेदार थी मेडिकल में, उसने इंतजाम किया और फटाफट डोनेट हो गया। जैसे बेटियाँ थी उससे भी आगे थी, और वो भी इसी प्रकार कहती थी कि शरीर का कोई अंग अगर किसी के काम आता तो उससे और क्या भला हो सकता है। और अचानक जब उसकी मृत्यु हुई, उससे पहले ही वो अपना फार्म भर गई थी देहदान का, हमें याद था, इसलिए उसकी डेथ होने के बाद हमने फ़ौरन अपनी ददीची संस्था जो थी उसको फ़ोन किया और उन्होंने आगे कंटिन्यू करके वो जो मेडिकल कॉलेज है वहाँ पर सारा
आज मेडिकल कॉलेज में जब बच्चे पढ़ने जाते हैं तो हमारे भविष्य के डॉक्टर्स या सर्जन्स को पढ़ाई के लिए जो शरीर यानी कैडवर चाहिए, वो भी समाज उन्हें उपलब्ध नहीं करवा पा रहा है।
मैं जब मेडिकल कॉलेजेस में जाता था और विशेषकर मैं एक हरियाणा के मेडिकल कॉलेज में गया तो मैंने देखा कि वहाँ पर जो डेड बॉडी जिसको हम टेक्निकल भाषा में कैडेवर बोलते हैं, उसकी इतनी ज़्यादा कमी थी कि एक कैडेवर के ऊपर दर्जनों बच्चे जो है वो अपनी मेडिकल की शिक्षा प्राप्त कर रहे थे। तो मुझे अपना मेडिकल कॉलेज में जब मैंने पढ़ाई की थी, फर्स्ट ईयर सेकेंड ईयर का समय ध्यान आया और उस समय किस प्रकार से हमारे लिए पर्याप्त मात्रा में कैडेवर उपलब्ध होते थे। बहुत अच्छी तरह से हम एनाटॉमी जो है शरीर की उसको अध्ययन कर पाते थे। तो मुझे लगा कि देश में एक देहदान का भी बहुत बड़ा आंदोलन प्रारंभ होना चाहिए।
जहाँ पे 150 स्टूडेंट्स एडमिट होते हैं या 200 होते हैं तो कई बार एक बॉडी पे 15-15 लोग भी काम करते हैं, 20-20 लोग भी काम करते हैं। तो उसमें फिर थोड़ा सा हर एक को हैंड्स ऑन जिसको हम कहते हैं वो मौका नहीं मिल पाता है।
हमने इस विषय पर देश के बड़े धर्मगुरुओं से सवाल किए।
बापू, मैं दिल्ली में दधीची देहदान समिति के नाम से काम करता हूँ। हम दिल्ली के लोगों से प्रार्थना करते हैं कि अपनी मृत्यु के बाद अपनी देह को मेडिकल कॉलेज को दान करके जाएं, जिससे वो शिक्षा के काम में आए। इसी वर्ष दुर्भाग्य से मेरे माँ पिता गए, पर उनकी अंतिम इच्छा के अनुसार हमने उनकी भी देह दान की। और कुछ लोग, परिवार के भी लोग कहीं कहीं
Hello, yes. Welcome, Dr. Rashi. Now we are going to start the session. Say all please join in the main hall. All the delegates, faculties, please join the conference hall. All the delegates, faculties, please come to the conference room.
All the participants of e-poster competition kindly come inside. We are shortly going to announce the prizes and will distribute the certificates as well. All participants of e-poster competition. All other members, the organizers are requested to kindly send people inside so that we can start the session in time. Organizers, all for you, kindly send the people inside who have had their lunch, or you can take your plate along. Send the people inside. are lined up. They are getting unnecessarily delayed. Kindly come inside. We can start in time. Welcome, Dr. Rajesh Agrawal. All the participants for e-poster competition kindly line up here near the dais, please. Well, friends, good afternoon. For e-poster presentations, we had a very enthusiastic response. We had 12 participants spread all over India. We had people from Jaipur, Delhi, from Bombay, and there was an excellent presentation of e-posters. Whosoever is interested can have it a look outside on the computer. So we'll start with the first participants certification, and for that, Dr. Sood, may I invite you, Dr. Sood, for this. Dr. Ram Babu. Okay, when Ram Babu is not there, then we call somebody else. And Dr. Anand Jha. I request all the participants to kindly come near the dais for the small dais. Again, last call for all participants of e-poster competition.
So prizes for the e-poster presentation, there are 12 participants. And the first prize goes to Nandita Thakkar. Nandita Thakkar. Nandita Thakkar, first prize for the e-poster presentation. It carries a cash prize of 3,000 rupees. ज़्यादा बोल देते नहीं नहीं, इसमें प्राइज में कुछ नहीं है सर, प्राइज में TDS काट के Dr. Nandita Thakkar, yes, she is coming running. She got the first prize for the poster. So he is the president of, vice president of FIMA. FIMA is for Junior Doctors Association. Second prize goes to Raghavi Bembe. Raghavi Bembe. पपलू भी तो है ही डॉक्टर अतुल। यार राघवी बेम्बे को भी दे दो, बहुत हो गया। सेकेंड प्राइज भी दे दो, फर्स्ट प्राइज में लगे हुए हो तो। And third prize, there was a tie between the two doctors, Dr. Suchin and Dr. Asha Lata. The two third prizes, Dr. Suchin and Dr. Asha Lata. Dr. Suchin and Dr. Asha Lata. Thank you. Now they will start the post-lunch first panel discussion, and the topic is very, very important, relevant to all the physicians and general physicians. When, how and how long to treat first seizure in all ages. So very, very important topic, and the speaker is Dr. Jaideep Bansal. He is a senior neurologist, Fortis and Director of Neurology at Fortis Hospital, Shalimar Bagh. Dr. Jaideep Bansal, please. Moderator is Dr. R.M. Chabra. Dr. R.M. Chabra doesn't need introduction. He is the founder president and he is seen everywhere. He is the chairperson, Dr. Rajiv Anand. Dr. Ivan sir, he is the director in HOD Neurology at BLK Max. Dr. Atmaram, he is also senior neurologist at Medanta Hospital. Dr. Manoj Khanal, very good friend of us, working in Max Hospital, Shalimar Bagh as an HOD. And the young neurologist, Dr. Reema Khanna, she is a senior consultant in neurology at Fortis Hospital, Shalimar Bagh. Now hand over the mic to Dr. R.M. Chabra to moderate the session. Dr. Chabra, sir.
Dear friends, it is a very important topic, though it is a post-lunch program, but they will not allow you to sleep. So seizure, it is a big problem. First seizure, whether we have to treat or not. We have the eminent neurologist here. Now I request Dr. Jaideep Bansal, who is a senior consultant neurologist at Fortis Hospital, Shalimar Bagh. Now I request to start the session, please.
Thank you, Dr. Chavda, for giving this opportunity. First of all, I would like to Dr. Atmaram to play a video of seizure. Dr. Atmaram.
So please see this video carefully and make your own diagnosis. Then we'll discuss this at the end of our sessions.
कब से दौरा आना स्टार्ट हुआ होगा लगभग?
करीब मैं 4th या 5th क्लास में हूँ
जी।
और
साउंड थोड़ा बढ़ा दो भैया प्लीज।
बताइए आपको कब से दौरा आना स्टार्ट हुआ होगा लगभग?
करीब मैं 4th या 5th क्लास में हूँ
जी।
और दौरा नहीं आता था पहले, जैसे मैं चाय पी रहा हूँ या कुछ खा रहा हूँ या कंघी कर रहा हूँ
जी,
तो एकदम झटका लगता था।
ओके।
मतलब पूरा चाय गिर गई या यूनिफॉर्म को छुपा हुआ आके
जी,
अपना मतलब किसी को बताया नहीं
जी।
और उसके बाद करीब 10th क्लास में मैं होऊंगा जब फर्स्ट टाइम मेरे को हुआ था।
जी।
और 10th क्लास में जब मैं सुबह 4 बजे उठा, बेल बजी तो मैं गेट खोलने के लिए गया था, तो वहीं पे ही मतलब कंप्लीट जो फिट हुआ.
We'll discuss this after the presentations.
First of all, I would like to say something about North Delhi Physician Forum. Basically, this is a wonderful forum in which all the senior consultants of this area, they are part of it. And they are organizing the conference. And it is just like that कि जैसे गाँव में मैरिज होती थी और उसमें चाचा ताऊ सारे जने everybody was used to organize the event. It is just like that. And everybody is actively participating and nobody is having any issues for ego. So I congratulate them for all this organization. And second is, this organization, one thing is also very important, कि whenever the scientific content is formed, that is all very high. But Dr. Chabra told me that do the total basic things about the small practical problems. And today the topic was the first seizure, when to treat, how to treat and how long to treat. This is the basic thing which everybody should know. As a clinician, all the time we are seeing the patients are coming with history of LOC and now I will be very brief regarding I will give you the brief about this, and then we will have a discussion, panel discussion, and we are having all the eminent neurologists with us, and we will be enlightened with that. And Dr. Atmaram will also show some other videos also for the seizures. Epilepsy is, as you all know, this is the commonest neurological illness, and the magnitude of this illness is very high, and is almost 50 million people worldwide, they are affected with this illness. And as far as India is concerned, almost 12 million people, they are having this disease. So this is a big number, and the prevalence of active epilepsy is between 5.59 to 10 per 1,000. This is also a big number, and we should not ignore it, and we should do the correct diagnosis in right time. The incidence ranges from 49 to 139 per 1 lakh population. This is very wide range because the 49 figure is from the developed countries and 139 from the underdeveloped countries. So this ranges very widely, and whenever we are diagnosing giving a diagnosis of epilepsy, there are almost 20 to 30% of the diagnosis is misdiagnosed as seizure, whereas they are not exactly the epilepsy. So this is to be kept in mind that whenever we are giving a diagnosis, it should be correct. And simultaneously, in a genuinely seizure patient or epileptic patients, almost 30% of the patients, they are also having the non-seizure activity, that is pseudo-seizure or syncope. They are also maybe a part of this. Means each episode which is there for LOC is not always the recurrence of seizure. They may be a seizure or it may be a pseudo-seizure also. So whenever the seizure patient, epileptic patient comes to you with the recurrence of the episode, we should carefully see and whether this episode was seizure or is was pseudo-seizure, because in 30% of the patient, this may be overlapping as well. So, and then if the seizures are precipitated by a particular stimulus, just like pain, emotions, that strongly suggests this can be a non-epileptic phenomena. Therapeutic trial of anti-epileptic drugs in doubtful cases is rarely justified because the drugs are to be given for longer duration, and patients should not be exposed to the anti-epileptic drugs for the reasons for just in doubt. So whenever you have any doubt, it should be cleared and should be referred to the epileptic specialist, and the diagnosis should be made carefully. And up to 30% of the patients, those who are on anti-epileptic drugs, they may have moderate to severe side effects of anti-epileptic drugs. So whenever the anti-epileptic drug has to be started, that should be done very carefully. And erroneous diagnosis of the epilepsy is frequent cause of treatment failure. It is said that patient is having refractory epilepsy. Actually, the patient is not having the seizures. So the number of anti-epileptic drugs you are adding, that will not control the episodes, and patient will be labeled as refractory epilepsy, and the other advanced tests and the investigations are unnecessarily done. So what exactly seizure is? Seizure is the symptom, signs and symptoms occurring due to abnormal excessive electrical discharges of the brain. And this is a single phenomenon, single episode. If these episodes, if the unprovoked seizures, they are 2 or more than 2 and occurring 24 hours apart, then you can say it is a epilepsy. Epilepsy can be divided according to the etiology, according to the type of epilepsy and the frequency. If it is the cause is not known, that is called as primary epilepsy, idiopathic epilepsy. If the cause is there, then it is called as symptomatic epilepsy, where there's definable lesions are there, just like hematoma and the heterotopia. These are small lesions which are present, but they are chronic symptomatic epilepsy. Now comes the provocative seizures. Provocative seizures are actually called as acute symptomatic seizures. There, the lesions are there, the cause of the seizures are present, just like electrolyte imbalance, toxins and the head injury, or the infections, or the stroke. These are called as they provoked seizures. The diagnosis of epilepsy is to be made very, very carefully, because it may greatly influence the patient's future life, not only by affecting the social relations, education and employment, but also the patient's self-esteem. So the key question comes, the episode of brief LOC, was it a seizure or non-seizure? There are certain conditions which mimic these seizures that should be kept in mind whenever such patient comes. And the most common condition, as you all know, is the syncope. Syncopes are of various types, where the vasovagal syncope, where the vagal is stimulated, there is a bradycardia and cardiac arrest, or you can say hypotension, or the peripheral vasodilatation that causes the blood pressure to fall. So in vasovagal syncope, there may be prodromal symptoms, there may be some jerky movements, clonic movements may be there. Conditions are just like in severe pains. Whenever we have seen a patient comes for the blood testing and they collapse, and that is because of the vagal stimulated hypotension. And is a condition which is called as micturition syncope is also very common and quite commonly seen, particularly in winters in males, where in the middle of the night patient goes to go for toilet, and then after micturating he fell down, and this is also vagally stimulated hypotension, which causes the patient to become unconscious. The cardiac syncope, where the cardiac output is low, such as in a patient of rheumatic heart disease, DCMP, and obstructive cardiomyopathy, prolonged QT interval, where the cardiac output is low, so patient there is generalized cerebral ischemia, which causes patient to become unconscious. And the postural hypotension, where the BP falls because of autonomic involvement, and such as in diabetes and Guillain-Barré syndrome, or hypovolemia also. And a condition which is MSA is a condition where there is very prominent symptoms, and this is a condition which is seen in the elderly patients, and they are very well confused with the cardiac syncopes. So this should be kept in mind. A condition which is vasovagal syncope, where cardiac sinus stimulation causes the bradycardia and hypotension, arthritis, and the stretch syncope is also one of the conditions where there is a compression of the vertebral artery that lead to fall in the blood pressure, and patient may become unconscious. And the respiratory syncope is also very commonly seen condition, where there is a bout of cough and patient become unconscious, where the cough is so severe that there is a hypoperfusion of the brain, so the patient become unconscious. Another very important and very common condition is a pseudo-seizure and panic attack. This is really a condition which is very difficult to sometimes differentiate from the seizure, because the family is in panic and they are exaggerating the things, and most of the time this is young females, they are having these seizures, PNES, but it can occur in males also, and the elderly women, elderly people also. So this can be of either two types, either motionless fall, or there may be some movement with the loss of consciousness. The typical thing is, whenever you try to open the eyes of the patient will resist. Otherwise, in genuine seizure, the patient will not resist the opening of the eyes. And normally in seizure, the patients are uprolled, and the investigation is video EEG. That is very, very helpful. Whenever the patient is having this episode and EEG is normal, that actually rule out the genuine seizure. There are other conditions which also mimic like seizure. There is TIA, whatever there is insufficiency where the transient focal deficits is there and the patient fall. Actually, in this isolated LOC is not there, but patient falls. So sometimes it is misdiagnosed as seizure. And TGA is a condition with a transient global amnesia where patient remain conscious and patient is amnestic of the event, and this may last for a few hours to few days, and the patient is otherwise all right. And the exact cause of this is not known. It is said to be ischemic or it is epileptic, but the EEG and other investigations are normal. Another condition which is called as transient epileptic amnesia, where there is a recurrent episodes of amnesia and the EEG is abnormal. These are the two conditions which can be differentiated by EEG. Acute raised ICP also, the patient may fall and may have a drop attacks, particularly third ventricular tumors. Whenever the patient bend forward, patient may fall, or any other condition where raised ICP is there, patient may have the symptom of headache, visual disturbances and drop attacks. So that should also be differentiated. And another condition which is cataplexy, where patient suddenly become unconscious, a bout of laugh, and after laughter he just fell down, and after that he just gets up, and usually consciousness is not is usually preserved. In migraine also, particularly in migraine with aura, the patient is having the symptoms of visual symptoms and followed by headache. And in this, it is you can say mimic like a occipital complex partial seizure, because the occipital phenomena is there. In migraine, the occipital phenomena will be, there will be gap of some time, then there will be headache. Instead of that, the complex partial seizure of epileptic type, the patient will, if the headache is there, that will be in the continuation of that. And in migraine, the precipitant causes will be there, family history will be present. Hypoglycemia is also very, very common, as you all know, all are practicing the diabetologist. And this is very simple to diagnose, because in a diabetic patient, first thing should be the hypoglycemia. And very simple, just to get the RBS done the moment patient had this episode. And the other conditions which may also mimic the seizures are the hemifacial spasm. In hemifacial spasm, there is a spasm of one side of the face that look like a focal seizure. But in hemifacial spasm, it will be localized to face only. But in focal seizure, the contractions will be, or the spasm will be not only in the face, but it also involve the upper limb also. If the patient is having twitchings in the face and the upper limb, then definitely it is not the hemifacial spasm. And tics also may mimic like seizure, and tonic spasm in the multiple sclerosis are also one of the cause. And the vestibular disorder, hallucinations, delusions, sleep disorders also may sometimes mimic like seizures, in which the EEG, video EEG and sleep studies, they are very helpful. Now comes the causes of epilepsy. That depends on the age group of the patient, because in neonatal group, the birth injury, congenital causes, hypoxia, metabolic causes, they are usually the causes. And in infancy, the febrile seizure is the most common cause, and the infantile spasm, which is also called as West syndrome, where the EEG is showing hypsarrhythmias and the mental retardation also there. And in children, the other syndromes which are apart from the febrile seizures, patient may have LGSA, Lennox-Gastaut syndrome, and continuous waves during slow waves, and Landau-Kleffner syndrome. These are the type seen in the children. In adolescent and adulthood, the JME is also very common condition, in which the patient is having the myoclonic jerks, especially on awakening. In the morning or in the afternoon, whenever he sleeps, he gets up, he may have some jerks and he may fall. And this is a benign condition, but in this, the patient will have to take the medicine for long. Lifelong medication is to be taken for these. And the other condition, juvenile absence epilepsy and the temporal lobe epilepsy, trauma and drug withdrawal is also one of the causes of adulthood causes. Middle-aged and old-aged people, the trauma, tumor, vascular causes, degenerative diseases, they are the causes. And the variable age of onset is reflex epilepsy and progressive myoclonic epilepsy. there are certain drugs which are also, which can precipitate and they can induce the seizures. There are certain antibiotics just like penicillin, quinolones, INH and linzolid. We have to see that whenever the patients are on these drugs, if they throw a seizure, then we should first of all change the anti-epileptic drug or the antibiotic or the drugs. And we should avoid giving them in a non-epileptic patients. The cardiac dysrhythmias agent, just like lidocaine and disopyramide, and the antimalarial quinolones, the chloroquine and mefloquine, stimulants like aminophylline, theophylline, amphetamine. These are the drugs which are CNS stimulants that they can also cause the induced seizures. And the withdrawal seizure with alcohol and barbiturates are very common, and that should be carefully seen, and that doesn't require any anti-epileptic drug to be started. And the tricyclic antidepressant lithium and baclofen is also one of the drugs which can precipitate and which are very commonly used. How to diagnose and how to evaluate the patient, such patients. In this first episode, the eyewitness is the cornerstone of the diagnosis. As we have seen, nowadays everybody is having a mobile. If they can record the episode, that is the best way to diagnose such episode. And CCTV cameras footage, that is also very useful. And most of the time, many times the patient comes with the CCTV footage, and the diagnosis is clear then and there only. So that becomes a very important tool, because that prevents the further costly investigations and unnecessarily putting the patient on anti-epileptic drugs. And the previous medical illness and the previous treatment history is also important. As we have seen, drugs can also precipitate the seizures. Then comes the etiology of the seizures. If the seizure is provoked seizure, that because of hypoglycemia or electrolyte imbalance, that should also be seen. And then once it is sure that it is seizure, then it should be classified the type of seizure. Investigation, all we know that all routine investigation, apart from the routine investigation, the RBS, the random blood sugar, calcium, and electrolyte is the first thing and very simple thing to be done in the trials. And the EEG and hyperventilation and photic stimulation is one, video EEG and sleep deprived EEG. These are the things which differentiate the genuine seizure very genuinely, and other investigations as and when required. And risk factor for the seizure recurrence are about 60 to 70% in initial 6 months, and after that the chances of recurrence reduces. What are the factors where the risk of seizure increase is if the patient is having remote symptomatic epilepsy, or the focal deficit is there, Todd's paresis is there, or the EEG is abnormal, he is showing epileptic discharges, then the chances of recurrence is high. If the patient is present with the status epilepticus, then that should be treated, that should not be left. And the family history, then the patient of the recurrence, chances of recurrence is high. And the patient where the febrile seizure is there, then also the chances of recurrence is high. Again, this is seen. This is the relapse rate. We'll discuss it later on. Now comes the management. The decision to treat the patient, such patients who present with the brief episode of LOC depends on the balance between the benefit of the treatment and the drawbacks of therapy. Because benefit of what are the benefits? It lowers the risk of recurrence. Once you start the medicine, the chances of recurrence of seizure is less. Because if you are sure that this is seizure, then you start the anti-epileptic drugs, the chances of recurrence is low. And the lower risk of potential injuries and death. If the seizure recurs, that can cause the injuries to the patient, and that is also prevented. And the psychological and social benefit of more security from the seizure. If the patient is having no recurrence of seizure, the patient will feel more confident. And on the other side, the drawbacks of therapy are drug side effect. As I have told you, there is almost 30% of the patient, those who are taking anti-epileptic drugs, may have moderate to severe side effects with the existing anti-seizure drugs. So that should be kept in mind. And psychological and social effect, the patient, those who are on drugs may have the stigma for that and inconvenience for taking the drugs. There are criteria for starting the anti-seizure drugs. The diagnosis must be very clear that this is seizure only, not a non-seizure activity. A risk of recurrence is high, and the seizure must be sufficiently troublesome. Here, one very important thing is there, the patient's wish are to be fully accounted, because patient should be explained about the recurrences and chances of recurrence, and then accordingly the medicine is to be started. Approach to the first seizure, based on the history and physical examination, exclude the events of the first seizure. This make sure that on history and examination, the seizure is actually genuine seizure, and exclude the provoking factors just like hypoglycemia and electrolyte imbalance. Once it is made, then do the the EEG and the MRI also. And then the first seizure mandate the individual counseling, because the patient is to be counseled regarding the risk and benefit of the starting the anti-epileptic drugs, and the patient should be counseled regarding the activity like driving and swimming. And then principle of treatment is always start, if you are sure that this is a seizure activity and you have just counseled the patient and anti-epileptic drug is to be started, then always start with the monotherapy. Start with the single drug and gradually build up the doses, and accordingly when it is well controlled, then continue. Most of the time, in 40 to 60% of the patient is well controlled with the single monotherapy. If it fails, then try another monotherapy and gradually build up the another the anti-seizure drug and taper off the previous one. And
Jaidev, time is up, please wind up.
I will just the last slide, and I'll skip this slide. They are whenever we are choosing the anti-epileptic drug, there are comorbidity also to be kept in mind, just like headache, valproate and topiramate is the drug of choice, and anxiety, depression, and the carbamazepine, oxcarbazepine, lamotrigine, and valproate are the drug of choice. Sleep, the clobazam is the drug of choice. Felbamate causes insomnia. If the patient is obese, the topiramate and zonisamide are the drug which causes the weight loss, and valproate causes the weight gain. So they should be avoided. And cardiac arrhythmias, if the patient is a cardiac patient, then valproate and carbamazepine and oxcarbazepine are the drug of choice, and avoid the rufinamide and lacosamide and phenytoin, because they can cause fatal cardiac arrhythmias. There are certain, the anti-epileptic drugs can also induce certain type of seizures, just like absence seizure may be precipitated by phenobarbital, carbamazepine and vigabatrin, and the myoclonic jerks may be precipitated by the vigabatrin and lamotrigine, and the carbamazepine can precipitate all these myoclonic seizures and absence seizure. The phenytoin toxicity can cause induced encephalopathy and can increase the paradoxical increase in the seizure frequency. And valproic acid induced encephalopathy with the hyperammonemia is also cause of increased seizure activity. How we'll manage the protocol for management is establish the diagnosis, identify the precipitating factor if it's there, and decide upon the need for the seizure, and then counsel about the reason for starting the anti-epileptic, goal and outcome, and the risk factor. And then start with the monotherapy, titrate the dose, and 60 to 70% of the patient, the seizures are well controlled with the single, or you can say polytherapy. And if it is not, then do the alternate monotherapy, or reassess the patient that the patient is having the seizure only. In conclusion, we can say that diagnosis of seizure is to be made very carefully, because the moment you label it as a seizure, you start the anti-epileptic drugs. Once it is started, it is sometimes very difficult to withdraw it, because the diagnosis is already made, and the patient will have the stigma for that. And the decision to start depends on not only on the drawbacks of the balance between the benefit and the drawback of the therapy, and it depends on the multiple factors, including the patient's wish. And selection of the anti-seizure drug must be correct, which depend on the type of seizure. And this is very important. Many times this myoclonic seizures, carbamazepine is selected and patient is not showing any control over it. No place for therapeutic trial of anti-epileptic drugs in practice. Thank you.
Thank you, Dr. Bansal. Very nice presentation. So there is scarcity of the time. Everybody is staring at me. Dr. Malhotra, can we discuss later on, please? Flight on ki jana next flight on, please.
One short question.
You can.
In a patient with incidental finding of granulomatous lesion in the brain, normal EEG, no seizure history or activity, shall we start the treatment or wait for the treatment, and when to and how long?
Just see. If the patient had this calcified lesion in the brain and there is no seizure and EEG is normal, then it is not the indication for starting any anti-epileptic drug. But patient is to be monitored, and the sleep deprived EEG and the video EEG is indicated in such patients. And it is not just once you see the lesion or EEG is abnormal, 2 to 3% of the normal patients may have some electrical activity in the EEG. So it is not just the one single factor which is deciding. And if the EEG is grossly abnormal and showing the sharp and spike and wave discharge, then definitely that is the abnormal, and we should start. It is not just see.
I'll answer this question.
Dr. Rajiv, last.
Dr. G.K. Ahuja is, everybody knows him. He is a doyen of neurology. So once my classmate's daughter was fully controlled epileptic, and she was doing well, but EEG was showing discharges. So I couldn't convince him, and he took that EEG to Dr. G.K. Ahuja, and he told them, we treat the patient, not the investigation. So your answer is, we treat the patient, not the investigation. If patient has had never any seizure, and it's an incidental finding, nothing to do it.
Yes. Thank you very much.
Now, Dr. Chhabra, just
give the big hand, please. Sorry.
Now we will have a panel discussion. I think is
Dr. Sanjay, please यार उनको flight है उनकी, please.
किनकी flight है?
डॉक्टर उनके कलकत्ता की flight है उनकी. Please अगली बार बाहर में डिस्कस कर लेना. Please यार, sorry. Time is over. Huh? Yeah. Thank you very much.
No panel discussion.
Thank you.
Actually, no discussion.
Thank you, Dr. Patel and our chairpersons. Now request Dr. Rajiv Anand to honor Dr. Jaideep Bansal. And request Dr. Malhotra, our president, to honor the chairpersons.
I request to cut short the honor business and start the next session.
Next speaker is Dr. Rajesh Kumar Agarwal, and the topic is choice of IV fluids in different clinical situations. Dr. Rajesh Kumar Agarwal is senior consultant nephrologist, chief department nephrology and kidney transplant, Sri Balaji Action Hospital, and the chairpersons are Dr. Manoj Arora. He is a senior consultant in Max Hospital, Shalimar Bagh. The second chairperson is his colleague, Dr. Yogesh Chhabra. Now no more young, but he earlier was young, dynamic nephrologist. Then we have got Dr. Naresh Pamnani. Dr. Naresh Pamnani is senior consultant physician, plus he is the director of his hospital, Bhavati Hospital. Then Dr. S.K. Bakshi. Dr. S.K. Bakshi is a senior consultant and head of medicine at Metro Hospital. Now request the chairperson to start the proceedings.
Good afternoon, everyone. So I would like to invite Dr. Rajesh Agarwal. I think sir needs no introduction because he is a well-renowned nephrologist in this area, and he is practicing in Action Balaji currently as a head of the department. So I would like to invite Dr. Rajesh Agarwal to proceed for the session. Thank you, sir.
Brief introduction. I invite Dr. Kiran Chhabra, the renowned gynecologist in North Delhi, and Dr. Praveen Bhatia to honor her. Thank you, sir. Sorry for that.
Thank you, Dr. Chhabra and his colleagues, and Dr. Manoj, Dr. Yogesh, Dr. Pamnani, meeting him after so many years, and Dr. Bakshi. We were together in 84 to 87. He was doing PG at that time. So thank you very much. So I could meet my so many friends after so many years after coming in here. Today I'm going to talk on choice of IV fluids in different clinical scenarios. You will agree with me. Now, easy availability of different IV fluids, ringer lactate, stereofundin, cabalite, N/2, ringer lactate. So many fluids are now available, and we are treating so critically sick patients, and we're getting ABG done and electrolyte done so frequently. And with the results of the recent trials coming in, more rationality has come in for choosing the right IV fluid while we treat patients. Whether in patients while we are resuscitating patients of septicemic shock, should we continue using normal saline or cabalite? While we are treating diabetic ketoacidosis, should we continue with normal saline or change it with cabalite? These are the few issues that I will be talking in next few minutes of my talk. 60% of a body is fluid. So a person weighing 70 kgs has got 42 liters of water. And out of that, water is divided in 3 compartments. Intracellular is 66% of the water. That is 28 liters out of the 42 is present inside the cells. And 14 liters is present outside the cells. With outside again divided in the intravascular and interstitial fluid, and 25% of the extracellular is present inside the intravascular compartment. The sodium is the main cation outside the cells, and chloride and bicarb are many anions outside the cells, extracellular. And inside the cells, potassium and magnesium are main cations, and phosphate is the main anion. What is important is the osmolality on both the sides is equal, and that remains equal even if the change in osmolality on one side occurs by the movement of water by the process of osmosis. For example, if the patient develops hyponatremia, the osmolality outside decreases, automatically the water will move inside the cells and the osmolality will become equal on both the sides. This is an important thing to understand before we move further. This movement of fluid inside extracellular and intracellular occurs by the process of osmosis, whereas the movement of fluid from the intravascular to the interstitial fluid occurs by the hydrostatic pressure and by the oncotic pressure maintained by serum albumin. You see, we have got blood has got packed cell volume and there is plasma, and the plasma has got serum. Is serum all water? No. 7% of the serum has got solid phase, and this solid phase consists of lipids and proteins. And this is the formula where we can calculate exactly what is the water content of the serum. This is important to understand. This is because you see, we say normal saline has got a sodium of 154 millicoulombs per liter. Normally, when the sodium is more than 145, we say this is hypernatremia, and we say sodium of 154, we say that this is normal saline. This is because of the fact that when it adds into the body, the 7% solid phase comes in and the sodium becomes 143. So the effective sodium is 143. In the bottle, it is 154. Now, this is very important. What is the distribution of fluid of different compartments? Now, if you give 1 liter of 5% dextrose to any person, what happens? 5% dextrose under the influence of insulin, when glucose is metabolized, is water. 66% of this goes inside the cells, and only 34% remains outside the cells, and intravascular is just 85 ml. That is, if you give 1 liter 5% dextrose, intravascular gain is just 85 ml. And this distribution occurs within half an hour of giving fluids. So whenever the patient has got hypernatremia, one should not be afraid that the patient will get fluid overload, because intravascular is just 85 ml. Normal saline, everything goes to the extracellular compartment. 25% goes to the intravascular compartment, and the interstitial is 750 ml. But if the patient has got severe hypovolemia, then the hydrostatic pressure decreases. And if you give normal saline 1 liter, maybe that fluid remains in the intravascular compartment for a longer period of time. N by 2 is half water, half normal saline. If you give 5% albumin to the patient, like a patient of the chronic liver disease, HRS, where the interstitial fluid is filled up, only the effective arterial blood volume is less. In that case, you'll find 900 ml remains in the intravascular compartment, only 100 ml slips into the interstitial compartment. And if you give 20% albumin 1 liter, 1 liter becomes 4 liter in the intravascular compartment because it takes 3 liters from the interstitial compartment. And if you give 1 liter of blood, everything goes to the intravascular compartment. Very important point to understand is strong iron difference. To understand the fluids, which fluid to give. The sodium and chloride are very strong cations and anions. The bicarb is a very weak anion. That is why the difference, normally sodium, if it is 140, the chloride is 102. And the strong iron difference is 38. Whenever any fluid which has got strong iron difference less than 38, or the existing bicarb of the patient is an acidic fluid. Any fluid which has got strong iron difference more than the patient's bicarb is an alkaline fluid. Like normal saline has got sodium of 154, chloride of 154. The strong iron difference is 0. It is a highly acidic fluid. Isolate G is got sodium of 63, potassium 17, and chloride is 150. So strong iron difference is minus 70. Very, very highly acidic fluid. And it has to be used in patient with metabolic alkalosis. Now if the patient has got acidosis, we have got ringer lactate with a strong iron difference of 29. Then we have got cabellite, which has got a strong iron difference of 50. And stereofundin, which has got a strong iron difference of 25.5. And the extreme end of this is your isotonic bicarb fluid, which has got strong iron difference of 150. Now what is this isotonic bicarb fluid? The 100 ml, if you take 8.4% of soda bicarb, is got 100 milliequivalents of sodium as well as bicarb. You add 150 ml of soda bicarb to 1 liter of 5% dextrose, it becomes isotonic soda bicarb. That is 150 milliequivalents of sodium and 150 milliequivalents of bicarb. So in this case, the highly alkaline fluid, that is your 150. Isotonic saline. This is important, you see, very commonly used. If you add 9 grams of salt to 1 liter of water, we say this is isotonic saline or normal saline. And it's got sodium of 154, chloride of 154, strong iron difference is 0. The calculated osmolality is 308, whereas the effective osmolality is 286. So this is what is normal in normal saline. The osmolality is normal. Otherwise, everything else is abnormal. Normal chloride is 102. Here it is 154. Normal sodium is less than 145. It is 154. And strong iron difference normal is 38. It is 0 over here. And advantages of using normal saline, it is a cost effective. We are familiar with the fluid, easily available, and can be used in acute CVAs and head injury. In acute CVAs and head injury, this is the fluid to be used. We cannot use ringer lactate or cabellite because those fluids are hypertonic fluids, and this is an isotonic fluid. This is the fluid of choice. The disadvantages of using normal saline, it can cause hyperchloremic type of metabolic acidosis. Now why this hyperchloremic type of metabolic acidosis? Because I give you an example. Like patient has got gastroenteritis and the bicarb loss has occurred. He comes to us with a bicarb is 10 milliequivalents per liter. His accessible fluid volume earlier was 14 liters. It has come down to 10 liters. Now if you add 4 liters of normal saline, the bicarb remains the same, but you have increased the volume. So the dilutional, the bicarb goes down further and causes metabolic acidosis, and you're giving more bicarb to the patient. That causes hypochloremic type of metabolic acidosis. Not only that, it also delays the recovery of AKI, causes more AKI, and the more requirement of dialysis also occurs. This is because of the fact when there is more chloride, body doesn't require that much chloride. Chloride is filtered from the glomerulus and goes to the proximal tubules where it is not absorbed, and it takes sodium along, and the sodium and chloride goes to the macula densa, And by the tubuloglomerular feedback, there is constriction of the afferent arterioles and the GFR decreases and AKI develops or AKI takes longer time to recover. So, but where it has to be used? So the disadvantages, hypercolemic metabolic acidosis and AKI. There's a disadvantage of using normal saline. The way to use it, they use it in patients with hypocolemic type of metabolic acidosis. Now either is vomitings are there, rise to aspiration is there, or you have been giving diuretics to the patient, you have decreased the volume of the patient and caused metabolic alkalosis. This is the fluid of choice. In hypovolemic hyponatremia, this is to be used. Acute brain injury, CVAs, head injury, this is the fluid to be used. In hypercalcemia. Hypercalcemia, we give normal saline to increase the calcium excretion. Problem is, some hypercalcemia we know, it causes nephrogenic diabetes insipidus. It can cause hypernatremia. So if there is hypernatremia, never use normal saline. Give N/2 or 5% depending upon the sodium content of the patient. Controversial use or debatable use of normal saline in patients in septic shock or diabetic ketoacidosis or intraoperative and early post-operative period in renal transplant surgeries. Till now we were using N/2 in renal transplant surgeries. And now the 3 trials have come in and they have shown that if you give Cabalite to these patients, then the hyperkalemia is less, the acidosis is less. Renal recovery remains the same. Now what are these balanced fluids? Balanced fluids are like ringer lactate, Cabalite, stereofundin. They have a concentration gradient close to the plasma. And chloride is much less as compared to, but they've got other annoyance, like ringer lactate has got lactate, 29 millimoles per liter. Lactate is converted to bicarb by the liver. And the Cabalite has got acetate, and acetate is converted again to bicarb by the liver and by the muscles. The basic fluids are neither perfect nor physiological. They should be avoided in head injury and acute CVA patients. In liver disease, ringer lactate is to be avoided. In hypercalcemia, ringer lactate is to be avoided because there is calcium in it. Acetate is metabolized by the liver and muscles to bicarb, and there is a fear that acetate will be converted to acetoacetic acid and ketonemia can increase in the diabetic ketoacidosis, but the large trials have shown that this risk is unfounded. We can easily use Cabalite in diabetic ketoacidosis. Patients with borderline high potassium might get hyperkalemia if large volume balanced fluids are used. And it has been shown that if you would use normal saline, there is more hyperkalemia and acidosis, where you will balance fluids, ringer lactate, although they have potassium, but because they cause alkalosis, the lesser amount of the hyperkalemia occurs. Now saline versus balanced fluids. In the sensitivity fluid for septicemic shock, SMART trial has clearly shown that lower hospital mortality at 30 days, lower need for RRT, no difference in persistent renal dysfunctions. Although not definite evidence of advantage of using balanced fluids over normal saline, enough physiological rationale in favor of using balanced fluids, expecting any long-term outcome benefit of any single intervention is unrealistic. Diabetic ketoacidosis, saline is recommended by the guidelines, but when large volume normal saline is given, it causes acidosis and AKI. There is also higher risk of AKI. Many observation studies and experts now believe that balanced fluid should be preferred as it shortens the time of recovery from diabetic ketoacidosis. Self-WH et al. And Ramanan M et al. Trials have shown shortening of time of resolution by 20%, decreased insulin infusion by 30% with use of balanced fluid as compared to normal saline in diabetic ketoacidosis. Acute gastroenteritis, normal saline should never be used. Only ringer lactate or Cabalite. Never use normal saline in gastroenteritis. Isolate G, it has got a highly acidic fluid, strong ion difference of -70, it's got ammonium chloride, and should be avoided in liver disease, and this is to be used in severe refractory metabolic alkalosis when other treatments are ineffective or contraindicated. Isotonic bicarb, I told you that you have decided that you have to give bicarb to the patient, and because it's a hypertonic fluid, never push bicarb, give it, combine it, make it isotonic by combining 150 ml in 1 liter of 5% dextrose, and then you give it, and then it has got strong ion difference of 150. It remains the extracellular fluid to be avoided in fluid overload, hypokalemia, and you control blood sugars. To summarize, the type of fluid to be used should be chosen after giving due consideration to the physiology and the clinical situations. Thank you.
As a nephrologist, I must admire this was a very beautiful presentation and very eloquently presented. And I would comment, sir, that it has been a topic which is very wide, beautifully covered. And any question from the dais will be welcome.
Chloride is a very important thing, ignored thing. For 140 sodium, the chloride should be 102. Now if you get sodium is 130 and chloride is something, always calculate or correct this chloride for that sodium. Like we correct calcium for albumin, we should correct chloride for that sodium. And sodium minus chloride gives you strong and difference. That gives you an idea whether there is metabolic acidosis or not. You don't require an ABG for that. You get an idea from sodium and chloride, but you provided you correct chloride with sodium. So for 140 sodium, the chloride is 102, and that way you can correct it.
Any other question? Yes, sir, Dr. Rajiv, sir.
You see, for hyperchloremia has got its own problems. It causes acidosis. So it should be normal chloride. Like for 140 should be 102. That is like this, right? But if it is more, it is harmful. And less also can be harmful because other things will occur, right? Like we have got vomitings. It is hypochloremic. But if the chloride goes down, the bicarb increases automatically because the anions have to remain same common. Like vomitings have got hypochloremic metabolic alkalosis. Diuretics has got hypochloremic metabolic alkalosis. So one thing goes down, the bicarb has to increase. The anion has to remain normal. Cations have to match the anions.
So I would like to make one more point that when we are thinking that NS is not a good solution, and many times in liver disease and when you have a lactic acidosis, you cannot use RL. So Ringer solution without lactate is also available. So one is a lactated Ringer solution which we use, another is a without lactate. So that is called Ringer solution, where you can have a balance of sodium, potassium, chloride, but the acetate is minus. So when in those conditions, that can be used as ideal. And third, sir, I would like you to just narrate the use of 3% saline, which we left, I think, in this word. It should be used very judiciously, and I will like, sir, to give just 2-3 good points before you jumping to start 3% saline.
That's very, very important. Good question, because 3% saline I've seen misuse 3% saline. Acute symptomatic hyponatremia. If there is hyponatremia, patient has got acute symptomatic. Acute symptomatic means the patient has got neurological symptoms. The patient is convulsing, patient is comatose, patient is drowsy, and then you give 3% saline. And there is a way to give it. Just give 100 ml 3% saline stat. And after, see, maybe 15-20 minutes, half an hour, you give more 100 ml. The purpose is to increase sodium by 5. And by increasing sodium by 5, we decrease intracranial pressure by 50. And that prevents the neurological problems. There is no point of giving 10 ml per hour, 20 ml per hour. That is all useless. You should give it only when it is acute symptomatic hyponatremia. That is it.
Thank you, sir. Thank you, Dr. Agarwal and our chairpersons. Now request Dr. Pamdani and the chairpersons to please honor our speaker. And Dr. Meglani, our secretary, to honor the chairperson. Next is cardiology again. Dr. Vijay Prakash Pandey is the speaker, and the topic is evidence with ARNI implications across the spectrum of LVEF. Dr. Pandey is interventional cardiologist at HOD Cardiology and Nach Narayana Hospital, Havada. And the chairperson is Dr. Rashi Khare. She is a senior consultant in cardiology at Fortis Hospital, Shalimar Bagh. Dr. Paras Gangwal is the president of East Delhi Physicians Forum, plus he is a senior consultant in Max Hospital, Parpaganj. Then we have Dr. A.K. Sureka, very senior physician in Rohini, and Dr. Anil Jain. Anil is also senior consultant physician in medicine, practicing in Rohini. Dr. Anil Jain. Before we start the session, I request Dr. Chabra to honor Dr. Amar Preet. He is very active medical social worker, Dr. Amar Preet. And now I hand over the mic to the chairpersons. Yes.
Yeah. So, good evening, friends. Thanks to the North Delhi Physicians Forum for inviting me to talk on this topic. This is evolving evidence with ARNI, implications across the spectrum of LVF. We know we are treating heart failure for ages now, and whether the ejection fraction measurement is really important in choosing the drug is one of the topics. Because in February 2021, ARNI got FDA approval for use in heart failure irrespective of ejection fraction. Normally, you know that Paradigm Heart Failure Trial, which was published in 2014, was designated that it should be used in heart failure with ejection fraction of less than 40, what we call heart failure reduced EF. And then came the Paragon trial, which was a borderline type, but still those patients who had a EF of less than 57, it was suggested to be used. And now we know that EF less than 40 is heart failure reduced EF, above 50 is heart failure preserved EF, and between 40 and 50, what we call heart failure mid-range. So the facts regarding mid-range are very little in the public domain. You have to really search the literature. So I'll try to focus a little bit on mid-range as well. And there is a very strong correlation for the physicians, because ischemic heart disease and renal dysfunction is quite often associated with mid-range, not so with preserved, and not so really with the reduced also. I'll tell you the reason. So nowadays heart failure we treat, we look at the signs and symptoms, we look at the echo to categorize whether this is reduced, preserved or mid-range, and then we probably do a NT-proBNP, not really for diagnosing reduced EF, but definitely for diagnosing preserved EF. And secondly, we do it for prognostication. So once you have a look on the clinical spectrum of the symptom signs, have a look on the echo, look on the NT-proBNP, you're really sure what you are dealing with. And with the advent of a quadruple therapy that includes the ARNI, that includes the beta blockade, that includes the MRAs and SGLT2, the treatment has really progressed over last 2 and 3 years. But still, if you look at the event rate, say in Paradigm Heart Failure, where ARNI was compared with enalapril, the control arm has an event rate of around 15%. Look at the DAPA Heart Failure, where all the 4 molecules were used, still in the control arm, you have an event rate of around 15%. Look at the Emperor, event rate in the control arm was 21%. So whatever you do, quadruple therapy, pentaple therapy, these patients really do not do well. Still you have a residual risk, and it's worse than the most of the prostatic cancers and even some of the colonic cancers. So in our MBBS days, we were taught 1 year survival was 50%. When we graduated our MDs, 5 year survival was 50%, but with quadruple therapy, it is, with the current mode of therapy, we are having event-free life of almost 10 years. So it is important to use these 4 principles, 4 pillars of therapy to prolong the event-free survival of at least 8 to 9 years. So the phenotyping of heart failure is nowadays important. When you look at the phenotype, then it is easier to use which drugs you are going to use. And the mid-range EF is a slightly neglected one, because we really do not know whether this is the heart failure preserved EF which has deteriorated, or this is the reduced EF which I have treated has improved, because unless you have a background echo, you are in a soup. And prognostication becomes difficult. But in practice, I can tell you that anyone who has got an EF below 50, we treat them as heart failure reduced here. That means all the 4 drugs are to be used. And in last few years, I think there is hardly any role for ACE inhibitor and ARBs, unless you have some specific indication we will discuss at the end of it. So nowadays, ARNI is to begin with. Initially, it was you titrate with valsartan or some other ARBs or ACE inhibitor. You give a washout period of 36 hours for ACE, and then you switch to ARNI 50 milligram, then 100, 200. Nowadays, no. Because you start if there is no contraindication, and contraindication only 2 things. Your EGFR has to be above 30, your systolic blood pressure has to be above 100. It's so simple. And your potassium has to be below 5.5. So if these 3 things are met, and you have a symptom signs of heart failure, irrespective of NT-proBNP, ARNI will be on board. And you have to monitor whether the pressure goes down, whether AKI happens, whether there's 50% rise in creatinine, then probably you slightly reduce the dose. So nowadays, we know, in fact, ARNI has taught us how to treat heart failure. So data backing ARNI in the use of a mid-range as well as preserved EF, still it is class 2B indication. That means most of the time will not use, because diuretics will be the cornerstone. SGLT2 in 2023, few months back, have got a class 1 recommendation. And probably ARNI in the coming year also might move towards class 1. We need a few more trials actually. But out of all these 4 drugs, you also as a physician must have experienced that this is the only molecule where patient reported outcome is greatest. You start any, doesn't matter if it is 25 milligram twice daily or 50 milligram, patient will come and tell you, doctor, I am feeling much better. We have never experienced with ACE inhibitor, we have never experienced with beta blocker, never with MRS. So what I say, ARNI behaves like a CRTD, giving a costly device of 5-6 lakh rupees almost gives you the similar result with the ARNI. And we have got this strong scientific evidence that it improves the ejection fraction by double digit. It reduces the NT-proBNP by 50% within first month. And it comes only at one side effect, a drop in blood pressure. So regarding that also, you have to look whether this is the physiological, that is symptomatic drop, or this is just the numerical drop. Most of the time we ignore a systolic blood pressure of 86 or 85 millimeter if the patient has come walking to your clinic. He doesn't have a perfusion problem with that systolic blood pressure. Probably I'll continue the same dose and will not increase it. So the impact on the clinical outcome with this molecule, even in a CKD and a ischemic heart disease, is phenomenal. The only exception is probably the acute MI situation, because Paradise MI did not show a great result with ARNI vis-a-vis Ramiptal. So apart from acute myocardial infarction, that is the first 3 months of MI, most of the heart failure, irrespective of ejection fraction, ARNI will be on board. So similar is the effect on a kidney patient, similar is the effect on, let's come at this guideline, yeah. This is 2022 guideline, which I was saying SGLT2 2A, now it has gone up to 1B, whereas all other in heart failure, mid-range and preserved EF is still class 2B. So only for ejection less than 40, it is class 1A indication. Same guidelines across the globe is almost the same. Indian Heart Failure Association guideline is also on the same line. A little bit talk about this latest Paraglide trial, which was the latest trial in heart failure. And it was shown that the NT-proBNP reduction, even in acutely hospitalized patients, are phenomenal. So we don't get much drop in NT-proBNP with SGLT2 inhibitor. Although patient gets response within first 2 weeks or 3 weeks, but drop in NT-proBNP is not that good. For that matter, vericiguat also, drop in NT-proBNP is not that great. But ARNI is the one where you get a 50% drop within 4 weeks. In proof heart failure, within 2 weeks, you get a 50% drop in NT-proBNP. So in 2023, if you diagnose a heart failure with ejection of less than 50%, my gut feeling will be that Arni will be on board, depends on the blood pressure head. Normally we start 50 milligram twice daily. We look at a creatinine, potassium, systolic blood pressure every 2 weeks and keep on up titrating unless there is a 50% rise in creatinine or there is a rise in potassium level or the systolic blood pressure drops below 90 with symptoms of postural hypotension. So that is the way to treat heart failure. And as I said, all the 4 trials, the residual risk still remains 13%. There has been a publication which pooled the data from paradigm heart failure, that is ARNI, from the emphasis heart failure, that is on MRAs, and DAPA heart failure. The total number of patients were 15,000 patients. By the combination of these 4 drugs, we could increase the event-free survival more than 8 years. This wasn't the case with ACE inhibitor and beta blockade when we were practicing in 89 and 90s. What about the generic versus a non-generic? Because now this has lost the patent. Just like ticagrelor, this ARNI is a special molecule with the 73 stereoisomers. It's made in 1:1 molar. It's not very easy to copy it. Solubility profile is a problem. So generic will be generic and branded will be branded. I'll not add further to that. So if the patient can afford, I think one would go with the originator brand rather than the generic with all the benefits on board. I'll end here. Thank you for the patience hearing. If you have any questions, I'm glad to answer those.
Thank you very much, sir. It was very crisp and precise talk on management of heart failure, which is day in, day out. We see in our OPD patients presenting to hospital with worsening heart failure symptoms, and in our busy OPDs, we very commonly see patients coming with some amount of fluid retention or the fatigue, the dyspnea on exertion. So we all know that heart failure has come to a long discussed topic throughout in last 5 years as we came comfortable with use of ARNI, and we have been discussing how the 4 pillars of heart failure have helped us in taking care of our patients better. So I'll open the discussion with inviting questions from the delegates, if there is any, and I'll ask my question that how do you see NT-proBNP as one defining factor in diagnosing heart failure?
Yeah. So as I said, NT-proBNP is very good for prognostication. Although none of the trial has been able to prove that if you guide your treatment with NT-proBNP, it is the good one. But in our practice, we all know that before discharging the patient, we always try to get down NT-proBNP at least below 1500, if not 1000. That's the practice, you can say, the expert comments. But none of the trial has, like guide heart failure, wasn't positive. Regarding the diagnosis, I think for ruling out for the physician forum, this is important because you have to differentiate in the emergency in your practice whether this is related to lung or heart. If your NT-proBNP is normal and if your patient is not very obese, 99% you are able to exclude heart failure. That's number one. So I mentioned in heart failure preserved EF, the rise in NT-proBNP in non-obese patient is really important. It is not mandatory to check NT-proBNP to diagnose heart failure reduced EF. सांस फूल रहा, पैर फूल रहा और EF less than 40 is no-brainer. Just like video EEG by your neurologist friend. You don't need any further investigation. But on a scientific forum, I think NT-proBNP should be sent for all heart failure patients. Yeah. Yes. Yeah. So Dr. Atul Gupta is my mentor. He was a registrar when I was doing MD in Maulana Azad. The sequence of events nowadays, the practice is that we add all the 4 medicines together in smaller doses, because it has been shown, if you are aware, in the last few months back in circulation, whatever dose of ARNI you use, whether it is 50, 100, 200, is immaterial. It provides you the similar efficacy. Same is with MRAs, whether you use 25, 50, there's not much of difference. And of course, you have a single dose of SGLT2, and beta blockade we have to titrate. So in our practice, if they can tolerate, and only hindrance is EGFR, I start most of the drugs in OPD setting in smaller doses. In acute heart failure before discharge, usually beta blockade is on board, SGLT2 is on board. ARNI and MRA will depend on the potassium and creatine clearance level, because renal dysfunction, as I said, is very common. 30, 40, you get ESFR 20, 25. It's not mandated to start straight away. Probably will discharge them on SGLT2 and beta blockade, and in OPD we'll see how it goes.
Thank you, Dr. Pandey and the chairpersons. Now I request the chairpersons to honor our speaker and Dr. Gomber to honor our chairpersons. Before starting the next session, we are going to have a lucky draw. 2 prizes. And this. Up to the chairperson. Dr. Amardeep Sachdeva, I think he is gone. Amardeep Sachdeva. पढ़ दो साहब. राजीव दीवान. राशि, please come. ये निकालो. जल्दी कीजिए. आप ही निकाल दो. मैं निकालूं? आप निकालो. मैं निकाल. लो मैं पकड़ता हूँ सर, आप निकालो. डॉक्टर राज नागरानी नहीं है. चलो. नाम बताओ, नाम बोलो. डॉक्टर अनिल जैन. डॉक्टर अनिल जैन आ जाओ, प्राइज निकला है. लकी ड्रॉ. और निकालो. और निकालो. डॉक्टर पी के गोयल हैं. डॉक्टर पी के गोयल नहीं है. चलो नेक्स्ट. नहीं, इतना टाइम नहीं है. इतना टाइम नहीं है. मेरा ना निकल जाए. डॉक्टर ए के सुरेखा, द ग्रेट ग्रैंड ओल्ड मैन. और है? और है? डॉक्टर जी एस कोहली, आई थिंक इज गॉन. नेक्स्ट. चांस बन रहा है मेरा. नहीं नहीं. एस के मुंद्रा. ट्रेजर को क्या जरूरत है महाराज? ट्रेजर को क्या जरूरत है? चलो प्राइज. Topic of psychiatry, and the topic is very apt, especially for the doctors, and our chairperson Dr. Bhatia. Panel discussion on de-addiction. Chairperson Dr. Vishal Chavda. Aja, please come. He's a senior concerned secretary at Fortis Hospital, plus his own clinic, Dr. Vishal Chabra. Then Dr. Praveen Bhatia, very right person for de-addiction. Rajiv Arora, I think it's not there. Dr. Rajiv Arora. Dr. Karnani, Kamal Karnani is there? Please come. And the speaker is Dr. Navya Saluja. He is a consultant psychiatrist and medical officer in charge, Sakoon Hospital, Gurugram. So I request the chairperson to start the proceedings.
Hello. Good afternoon, everybody. Today we'll be talking about the addiction. Every one of us has patients of substances and we don't know what to do next. So here we will be talking in general about the addiction today. I am not going into details because it is a very complex topic to be discussed in next 10 minutes. So I'll be starting now. We'll be going through these contents. What are psychoactive substances? Prevalence, terminologies, what are substances called in North, etiological factors, classification and treatment strategies. So we all know what psychoactive substances are. Any substance that can alter our perception, mood, thinking or behavior. Any substance that can lead any changes in our physical or physiological functions. Talking about the prevalence, if you see the figures here, there are 16 crore users of alcohol in India. But however, only 2.9 crore people are dependent. So everybody who's using alcohol is not dependent, does not need treatment. And talking about cannabis, there are 3.1 crore users in India, and out of which 25 lakh people are dependent on cannabis. Talking about opioid use, there are 2.3 crore users. However, we have 28 lakh population dependent on it. There are various other drugs, but we are talking about the main today. Talking about the terminologies. What is a substance? Any drug, medication or toxin that has an abuse, that has a potential for abuse. Now talking about addiction, everybody knows what addiction is. We are not talking something new today. So addiction is is a physiological and psychological dependence on any psychoactive substance that can lead to withdrawals when we discontinue the substance. Talking about abuse, abuse is a maladaptive pattern of substance use that impairs health in broad sense. Talking about harmful use whenever we are using any psychoactive substance that can lead damage to health, that is the body of any human body that can lead to damage, that is harmful use. Talking about dependence, dependence refers to physiological and psychological phenomena induced by repetitive intake of substance. Tolerance is, supposedly today I am taking 20 ml, but I have to take 60 ml tomorrow or after 1 month to induce the same level of changes in my body that I used to get with 20 ml of alcohol. So the dose of substance increases. Talking about withdrawal state, it is the group of signs and symptoms that occur whenever the amount of the substance is reduced or we stop the substance. That can lead to any physiological or psychological phenomena of withdrawal. Talking about commonly named substances in North, this is very, very important for every one of us. Why? Because many these new generation people, they are using multiple substances and we don't know what they are called as in a common OPD. So like opioids are called as Fuki, Chitta, Afim, heroin, brown sugar, etc. Cannabis is also called as bhola, ganja, hash, hashish, charas, bhang. Stimulants like MDMA, this is the common local name of MDMA is meow, moli. Other stimulants like cocaine, methamphetamine, mephedrone, methamphetamine, and other psychoactive substances like LSD and phencyclidine. Talking about the illicit drugs, we all know alcohol, we all know nicotine. But what is more common in nicotine these days, what children are taking is vape. We don't know what amount of quantity they are consuming in the form of vape. So we need to be very well aware of substances that are present in the local market today. Talking about benzodiazepine, there are many patients who come with benzodiazepine dependence. They go to GP, they write benzodiazepine for sleep, and they keep on taking benzodiazepine. And we also know that benzodiazepine can also cause tolerance. Then eventually they become dependent on benzodiazepines also. Talking about etiological factors, I'll go through community medicine model only, the agent, host, and environment model. Substance here is an agent. It can have multiple physical factors on our body. It has, every substance has different, I would say, every substance has different factors on our body, whereas every patient is different. Why is a patient consuming substance? Could be because of the environmental causes. The most common factor we talk about is stress. It could be an environmental stress, whether you talk about school, whether you talk about office work, everybody is stressed out. Even a school-going first class kid is stressed. But we have to understand the availability of substance in the market is also making them use the substances today. So when we talk about psychiatry, yes, this is a very different field altogether, and we have different classifications for each of the drugs that we use these days. So this is the ICT classification. I don't want to go in details, but we'll talk about what happens when we take each substance. Talking about acute intoxication, we are well aware of what acute intoxication means. In every party, whichever you go, where substances are served, you'll find many people who are acutely intoxicated. So it means that any substance that can disturb the level of consciousness, cognition, perception, affect or behavior, and other psychophysiological functions and response, that is what is called as acute intoxication. So if I am taking 20 ml of alcohol and somebody else is taking 40 ml of alcohol, we'll have different responses. Maybe I am acutely intoxicated, but the other person might not be acutely intoxicated. Talking about harmful use, supposedly I know that my liver is damaged, but still I keep on continuing taking alcohol. I know I have memory losses after taking alcohol. I know that my body is harmed, but still I am taking alcohol. That means that I am a harmful user of the substance. Talking about dependence. When do we say that this person is addicted? So we need to have at least 3 out of 6 criteria when I say a patient is dependent. When I have a lot of craving for the substance, when I have increased tolerance for the substance, and if I'm not taking the substance, I'm having withdrawal symptoms. I am neglecting other parts of my life, maybe my household, my functioning, or my occupational work. I continue to take substances when I know that I'm having harmful effects of it, and I continue taking substance when I know I have problems in my relationship. Talking about withdrawal state, this is very, very important for everybody sitting around here. Most of us are treating withdrawal symptoms in the OPD, whatever the patient has been taking substance. Now where most of us are treating the uncomplicated withdrawals by benzodiazepines. But now we need to understand that these substances can also harm our life by conversion, and they can have a withdrawal state that can lead to delirium. Delirium can also be with conversions and without conversions. We are talking about epilepsy today. So anybody who's throwing a fit, it's very important that we have to manage it there and then. Let's not prolong it. Talking about delirium tremens, everybody has heard about delirium tremens. This is not something new to us. it is the most common and severe form of withdrawal of patients taking alcohol. Now talking about why I'm talking very severe form, because it can lead to around 25% is the mortality rate, and even after treating the patient, the mortality rate is 5 to 10%. So it is a very serious form of withdrawal and we have to take care of it. We need immediate hospitalization in patients with delirium tremens, and what is more important is the fluctuating orientation in the delirium tremens. Whenever there is delirium, we have read about this clouding of consciousness, so we have to be aware that the patient can also hallucinate at that point of time. Even substances can lead to psychotic disorders. We talk about delusions and hallucinations. When there is no stimuli, we are able to hear or see something, then we call it hallucinations. And delusions we know about is a false, firm, fixed belief about something that is not happening. Now talking about treatment. Why treatment is important? Because physiology of the body is disturbed and mind is also disturbed. So there is importance of treatment as well. It's not like today there is somebody who's taking alcohol and we can leave them aside कि अरे ये तो कभी ठीक होगा ही नहीं, इसको ठीक करने की ज़रूरत भी नहीं है. So we don't have to go by that idea. Today we have multiple treatment plans and we can go ahead with that. We have two different treatment plans, that is acute treatment and the long-term treatment. Talking about acute treatment, so first it's very important that we take the detailed history from the person itself and the family members. Sometimes what happens is patient is taking substances which can lead to secondary psychiatric illness, or sometimes there is psychiatric illness out of which the person is consuming substances. When I'm talking about dual diagnosis, I'm talking about alcohol plus some other psychiatric disorder. Either it could be depression, either it could be bipolar illness, or I could be talking about schizophrenia as well. Talking about triple diagnosis is substance abuse. Along with that, we have psychiatric illness, and very common that we see in our OPDs, and you also have seen, is the HIV that we have to be taking care of. That is what psychiatrists call as triple diagnosis. Talking about pharmacological treatment, first aim of a psychiatrist is to stabilize the patient. First, to stabilize the physiological symptoms. We have to treat the comorbid illnesses. Sometimes the patients are not ready to leave substances. What we can do is reduce the harm. We can reduce complications of HIV, liver disease, or some other problems happening to them, and help them maintain abstinence for a very long period of time. Talking about non-pharmacological, in psychiatry, we need other people to help us out and change the perspective of anybody who's taking substance. So we have various therapies. We have commonly heard about cognitive behavior therapy, motivation enhancement therapy, and relapse prevention therapy. It's very important that we educate the family also. What is substance abuse? Otherwise, they would never understand, and there would be no family who would be supporting their kid. It's not about leaving a person in rehab and wanting them absolutely okay after 6 months. This does not happen. So we need support from the family also, where there is a role of psychiatric social worker. They psychoeducate about the illness. They talk about expressed emotion. This is very common thing that I talk to my patients about, expressed emotions. Like we say that sugar and salt should be taken less in diabetes and hypertension, the way we express should be taken care of when we are talking to a psychiatric patient. Talking about rehabilitation, that is the long-term plan. We take rehabilitation in protected environment. That is the rehab that we are talking about for 6 months, where we help in building the life and social skills, help in increasing the socially responsible behavior, increase in maintenance of abstinence, and learn about the alternate reward mechanisms. So talking about rehabilitation in community, we ask the patient to start joining AA groups or narcotic anonymous groups. See, talking about de-addiction, this is a relapsing and remitting illness which requires a lot of challenge and requires a lot of compassion, patience, and consistency from the clinician side. So just like a patient who's coming to you with diabetes and hypertension, they would eat sweets. But do you say them, don't come to me next? No. So here, my patient will also take alcohol. So don't tell them that we won't treat you. This is an illness, we have to treat it. Talking about Sukoon, we have different centers in Gurgaon, Chhatarpur, and GK. Okay. And we just one video.
Yeah, okay.
And you can just see what we do. It's just very different from the government centers. It's more of a patient-centered approach that we follow.
Okay, I've been told to take up the
It's just
questions.
about
Thank
the
you so
center.
much. Any?
That's.
Sir,
I'm sorry, sir.
Yes. I'm sharing the stage with two eminent psychiatrists. So in today's era, besides substance, we're having Wi-Fi era, mobiles era, internet era. Is
Yes.
it comes under the category of addiction? My question is number one is this. If
Yes,
yes,
it does.
in which particular ICD category? And number three, what is the treatment for this? Dr. Vishal or Dr. Neve, anyone can give the answer.
I would say it has not still come in the ICD criteria. It is in ICD 11, and we talk about gaming and addiction in DSM 5. I guess Dr. Vishal would be the right person to.
So what we're talking about here is substance use. So this is chemical addiction. You're taking a chemical which is altering your brain, and that's why you are addicted to it and giving you a high, basically dopamine. But when you're talking about all these things, this is behavior addictions. So every time I get a notification, every time I get a like on Facebook or whatever, and I keep looking at it, I keep checking again and again, that again gives me a dopamine hit, and that's behavioral addiction. So this is behavioral addiction, which has been, this is all because they had employed psychologists, they've done a lot of research, and after that only these algorithms have been dished out to the public, and it's very, very addictive.
But in younger populations, especially adolescents, it is disturbing their normal life. That's why I'm saying. Does it come under the category of addiction?
Yes, so there is a debate going on, sir. This is called behavioral addiction, and there are clinics for the same. NIMHANS opened one clinic to take care of video game addiction. South Korea is the first country in the world where they opened 2 or 3 clinics for de-addiction from the video games. Because वहाँ बहुत खतरनाक cases हैं. There's one person who burned his thighs playing video game. He was so excited he did not realize because the laptop was so hot he burned. And another, couple lost a child because they were so busy playing a video game. So they did not feed the child properly. So such bad instances also happen.
Even the Blue Shark game was there,
Yeah.
which was stopped because of the behavior addiction.
Thank you. I know it's a big topic, but thank you. Maybe next time we can. Sir, I request RM Chawda sir, आप next time थोड़ा ज़्यादा time दे देना, so we can highlight on this. Huh? I know. Thank you. I think the amount of topics you have should have a 2-day conference, sir, not one. It's a wonderful conference. Thank you.
Thank you.
Thank you, chairpersons.
The पैसे तो लगे नहीं हैं.
Please come here. Join at the. There is some change in the program. Next topic is long COVID syndrome, and today we are having one very eminent faculty, Dr. Dhruv Chaudhary, senior pulmonologist, HOD respiratory medicine, PGIMS Rohtak, and moderator is Dr. Anand Jha, and the chairpersons are Dr. Vikas Maurya, Dr. Sanjeev Jain, Dr. Pankaj Gupta, and Dr. Aditya Chawla. I invite them all on the dais, please. Yes, sir, please.
Good afternoon. It's a fact, and I hope most are either left or are feeling little groggy. Same is the situation here because I have been traveling for so many last 3 to 4 days, and this is the 5th day in continuation. So I'm extremely grateful to Dr. Chhabra and Dr. Meglani for heeding to the request for a little prepone because I have some appointment at Rohtak, so I have to reach there by 7:30. Thank you so much. I think this is what we have been all discussing, long COVID syndrome. A lot of people must be coming to you that they're feeling tired, they're feeling weak, they're not able to concentrate, they are having a foggy brains, they can't recall. Number of people have been coming it up. And as a physicians, all of us, especially the senior people who are sitting here must be recalling, we used to call as a post-viral asthenia. Somebody is going it up for some point of time, not recovering and persisting with the low-grade fever or sometimes also extreme fatigue and tired, which later on was labeled as chronic fatigue syndrome. And also along with it another word which came up with the myalgic encephalomyelitis. So a lot of these things have happened. And also we have been seeing, because I am quite active and a part of intensive care units and critical care units, we did a study in terms of the patient who are hospitalized and how is the outcome. Then we realized at that point of time in COPD, when they ventilated discharge in 1 year, we had 70% mortality on follow-up. In ARDS also we are seeing a multiple cognitive decline. But what has happened with the COVID is that we saw such a huge number of cases that probably the quantity may be percentage, may be the same or maybe a little more. But because a huge number of patients had a COVID clinical or subclinical, that we are seeing much more absolute numbers patient coming up to us. Definitely there is no criteria, and over next 10 minutes we shall be talking about and seeing about it. When you see it here, when you see the definition, we define it as a multi-system. This is a nice National Institute for Health and Care Excellence has been in the UK, which decides how guidelines have to be followed or formed, and the NHS follows the pattern, and that's from where I have taken it up. It's a multi-system condition with a range of debilitating symptoms, signs and symptoms, continue or develop after acute COVID, continue for more than 4 weeks, and are not explained by an alternative diagnosis. Three things are required. They should be of a sufficient duration, they should be a continuity, and if they come back, they again should be stable. That's the first time the definition of it came up, but now we have a little different definition. And it obviously both ongoing symptomatic and post-COVID syndromes 12 weeks or more. So today we shall primarily be discussing and talking about a post-COVID syndrome. And here if you will see, what is the long COVID is the out one, and the post-COVID syndrome is the center one, which is the Kesariya Rang, or which is the orange color. When you look at now, this is the new definition which is accepted throughout in 2022, that persistent of symptoms in a proven COVID beyond 3 months, or development of new symptoms with persistence up to at least 2 months without an alternate explanation. Last line is when 2 words are extremely important. You need to find an alternate cause. If you are not able to find it out, and if person had a COVID and then developed it, then we will say yes, person is having a long COVID syndrome. Now epidemiology, this is the Western data which tells us about 65 million individuals. They will see, look at the burden which will be there on the primary health care or on the specialty care. When you start looking at it, there are different studies. In Scotland, they found 42% recovered at 18 months. They looked at meta-analysis again, which was done, 45% they experienced symptoms at 4 months. And then REACT-2 survey, which was done, they found that 37.7%. The UK Office of National Statistics said had persistent symptoms of 24%. Now that's what one has been seeing, what has been observing, a number of literature which is coming up from the Western world. When we started in a low-income, low-medium income countries, and recently now we had a publication in Lancet which talked about the unmet need. But the question is it, what are our status? This is one study I'm quoting which we have submitted to the Lancet, and it is under preview and available on preprint. And what we did, the prevalence of long COVID symptom and observational cross-sectional follow-up study in India, in Haryana. We found out that for us, it was the only thing which we are finding, it is the cough which has been there. Especially we took at the patients who had mild or who are seropositive for COVID, and then we looked at it up, how many symptoms are there as a part of Lancet Commission. So we have found out that cough definitely is one, but we are not percentage-wise, as the Western world is saying, we are not seeing that much of a number in the patients who are asymptomatic or minimally symptomatic, or let's say who are seropositive. So I think that is very important for us. Whereas the persons who had a severe COVID, now most of the time, like I am a respiratory physician, majority have recovered, and you are seeing a small amount of lung fibrosis, but cough continues to be a problem in these cases. When you look at it, the fatigue is the most common COVID-19 symptom after 5 weeks, obviously followed by a cough, headache, and we are seeing myalgia. And in fact, a lot of people are complaining now, and the data came on Medscape around about a week back, was the incidence of migraine after, which had never had a migraine in the past, post-COVID, have started getting it up. So there is much more than what we know actually on the neurobiology or other things, because these things are evolving. Loss of taste, etc., we have not seen, and to an extent, what we started seeing with an alpha, then later on with the delta, probably Omicron changing and alteration strains, it's not as much of a problem as was with the initial strains. Now these are the cartoon which is again showing up. Practically only thing it is telling it, A to Z, every single organ system is involved. When it happened, lungs were the primary one, followed one we looked at 20% cardiac, but later on it was turning out when we started doing a study, on an average in the acute phase we saw troponin I and troponin M going up. But later on when we looked at an NMR and we did PET-CT scans, incidence was around about 5 to 8%. 8% in our thing, which we did it at few cases. So what I am saying is everything has been involved, and gut is another area, and the neuronal and the CNS is the other one, where one is seeing number of symptoms coming. I mean, all of us are talking about increased incidence of cardiovascular events. We are also looking at it, number of people are having a persistence of diabetes, which started at that point of time. Now, when you start looking at it, the symptoms and the pathology, chest pain, palpitations are not uncommon. And what is very important is the POTS, which we're talking about, which you see it in chronic fatigue syndrome. This is basically a dysautonomia. When patient starts, suddenly they start getting tachycardia or hypotension. When you look at a patient who is lying down and when he stands up, if you find the rate has gone heart rate by 30 or there's a fall in blood pressure, think in terms of dysautonomia. And this is a postural orthostatic tachycardia syndrome that is being described and probably has been associated with some amount of increased mortality and morbidity. Lung, cough and breathlessness is there. With the dual energy we are finding it up, and along with the MR and xenon scans, that small airways, and also along with it in dual energy, probably small interstitium is involved, and probable reason is the pulmonary induced pulmonary intravascular coagulation, the small thrombotic ones, which have been responsible. And what is interesting is, I think Dr. Upadhyay will be looking into it, will be the gut dysbiosis. What we are finding is that there is an alteration of gut bacteria in it, leading on to probably increased symptoms. If the gut bacteria, there's no dysbiosis, we are not finding higher incidence of post-COVID syndrome. And CNS also, they have been found to be having a higher incidence of chemokine 11, which is responsible for causing it, which leads to forgetfulness, which can also lead to sometimes dysgeusia, but dominantly fog, mental fog, which is there, or brain fog, which we call, along with the migraine. That is what we are looking at. So practically every single organ is there, and obviously we are finding it up. There is a reduced sperm count. When we did an NMR studies which came up in COVID, they found there was a very active uptake. So practically wherever you had ACE2 receptors, or wherever you have a G receptors, which are the two areas, wherever that was there, was responsible for some amount of activation or alteration in the functionality of the cells, leading on to these problems. These are the hypothesized mechanisms for long COVID. I will not go into it. Same is the one, the fatigue is the generation is most of the time, probably it's a neuromodulation which takes place as a part of COVID. We are seeing it up. So my dear friends, the question is, who are more susceptible? If person has a higher age, person has a number of symptoms in the acute phase, multiple organ involvement, it's a multi-system disease, multi-organ involvement. So if you find number of symptoms in the acute phase, hoarseness of voice, greater body mass index, we realize in the beginning itself that those have a metabolic abnormalities or who have an apple-shaped body were higher risk of it, because there is already a state of inflammation. In the females, again, like any autoimmune disorders, we are finding a higher incidences, shortness of breath anybody had in the past, or bronchial asthma. So multiple etiologies and theories have been put up, and some of them are talking in terms of reactivation of Epstein-Barr virus. Another has been a gut dysbiosis, another is in a coagulation like antiphospholipid syndrome. So it's a whole spectrum which we are talking and discussing up here. This is a study which has been published only last week, and what they are finding it up is cumulative incidence of daily loss of work has been far high in these patients in the Western world, which are the persons who didn't have a very severe disease. This is the veteran affairs data from USA, nearly 8 to 10 times loss than the people who had not a COVID syndrome. In particular, again, there is a differential who had a severe COVID, they had much more loss versus which have not. The only thing is that we have never ever compared these things with what had happened after the flu epidemic or after other viral infections, because the numbers which have been there are overwhelming in this case. So how are you going to manage? There is no treatment. One group did talk about in terms of endocrinal, especially deficiencies of hydrocortisone or cortisol, not hydrocortisone, the cortisol, and all symptoms can fit into it. So that's why sometimes one has seen the prescriptions of steroids, also people writing it, but nevertheless, what you see is a self-management support for managing fatigue is important, cognitive behavioral therapy is important, and there is another terminology used is a pacing, that you do activity for your work. You don't want to do a physical activity going back what you were normal. So gradually you keep on changing the goalpost, and that is what we called as a post-activity malaise, which can happen. So what is important is when your patient comes, you tell them to do an activity which keeps them moving, but don't tell them to force it beyond a point, because post-exercise malaise will again come back and they may land up with the problem. I will not go into it, these are not the treatments, but rest is the impact of vaccines and variants, because vaccine is supposed to have been some protective effect. Variable results initially were there, but they say now it reduces incidence by in different series from 15 to 14%. Long COVID, again we are seeing a differences with the Omicron variant. It is much lesser. Again in this BA.1, which was the earlier variant, and it's not theory today, because we are now doing NGS and we know the variants which we are dealing with and can help us in these cases. So summarize, my dear friends, it's a definitive clinical entity. It's a multi-system, multi-organ disease. Fatigue, post-exertional myalgia, weakness and dysautonomy are the commonest clinical feature. Pathogen concepts are evolving, and we know probably either there have been an activation immune system which has not gone back, or there is a reactivation, or there probably has a reactivation through it of EB viruses, because CMV reactivation is found to be protective, and along with treatment predominantly is symptomatic, and what we need is that cognitive behavior therapy or graded physical activity is the treatment of choice. Thank you very much for patient listening.
Yeah, thank you, sir, for the nice and wonderful presentation. And we have listened to you for years, and you're always a great speaker. And
thank you.
Yeah, and we don't have a COVID, but yes, we still seeing long COVID. We don't know how long is long COVID, and I think sir has very beautifully described about what is long COVID, what are the manifestations, and what is the treatment. Yes, it's a multi-system effects, and therefore multi-system people has to be involved in the treatment of this disease. So if
Sir, it's an honor to know you as a teacher and as a person. And sir, I would like to know your experience of the post-COVID patients who are having cough, still with no significant parenchymal damage. They are having cough, the cough doesn't go away. So what to do in such patients?
You see, here again, when we look at it, these people who are persistent with the cough, the initial studies when they're talking about breathlessness having a normal CT scans, they found out in the xenon scans that there was a small airway disease. And then the dual fractional, when they started looking up, very small amount of thrombosis was there. Now cough is there, cough we need to look at it from the neurological perspective and the efferent pathway. So probably we need to modulate the neural, it's not that we keep on starting, unless if you are finding any evidences on spirometry of obstruction, or if you are finding any evidence of a reduction in it or interstitial which is not responding otherwise, answer for that is that we have to use antitussives. But if there is a more cough production, phlegm production, then you will not straight away will be using it up, and ideal would be to look at the pulmonary microbiome, what it is. If it is there, you may use small macrolide. If that doesn't work with it, probably also other things are not there, then we have to use peripheral acting antitussives, which are coming up today. And in these cases, we have, this is what we look at it, protoprozazine, which is coming up now. That is one particular thing which can be used, though not has been propagated. But this then comes up into that category of a cup hypersensitivity syndromes, post-infection. Thank you, sir. So please. You see, viral thyroiditis have been underdiagnosed, in fact. And this will, if person has been asymptomatic earlier and has been unmasked now, so probably we need to rule out thyroiditis, and it may be part and parcel of that person because of COVID. Because with the data which I have shown you here, that was of endocrine, in particular of a testicular secretions. Same thing has also been seen in the virals, post-viral. You have diadequatine thyroiditis. So the best answer on those is you get a technetium scan. If it is not picking up, they're hypothyroid, it's all likely to be thyroiditis. You see, again, I'm saying it, you look at NDTPO antibodies. If you find it up, you are not finding anything else, probably you will think in terms. And if we are looking in terms of, if thyromegaly is there, there is a mild tenderness is there, I will think a primary de novo happening per se, because most of these patients who have got a thyroiditis have some symptom at that point of time. It was not uncommon to find a thyroiditis at that point. Now, if in the men it is coming, which was not there in women, usually you tend to see it. But if it is there, I will like to appropriately treat it like any hypothyroidism I will treat.
So last question from my side, sir.
Sir.
Thank you. It was a wonderful, and you have summarized this long COVID. It's a new entity in our field. You have done a study, a lot of studies. Like we have seen, or maybe people relate, the sudden cardiac deaths are quite common. Those studies say there is no relations. You can't say this is because of this COVID or long COVID. So what was in a study? Is there any incidence of more cardiac death post-COVID?
Sir, post-COVID, when you look at the data in the first 3 to 6 months, then it has started normalizing it up. And the incidence of cardiac death has been found to be more than 3 times. And what one is seeing is that ACE2 receptors are there on the cardiac myocytes. They are on the fibroblast and endothelium. So one has seen de novo, a lot of people coming up with, so one of the major symptoms have been the pain chest in the long COVID also. So it is important for us. That's why we looked at the TROP-I and TROP-M. If it was there, it was a poor prognostic indicator. So it answers partly your question. The question is whether there is having an in situ thrombosis leading on to obstruction like an acute myocardial infarction. Not an uncommon entity, which has again incidence has been found up to 6 months. But some studies say that probably even up to 18 months, that it has been stayed high. I give you an example quickly. One of our senior colleagues, post-COVID, he had a bad COVID, he recovered, he was doing, he had some symptoms, he had mild asthma. He got himself found to have a coronary artery disease because he was having an angina post that. He thought that my activity will not be good if I'm suffering it, went for the surgery, landed with the mess, fortunately survived. So that's why the data came up that even the surgeries in these patients that we have to do, if it's not emergency, by at least by minimum 3 months, preferably elective surgery. That means tissue takes time to heal. So in this, there is an endothelial damage, there is a myocyte damage, and there is a fibroblast. That's why there is a higher incidence in these patients of your not only coronaries, but atrial fibrillation and arrhythmias also. And that is where dysautonomia, when sympathetics get involved in it, when they are having it up, you're finding postural orthostatic tachycardia syndromes. So I hope it answers your question.
Yes, yes, absolutely.
So and another, sometimes कई लोग शेर बनने की कोशिश कर रहे थे, इसके बाद we are trying to tell them go slowly, and the one who did it more, they suffered the more.
Thank you, sir. Thank you. I think.
Also post syndrome, and any treatment modality has helped.
You see, post vaccination, what we saw much more with the challenges, spots I won't say so, we saw demyelination, we also saw thrombosis happening post, especially your AstraZeneca one. because that data we have it. I was a part of the adverse advisory committee, so we were seeing a much more number of people, young nurses or the A&M workers had a shot of Covishield, and one day, 3 days landing up with this. What I have not seen as such, but as such, if you see it, any person who is a viral illness, if they're not adequately hydrated, suddenly when they get up, they start getting little dizzy and blackout start feeling. That's what we always tell them. So whether it is unique to it or whether it is another, because no comparison head-to-head has been done. But nevertheless, it has been observed, it has been there. We have seen a couple of cases, not too many.
Thank you, sir. Thank you. I think we should end this
Thank you.
session now.
Thank you, sir, for wonderful discussion. I invite the chairpersons to join us for the dance. So our next session will be, is robotic surgery justified for oncology? And for this, we have an eminent speaker, Dr. Himanshu Shukla, Senior Consultant, Department of Surgical Oncology and Robotic Surgery, Max BLK Hospital and Max Hospital, Shalimar Bagh. The chairpersons are Dr. R.K. Jain, Dr. Pratik Varshney, Dr. Ashok Pansari, Dr. Avinash Rai. I invite them all on the stage, please.
I like to thank Dr. Chawla sir for providing me the only surgical topic in this academic feast. So my topic is robotic surgery justified in field of oncology? So it is a novel technology in minimally invasive surgery which is becoming more and more popular in today's scenario. It is an evolution of minimally invasive surgery that combines with medical science, robotics and engineering. It helps the surgeons to operate in inaccessible area of the human body with ease and comfort. So it is used in main benefit of robotics is minimal and hidden scar, reduced blood loss, early recovery, minimum wound related complication and reduced hospital stay. And it is a kind of master slave manipulators. So I want to just show what the robotics is. So we have three components of robotics. One is a robotic arm which stands at the patient. The other is vision card with electrosurgical units. And the third one is master console. The surgeon sits in master console. He moves the joysticks. The same movements are repeated at the patient card site. So the main robotic systems that are in use in today is the one, Da Vinci surgical system that you have seen earlier. The other is Vercius. The third is Hugo Ras. This system is mainly used in head and neck surgeries. Then third is Zeus. It is used in neurosurgery. And the third one is the Indian-made robotics, that is SS Mantra robot. So there are some newer surgical system also. I'll just show a small video. It is a Chinese robot that is being developed. It has a single port with a better articulation and manipulation, and it helps the surgeon to work in a very tightened anatomical area, like in narrow pelvis. We can manipulate the instrument, we can do suturing with very much of ease. So this is another newer system, single port Da Vinci system. It has a serpentine like 4 arms, 1 camera and 3 arms, with which we can do the surgery with much of ease. So we are fortunate to see the 3 eras of modern surgery, from open, then lab and to the robotics. These are the practical advantage of robotic surgery, especially to the surgeon. The intuitive hand-wrist movements, 3D HD vision, endo-wrist instrumentation, and dual console capability. Dual console capability has a very good advantage in teaching purposes. So these are the few more advantages of robotics. You have simulator, firefly imaging, single port site, and with the advanced instrumentation, the suturing and the stapling devices, the surgery becomes much easier. So this is a just evolution of minimally invasive surgery from traditional laparoscopy to the advanced robotics. So these are the key advantages we have already discussed. I'm not going to detail. That what I was discussing, the dual console. So we have two console, the trainee console and the trainer console. So on trainee console, the trainee surgeon, he used to operate at any time of point. If you feel that he is going wrong, with single tap you can take the control to your side. There will be no damage to the patient side. While in traditional laparoscopy, you have to take the camera, you have to take the instrument, that there is a time lapse while controlling. But in this, just single tap and the control is yours. So now I'll discuss region-wise robotic surgery. So in head neck cancer especially, for oropharynx, hypopharynx, we do transoral robotic surgery, and there is a increasing popularity of neck dissection and thyroid surgery in present scenario. So if we see the MRI of this image, this patient traditionally goes to chemoradiation. But with the help of robotic surgery, now these patients are also converted to the surgery followed by risk-based radiotherapy. So if we go for just retrospective, for this cancer, we need to cut the jaw, split the lip, split the tongue, then go back to the base tongue to do the surgery. The final picture will be like this. And the complication rate in such type of defacing surgery, degloving surgery is almost 50%. That's why surgeons used to defer from surgery and the chemoradiation took place. But with the advent of this robotic system, now the surgical system has again come into the play, and we are doing more of oropharyngeal and hypopharyngeal cancers with much of ease. So transoral robotic surgery got FDA approval in 2009, and various studies have shown that transoral laser microsurgery as well as transoral robotic surgery, they have excellent oncological outcomes. And this changes the paradigm from chemoradiation era to surgical. If we discuss in the terms of duration of the treatment, the TORS requires only 3 days of hospitalization, while chemoradiation takes 50 days of treatment. So the cost is much higher in cases of chemoradiation than in transoral robotic surgery. But yes, if you discuss in a short-term basis, the cost of transoral robotic surgery is a bit higher. But if you take whole treatment in sequence, the cost of robotic surgery is too less. And if we discuss, especially in Indian population, the P16 negative oropharyngeal cancers are much common, and the radiation effect of the radiation for P16 negative oropharyngeal cancer is not too good. So this is a study that is published, and it concludes that P16 negative oropharyngeal cancers, primary surgery has a better long-term survival and dysphagia-related complications. So if we go for guidelines, these are guidelines for especially P16 positive. The chemoradiation as well as the surgical options, they have same category of recommendation. And even for the locally advanced oropharyngeal cancers, T3, T4 tumors, the level of recommendation for surgery as well as radiation are the same. So current treatment for oropharyngeal cancers, HPV status does not change the management. For loco-regional advanced oropharyngeal cancers, transoral robotic surgery followed by risk-based radiotherapy as well as concurrent chemoradiation has same level of evidence. For early stage, single modality is preferred. For early stage oropharyngeal cancers, transoral robotic surgery or radiotherapy, they have same level of recommendation. So this is a meta-analysis which compares chemoradiation and transoral robotic surgery. This meta-analysis shows that in long-term survival, in terms of oncological safety, the transoral robotic surgery as well as chemoradiation has the same equal functional outcome as well as overall survival. So this becomes totally, the transoral robotic surgery becomes totally non-inferior. We have level 1 evidence for this. If we discuss the cost, we don't have much of Indian data, but in Western population, the cost of transoral robotic surgery is 18%, while the chemo radiation is 24%, and we combined surgery plus radiotherapy, the cost becomes much higher. But the side effects are much less with transoral robotic surgery than the chemo radiation. You can see with this chart, the surgery has the range has $22,000 to $50,000, which is a lower limit for chemo radiation. So surgery, if we go for early for oropharyngeal cancers and do surgery alone, the cost is much less. These are few studies that are quoting that it is cost-effective treatment. So we have also published our data on stage 1 and 2 of HPV negative oropharyngeal cancers that are treated with transoral robotic surgery, that shows an excellent 5-year overall survival to the tune of 92%, as well as in the locally advanced stage 3, stage 4 HPV negative cancers, that remains to the tune of 75 to 80%. So in nutshell, it is well proven that transoral robotic surgery is better treatment for early stage oropharyngeal cancers, especially in HPV negative oropharyngeal cancers. It is almost equally effective in advanced oropharynx with adjuvant treatment with significant morbidity. However, we lack level 1 data, hence well-planned trials are required. So for thyroid, it is a newer modality gaining popularity across the globe because of hidden scar. The current indication for this robotic thyroidectomy are differentiated thyroid cancer less than 2 cm with N0 neck, nodule size less than 5 cm, total thyroid of 7 cm, and tirage 2 to 5 lesions. These are usually treated with robotic thyroidectomy. So if we discuss the approach, we can do it with retroauricular approach. The scar is hidden in hairline. The second is bilateral breast axillo approach. The third is transoral robotic approach, and the fourth is rabbit approach. The scars in these cases are hidden, so especially for female patients who doesn't want a scar in her neck, we can use these techniques. So safety and feasibility has been established in many studies. However, long-term oncological data is limited. The main advantage is better cosmesis, less bleeding, better identification of recurrent and superior laryngeal nerves. The disadvantage is a longer operative time, higher cost, as well as the limited oncological safety data. So you can appreciate the open thyroidectomy scar and the robotic thyroidectomy. There is no visible scar in the neck. Especially for females, it matters a lot. So if we talk of the evidence, there are multiple studies that are retrospective or prospective single center studies talking about feasibility and safety, but we lack level 1 data. The second is a neck dissection. So this is also a newer modality, very limited data is there. The main advantage is better cosmesis, less shoulder dysfunction. Both sides can be done with similar instruments. The main indication are early oral cavity and oropharyngeal cancers with N0 or N1 neck. The disadvantage is the longer operative time and higher cost. So you can see this is a conventional scar on the open thyroid, open neck dissection. The trifurcate incision as well as the long skin crease incision. But with robotic, there are only two scars in the axilla, hidden scar, and 2 scars on the nipple. So the cosmesis is much better. There is reduced chances of shoulder dysfunction as well as the hyperparesthesia. So this is a short video, but with lack of time, I don't go into the detail. And if we discuss evidence, meta-analysis shows that the results are same with open or robotic neck dissection. So we also publish our data. It is in oral and maxillofacial surgery, with that defines that it is a better modality for this condition. Then GI surgery, we are doing all of the GI surgeries are being done with robotics with much of ease and less of side effect. Data also favors, there is no level 1 data, but the prospective data shows the safety and feasibility as well as the outcomes are the same. These are multiple studies that are talking about that better sexual function and better reproductive functions. In gynec oncology also we are using endometrial cancer, cervical cancer, and very early stage 1 ovarian malignancy. The robotic staging is being done, and The better lymph node yield and autonomic nerve preservation causes better urinary and sexual function. So also for this also we have a multiple studies. This is a guideline of HISTRO that shows that minimally invasive surgery should be preferred surgical approach in high risk endometrial carcinomas. So with the lack of time, I'll not go into detail. This is in nutshell, the minimally invasive surgery is and surgical innovation are required. These are in need of are for better quality of life. Proper case selection is a key component for better results in oncology. Proper surgical training in minimally invasive surgery is necessary, especially in oncology. Judicious use of robotic surgery is required in era of personalized medicine. One size fits all, this approach is wrong. More well-planned randomized control trials are warranted for long-term safety and oncological outcomes. So, thank you, sir.
Thank you. Thank you, Dr. Himanshu. Wonderful presentation. Only one question.
Yes, sir.
In cases where the laparoscopic surgery can be done, do you still prefer robotic surgery? Because looking at the cost, too exorbitant a cost.
So, with the competition in markets, the cost is going down. Definitely, the laparoscopic surgery versus robotic surgery, that the cost is basically depends on number of instruments. One instrument costs 30,000. So, if we are using 3 instruments, the cost is 1 lakh more. But in pelvic surgery, it is proven the autonomic nerve preservation is much better with robotic surgery than the laparoscopic surgery. The lymph node yield, especially for endometrial cancer, for rectal cancer, that are much better with robotics. It is well proven. However, long-term oncological data are required for this confirmation.
Thank you, sir. Thank you very much.
Any different complications of robotic surgery?
Complications are same as laparoscopic surgery. But when you train, you become trained, initially your threshold for conversion to open will be less. But as much as you gain experience, the threshold for converting to open becomes less. Initially, when we started our robotic program, the conversion rate was roughly 25 to 30%, and now it is less than 5%. So as you gain experience, the conversion to open becomes less.
Any questions from the audience?
Thank you, thank you. Video दिखाया नहीं सर, मैं काम कर.
Thank you, speaker and the chairpersons. Dr. R.K. Jain, to honor please the speaker, being a surgeon. Jyotika Sharma sir and Dr. Raj Gupta to honor the chairpersons. Chairperson. Yes, crosswise because, sir. To honor Dr. Sujita. She is the medical superintendent of Jaipur Golden Hospital. Now, Dr. Rajesh Upadhyay, one of the founder gastroenterologist in Jaipur Golden Hospital. And Dr. Professor Ram Babu. And we have to honor Rajiv Gupta and Dr. Ram Babu. They are the judges for the e-poster. Dr. Rakesh Sood is gone for the emergency. So Dr. Rajiv Gupta and Dr. Ram Babu to be honored by Dr. Atul Gupta. Next, there is a penultimate, one more. Challenges in management of superficial fungal infection, fight against second infection. The speaker is Rahul Arora. He is a senior dermatologist at Max Hospital, Shalimar Bagh. Dr. Vijay Arora. Dr. Rupak Wadhwa. He is a senior consultant in medicine at Fortis Hospital. Dr. Manoj Agrawal. We worked together for a very long period in Max Hospital, Pithampur and Shalimar Bagh. And Dr. V.K. Singh. Dr. V.K. Singh? Yes, sir. He is a senior consultant physician practicing in Rohini. So, chairpersons to start the proceedings.
Good evening. I'm Dr. Rahul Arora, Senior Consultant at Max Hospital, Shalimar Bagh. But today, I'm also a proud son of a proud father, as I'll be presenting for the first time in front of him. And I would like to thank NDPF for giving me this opportunity today. So, I'll be speaking about challenges in patients with fungal skin infections. There used to be a time when we used to see this beautiful little patch on skin and we used to say, yeah, tinea aa gaya, good. Kuch nahi karna, ek antifungal dena, gone. But nowadays we see a different scenario altogether. I'm sure everybody in their OPDs will be seeing cases which are beyond one area, beyond easy management, and that is where we face the challenges. So we need to go back to the basics and understand where we went wrong. So fungus is a parasite. It's a saprophytic organism. They have been classified, as we used to study in microbiology, into yeast, molds, and dimorphic fungi. And in clinical practice, we see mostly superficial mycosis in OPDs, which involves skin, hair, nail, and depending upon that, we have classified various forms of infections of this fungus. So mainly we see two types of infections, which are dermatophytes and the yeast, and they are basically caused by the trichophyton species, and yeast are caused by the Candida and the Malassezia species. They are very common, and we keep on seeing them in our practices, and they are more common altogether because of more immunosuppression due to diabetes and HIVs. So coming to the dermatophytes, which is the most common form, it is these are the organisms which rely on superficial keratin, and they affect wherever there may be keratin, like nails, hair, skin, and these are the common species we used to study in our MBBS days also. And they can spread directly by contact, through people, through animals, and even through soil and fomites. Various risk factors include the climatic condition, unhygienic conditions, tight clothing, immunocompromisations, and these are the various forms of infections which we see commonly, like tinea pedis, which is a very superficial infection involving the interdigital toe, and common in athletes and people who wear footwear a lot, like office goers. And it is common in diabetic patients also, or tinea manum, which is the infection of the hand, and usually seen in more dominant hand and people who frequently wash their hands and keep the hand wet. Tinea barbi, which can be easily confused with the superficial folliculitis, is usually more itchy and more inflammatory, and is commonly in patients who go out for the shaving in barber salons. And it is a superficial infection mainly involving face and neck area. And the run-of-the-mill tinea cruris, which is jock itch, which is very common in hot and humid environment like Delhi. And you do get patients, presenting with annular lesions which are very itchy and have a lot of pustules in it. And tinea corporis, similar involvement, involving anywhere on the body, and it is the most common form of fungal infection which we see in our practice. Tinea capitis is very common in low socioeconomic strata, especially in children, and there are various presentations. There can be only just scaly patches which looks like a dandruff, and child may just come with a persistent dandruff, or may present with hair loss, which many times are misdiagnosed as alopecia areata, or continuous persistent boggy swelling, which is the Kirion type of tinea capitis. And this is an emergency because the kind of inflammation which is going on may lead to a scarring alopecia, which is kind of irreversible, and a mix of secondary infection amongst this. And this is coming up even in our society because of a lot of overcrowding, and people, a lot of children going together in school and buses and all together. So it can spread through hair brushes, combs, and through infected hair into the whole family also. And fungal infection of the yeast, there is cutaneous candidiasis, which is very common in diabetic patients. It usually presents like a sheet of erythema with a lot of maceration, itching, and pustulations, and it can involve oral cavity and lead to oral thrush, or may involve the genital area, which may lead to candidal pyelonoposthitis or vulvovaginal candidiasis, which is very common, especially in diabetic patients who are very uncontrolled. Similarly, patches of different colors, like versicolor, which may present like asymptomatic light-colored or dark-colored patches. These are not so troublesome to the patients, but do come as a cosmetic concern, and they are basically fungal infections rather than vitiligo or hyperpigmentation as perceived many times. And onychomycosis deserves a separate discussion in itself. It is a most underrated form of infection because the patients usually are asymptomatic and the infection keeps on harboring in various nails. It may be single nail or multiple nail, and it is to be recognized because it is a very common source of tinea infections to the patient itself as well as to other people in the family. And it typically presents like a small discoloration of the nail plate, or there is a breakage of the nail plate called onycholysis, and there is a lot of debris called the subungual hyperkeratosis, and these are the typical features of onychomycosis. It accounts actually for 1/3 of the infection, but it is still underrated, and it's caused by the trichophyton species. It is more common in males, and its incidence is definitely increasing, and more of toenails are affected than fingernails. The risk factors are trauma, poor hygiene, ill-fitting shoes, and diabetes, HIV, and presence of tinea infection in the foot also. The diagnosis used to be always very straightforward. It used to be a clinical diagnosis, and we hardly used to get any tests done, like simple cuvette scraping. In practice, we usually never used to get done. But the problem is that we don't get such kind of things in our practice now. There has to be a marriage between expectation and a reality. And in reality check, we are seeing a lot of challenges. Reason being, this simple form of tinea is less than 5%. More or less, we are seeing more of atypical infections, which are very huge in size. There are presence of these rings. These are called the imbricata rings. This is due to both infection of tinea concentricum type of species, which is very resistant to treatment, or repeated use of steroids and improper use of antifungals. Also, we are seeing unexpected shapes, like this young man was very happy about a heart-shaped tinea on his chest, or we are seeing different areas involvement, multiple body area involvement. We are seeing a lot of pediatric infections also, as young as 2-month child getting infected with tinea in various cosmetically significant sites. And not only the source is usually somebody in the family, as naive infections in children are very, very less common. And the problem becomes they are more resistant, and the proper dosages of medicines are difficult to give in such young children, as they do not respond only to the topical therapy. Tinea incognito is also very common, like this young man who was very happy about becoming fair and fair after applying Betnovate and wasn't realizing that there is a tinea ongoing on his face. But and similarly, the tinea presenting like eczema and different scenarios, it is very difficult to diagnose, and this is where nowadays cuvette scraping is becoming more important. Steroid-induced atrophy due to extensive use of topical steroids leading to stria, and these are all irreversible changes, not only in terms of cosmesis, also in terms of the kind of irritation and itching, persistent burning sensation which it leaves behind. Not only a recurrent form of tinea, which is an understatement. Not only that, nowadays a lot of mix and match of presentations of tinea is there, like seborrheic dermatitis like tinea, or an SLE like malar rash like tinea, or just something which was very typically clinically psoriasis, but is actually a tinea on fungal infection, or a nodulo-ulcerative lesions, which we used to make us think of cutaneous tuberculosis and all, are actually coming up as tinea. And something which we never used to imagine, that in erythroderma list we have to add now tinea also, which used to be only like psoriasis or atopic eczemas. So all these changes are coming up, and that is where we are facing challenges. And the biggest challenge is that it has become more chronic and more recurrent. So chronicity is when it is occurring, persisting for more than 6 months, and recurrence is that just after a few weeks of stopping the treatment, the patient is coming back with all the infection altogether. So there is a lot of research being going on why there is chronicity, and there have been various factors, just like host, agent, environmental, something like PSM stuff, which we are always aware of. Things which have been blamed are urbanization, overcrowding, poverty, poor compliance, immunosuppression, but these have been there for ages, always. So what has changed over few years, 5 to 6 years, that the face of tinea has changed? And what is believed is that there is a change in the agent, as well as indiscriminate use of topical steroids, improper dosages, as well as improper pharmacological combinations, and poor quality control of medications nowadays, which are being used in the practice. There are a lot of unchecked availability of irrational corticosteroid antifungal combinations which are sold over the counter in India, and they are prompted as fairness creams or anti-itch creams or simple antifungal creams, displayed in the front right at a chemist shop, and the person goes and straight away a 80 rupee tube is given, and that is how the tinea is changing its face. And of course, we all are facing this endemic of influencers, and they come with all these unnecessary questions and regarding, how Betnovate kaise gora kar sakta hai, and we all are getting, pestered by this. So what does this topical steroid do? It alleviates the itching and redness, but does not eliminate the fungus from the skin. It also leads to local immunosuppression. After some time, there is spread of lesion after the initial symptom relief, and when it comes back in a modified form because the overall immune system there is modified. So it can come as a dermatitic patch or even a rosacea-like or psoriasiform patch, and this contributes to treatment failure and further promotes the antifungal resistance. And locally, if you see immunopathologically, there is alteration in Th1 and Th2 responses. There is a disruption of the skin barrier due to steroid-induced atrophy, due to which, again, the fungus is able to penetrate more, and this leads to further resistance. So we are seeing a lot of these, infections due to these creams repeatedly, coming and going, and leading to further extensive tinea infections. And I know we have all used these kind of creams which are containing combination of antifungals and with steroids, with antibacterial, but these are not antifungal creams, and the steroid component of it is actually harming the patient. There has been a study in which these steroid modified, these use of these topical steroid combinations have been evaluated, and that has led to overall increase in the incidence of resistant infections. In fact, in the study, most commonly used salt in the topical medication was clobetasol propionate, which is very common in this like Lobate GM, Clob GM, and we have been using it for years. But if we just look at the steroid potency British guidelines, clobetasol comes as the most potent form of steroid, and even the beclomethasone comes as a very potent form of steroid. So most of the guidelines these days recommend avoiding the use of antifungal even for say one day, because it may promote habituation of the patient and he may not come back to you because of the immediate relief, but keep on applying the steroid creams. There has been change in the agent also, where there is more of a mentegrophyte, there is a host change, environmental change, there is a lot of drug resistance which is there, but truly speaking we are seeing more of a clinical resistance, that is the patient is coming again and again with the same infection. And a lot has been implicated because of the medication factors, and there has to be a role of the pharma companies also. There are more than 500 types of itraconazoles which are available, and there is hardly any drug check which is there. This was a study done to check actually the quality of the drug, which is the drug of choice for fungal infections. And on the left side, this is the originator molecule, the Sporonox. When this was studied compared with other molecules, there was a lot of powders and dummy pellets in many of the formulations, which led to decrease in actual efficacy of the molecule. So we should rely on good quality products which are, may not be as expensive, like something like Itrasys. It comes in a 10 rupee capsule and may have similar quality and efficacy as compared to Sporonox. So, but we need to rely on good quality antifungal medications. I'll skip this part because of paucity of time. So the management remains, the naive infections may respond to only topical therapy, but oral antifungal is mostly indicated in almost all indications now, and the topically all molecules work almost equally if they are not containing steroids, but orally, yes, itraconazole remains the drug of choice. This is the ideal the recommendations of dosages, but this is not the rosy picture. In today's scenario, we are seeing a lot of recalcitrance, and the guidelines are actually still not clear on what should be the right dosage and what should be the right duration. But mostly we are using oral antifungals almost in every patient, apart from the counseling and lifestyle changes which we are recommending. Oral itraconazole remains the drug of choice. It requires a higher dosage than the 100 milligram once a day. Even my recommendation is 100 milligram twice in a day, which is able to take care of most of the patients. and combination of oral antifungals, like we are seeing a lot of prescriptions of itraconazole with terbinafine, terbinafine with fluconazole, or itraconazole with fluconazole. These are all irrational and will just promote drug resistance. And all the topicals are almost equal. There is not much of a difference. Some work faster, some work slowly, but almost they are equal. Cutaneous candidiasis is very easy to treat. It responds to the antifungal therapies easily, but there are some discussions which are there, like more and more coming of Candida glabrata, which is more difficult to treat and more resistant to oral antifungals. Diabetes, just last topic, diabetes and fungal infections are concomitant, and hyperglycemia, hyperglycosuria, and altered immunity predisposes the patient to fungal infections. And there are recurrent genital candidiasis has been implicated with the use of SGLT2 inhibitors. These are very recent onset molecules which are very effective in controlling the overall blood glucose level. And but there is a significant glycosuria associated with it, and increased risk of genital mycotic infections are there. In fact, in various studies, it has been seen that there is 4 to 8 times increased risk of genital mycotic infections on patients taking SGLT2 inhibitors. In fact, in 2015, there was a US FDA warning regarding this also, and there have been reports of severe candidemia, endophthalmitis, and fungal endocarditis with the use of SGLT2 inhibitors. So should that be stopped in a patient who is getting fungal infections, where the guidelines still say no, and only addition of antifungal treatment is required? And most of these infections are more common in the first year of the therapy, and they usually gradually decrease over a period of time. Postmenopausal women, uncircumcised men with diabetes, patient with high risk like genitourinary abnormalities like prostatomegaly or obstructive pelvis, and in any female patient postmenopausal who has severe and recurrent infection, in those patients it should be avoided. Counseling regarding how to wash the perineal hygiene in any patient who is taking care of SGLT2 inhibitor is there, and there are some reports of that DPP4 inhibitors in combination with SGLT2 does decrease the risk of infections in these patients. So just to summarize, the fungal infections are on rise, and I think there is a need of a national health program regarding awareness of the use of steroids in fungal infection, and more information and education should be propagated regarding the same. Thank you.
Thank you, Dr. Rahul, for such a nice presentation. Definitely, we don't need further discussion in this, and Dr. Rahul has already covered everything. And definitely, we need to have a more controlled use of steroid applications and the immunosuppressive therapy that can provide a protection from the fungal infections. Thank you, Dr.
Thank you, sir.
The duration of antifungal in these cases of post-SGLT2 inhibitor induced genital mycotic infection.
So the recommendation remains the same, 2 to 4 weeks of use of oral antifungal, which may be as good as an azole.
So can we restart if it's the first time infection? Can we restart after 2 to 4 weeks?
Whenever the patient has
inhibitor.
infection, the recommendations are to stop the SGLT2 inhibitor temporarily till the infection is there, promote local hygiene, and start on the oral antifungal treatment for 2 to 4 weeks for candidiasis.
And what are your recommendations for hygiene? Is it wash only with the plain water or wash with the soap and like that? Any
Preferably
specific?
wash with soap water, gentle soap water, but at least wash with the simple water. It's the accumulation of urine which is predisposing the hyperglycemia local, which is predisposing for fungal infection.
Okay. Any studies on SGLT2 inhibitor used in like patients those who have already done circumcision in the past and
Yes, there have been studies, sir, in patients in which it was evaluated between circumcised and uncircumcised patient, and the odds ratio of risk was much more in a patient who were uncircumcised. So circumcision does in circumcised male, the risk was as equivalent as normal population of fungal infection.
Thank you, Dr. Rahul, for such a nice discussion presentation. I'll request the chairperson from Dr. Rahul. Please come to my right side. So now our next topic is which PPI is preferred in many available PPIs. We have now lots of PPIs. Which one should be preferred? And for this, we have none other than Dr. Rajesh Upadhyay. He doesn't need any introduction. One of the senior most physician, our past president of API, and presently he is with Max Hospital, Shalimar Bagh as Senior Director and Head, Department of Gastroenterology and Hepatology, Dr. Rajesh Upadhyay. And the chairpersons for the session are Dr. Nanak Wadhwani, Dr. A.K. Kaushik, Dr. Sandeep Miglani, Dr. Ankit Gupta. I request them all to please come to the dais, please. और कौन है? Dr. Anil Gombar, please come to the dais.
Yes, sir, please. Continue.
Shall I go ahead?
Yes.
Okay. Good afternoon, everyone. The hazards of having a talk at 5 or 6 o'clock in the evening when everybody is tired and I don't know what is happening to the Asian Cup final of cricket, so probably there will be another distraction. But anyway, I think what I'm talking about is a very important topic. A drug which is used by one and all branches, be it physicians, gastroenterologists, surgeon, gynecologist, ortho, everybody uses PPIs. So, and there is a whole array of PPIs which is available, and sometimes it is very difficult to say which one to choose, when to choose, how long to give it for, and that's the topic I'm talking about. Now, dyspepsia can be distressing for the patient, and it can be very difficult to treat for the doctor. But what I am showing you is the bright side of dyspepsia. Look at this slide. This is a slide from 2018, and what it says clearly is the dyspeptic Indian is contributing to a large extent for the industrial growth of this country. And if you look at the figures there, this is 2018-19, 2.5 percentage points for digestive enzyme and antacids, much more than electricity, cement, sugar. So let's look at the bright side of it. And now let's move to the serious side. It is certainly a very effective drug, very commonly used worldwide. And if you look at the predictions, something around $3.6 billion is what the market size is worth. Indian market of PPIs is about 10,000 crores. So you can imagine we are dealing with a drug which is a hugely popular and selling to a large extent, so no wonder you will find all companies coming into manufacturing of PPIs. But over the last 7 to 8 years, there has been a lot of concerns raised about the side effects. So what are the safety aspects of long-term PPI use? What are the complications which we can encounter? And I think by now we are all aware that PPIs can lead to increase in C. difficile infection, pneumonia. PPIs association with dementia is well known. PPIs and cardiovascular risk is well known. PPIs and kidney disease has become a scare to some extent. PPI and micronutrient deficiency, deficiency of calcium, magnesium, B12 are all very well known now. And PPIs and hip fractures, loss in mineral density of the bones, etc., is all which caused a lot of scare. And I think this is 2021. We actually thought that it's important to reduce the scare and actually analyze the details of the studies which are reporting these side effects. This article I published in JAPI, and it says PPIs and safety concerns, a pending verdict. So lots of things have been published, but you cannot say that it definitely causes. And therefore, it's almost a condition of charged but not yet guilty. So I think that is something which we have to remember. But certainly it points out to one thing. We have to have a judicious use of this drug. So what does judicious use mean? Well, using the appropriate PPI for the appropriate indication, for the appropriate duration. We must be aware about the drug interactions, and we must be aware about the adverse events. Now, the first PPI to come out was omeprazole, and therefore the potency of all the PPIs have always been compared against omeprazole. And this is the potency of PPIs based on omeprazole equivalent. So, as you can see on the right-hand side, rabiprazole and esomeprazole are much more potent than omeprazole. So rabiprazole and esomeprazole 1.8 times or 1.6 times more potent than omeprazole, whereas lansoprazole and pantoprazole are less potent. Then we talk about how quickly they act. So peak time of action. And there you see that omeprazole has the quickest onset of action, within half an hour to 1 hour. On the other hand, the rest of the PPIs are all about 1.5 to 2 hours, the onset of action. But then again, you can argue, why are we worried about the onset of action? We're not trying for immediate relief to the patient by giving PPIs. Then other issue is, what about the cost? And therefore, this should also be considered. And as you can see over here, well, the cheapest is still the omeprazole. And these are Indian prices, by the way, the minimum and the maximum. Rabiprazole, again cheaper, and then followed by esomeprazole and the others. Now, this is a knowledge from 1970. pH of 4 in the stomach is a critical threshold for gastric pepsin activity, and therefore the drugs, they've always studied to see for how long they could increase the pH of the stomach more than 4. And in this, the intragastric pH control data, if you look, esomeprazole certainly surpasses all the other. It is better than the others for gastric pH control. And there is at least a 20 to 40% advantage when you compare to that. But this is a very interesting data. This is day 1 of different PPIs and day 5 of the different PPIs. And you can see right in the beginning, this is pantoprazole. So the acid reduction by pantoprazole is very low on day 1, but by day 5 they all appear to have a similar level. And we are going to give these drugs for a long period of time, or at least for a 4 to 6 to 8 weeks. So I think this acid control, does it really matter? And therefore the question arose, is more acid suppression better? And therefore we needed to look at the clinical effects rather than the acid control. Now, another very important issue is the issue of drug interaction. PPIs are extensively metabolized in the liver via cytochromes, P450, CYP2C19, and so on and so forth. And this is inhibited by omeprazole, which is, this enzyme is required for activation of several drugs, including clopidogrel. So this is the reason why omeprazole interacts with clopidogrel and reduces the efficacy of clopidogrel. Omeprazole interaction with common drugs like warfarin, phenytoin, benzodiazepines is all very well known. Interaction with heart reduced protease inhibitor activity is noted. But the least drug interaction occurs with rabiprazole, followed by pantoprazole. Now, why does this happen? Because rabiprazole is not metabolized through the CYP2C19 pathway. Therefore, it escapes that pathway and hence has very little interaction. And this paper was very important. This, what they showed, that there is a polymorphism, and about 20% of the Indians may be rapid metabolizers of PPI and therefore not respond to standard doses of PPI. And in such patients, therefore, either you require a drug which does not go through the CYP2C19 pathway, which is rabiprazole, and to a lesser extent the pantoprazole, but other drugs you may need to have higher dosages. So let us now look at the clinical aspects. If we try and summarize the RCTs which are there comparing PPIs for GERD, which is one of the commonest conditions we use it for, there is not a single study which compares all the PPIs. So there are studies with one PPI versus the other and so on and so forth. And therefore the way to look at it is to, is what I have done over here. 26 RCTs and large number of patients which were used for treatment of GERD. Now, the summary would be esomeprazole, pantoprazole and rabiprazole are all comparable in improving symptoms at 4 weeks. And they are superior to omeprazole. So these three are better than omeprazole. What about endoscopic healing? Endoscopic healing in GERD is comparable in esomeprazole and rabiprazole and superior to omeprazole. So when you come to the question of which PPI, all PPIs have similar symptom relief and lesion healing rate. Similar, maybe less with omeprazole, little higher with the others. Choice of PPI in GERD may therefore be individualized for patients who are taking multiple medications. Prefer drugs which have least drug interactions such as rabiprazole and pantoprazole. Now, for patients who are not very compliant, because you are supposed to take the drug 30 to 60 minutes before breakfast. So large number of our patients are not complying to this. For poorly compliant patients and those with nocturnal symptoms, consider dexlansoprazole. Now dexlansoprazole does not require that you need to give it empty stomach, you can give it after food also. And they have a dual release system where part of the drug is released later on in the intestine and therefore have a nocturnal effect as well. Now, how long? You give it in GERD for 4 to 8 weeks. If they do not respond, you double up the dose, you optimize, and cessation of therapy in 8 to 12 weeks. So when to stop therapy is very important if we want to make sure that we are not misusing PPIs. But if a patient has got severe degrees of esophagitis or Barrett's esophagus, then you clearly carry on as maintenance therapy. More than one switch of PPI, which means sometimes you use a PPI and if patients, do I have 1 minute more? Yeah. If patients don't respond, then we sometimes change from one to the other and get a benefit. One change is allowed. Maintenance treatment is only recommended for patients with severe degrees of esophagitis or those with Barrett's esophagus or peptic stricture. the erosive esophagitis responds better to PPIs than non-erosive reflux disease. On-demand PPI is the way to treat patients who have got non-erosive reflux disease and they require on-demand treatment. Dexlansoprazole, unaffected by meals, and there is this combination which is not yet available here, omeprazole sodium bicarbonate combination for predominant nocturnal symptoms. Optimization of therapy I've already talked about, so I'll skip these. When to use high dose PPI? Partial or non-responders in GERD, healing of erosive esophagitis if initial treatment fails, and in patients with extra esophageal GERD. So those with non-cardiac chest pain, laryngitis, chronic cough, etc. And if you want to optimize the anti-H. pylori regimen, and clearly in those with bleeding ulcers. So PPIs are also used in the treatment of dyspepsia, both organic and functional. And role of PPI in functional dyspepsia is controversial. Meta-analysis has shown that it is superior to placebo, best response in patients with epigastric pain or burning. ECG recommendations, in America the prevalence of H. pylori is very low, so they have a clear concept. First, look for H. pylori. If they are positive, clear that. If they are negative, then use PPIs, and PPIs are given for at least 12 months if they are effective. On the other hand, if PPIs no response, stop after 8 weeks. Indian, or I would say Asia-Pacific guidelines again recommend PPIs for treatment of functional dyspepsia of two types, those with duodenal hypersensitivity or duodenal eosinophilia, and use fundal relaxant for patients who have got early satiety or postprandial bloating, etc. And last slide is how long do we give it for? For GERD, I've already said 8 to 12 weeks, but there will be patients who have got high degree of esophagitis who will require it for a long period. H. pylori eradication 14 days, duodenal ulcer 4 weeks, gastric ulcer 8 weeks, bleeding peptic ulcer, IV PPI should be used for 3 days. Gastroprotection when you're using PPIs for patients who are on long-term NSAIDs and aspirin, etc., as long as the patient requires. And the functional dyspepsia I've already talked about, Zollinger-Ellison syndrome, long-term. In conclusion, I would say all PPIs broadly comparable in GERD and dyspepsia management. Therefore, the choice of PPI has to be individualized based on multiple factors. The cost is there, the patient characteristic is there, is the patient compliant, non-compliant, etc. Does he have nocturnal symptoms or no, etc. Treatment duration in GERD is 8 to 12 weeks, duodenal ulcer 4 weeks, gastric ulcer 8 weeks. Maintenance treatment should be given for high-grade erosive esophagitis, those with Barrett's esophagus, Zollinger-Ellison syndrome, and in patients who require long-term protection when they are using the non-steroidals and aspirin, etc. On-demand treatment is ideal for patients with recurrent NERD. Nocturnal dosing or for nighttime symptoms, you can sometimes try addition of H2 receptor antagonist, but most people will use double dose of PPI. Dexlansoprazole may be tried in such patients. PPI in functional dyspepsia is based on symptomatic response. If they respond, attempt to withdraw in 6 to 12 months and stop in 8 weeks if there is no response. Thank you very much.
Nice talk, a common topic, excellently covered. But I would like to have final comments, like on the deficiency of B12, magnesium, and the calcium, and the incidence of fracture. Is it because of overuse, or is that otherwise in the community that there is a deficiency?
I think a very appropriate question. if you forget about those on PPI, if you measure the B12 and the vitamin D levels in general population in India, I believe about 70% are deficient, particularly those who are vegetarians. So as it is, there is a tendency for low B12 levels. And if you're using long-term PPIs, probably that tendency increases slightly. So I think in practice, till now, there is no body, no society in the world which has recommended a routine testing for B12.
Thank you. Dr. Upadhyay, very well taken up the subject. But what is PPI addiction? People keeps on taking without any specific symptoms.
I think it's a feel-good phenomena. I won't call it an addiction as such. It's because they take the PPI feel good.
So many side effects.
Yeah, that's true. But if you look at these patients, you all have seen patients who have been taking it for the last 20 years, 10 years, 15 years, and they all say, कि डॉक्टर साहब हमें कोई दिक्कत नहीं है. But okay, you will measure the B12, if you measure their calcium, vitamin D, etc., you will find trouble. But I think the idea is to certainly prevail upon them to say that there are side effects and you must try and get yourself off this drug, and probably reduce the dose to the best possible extent and encourage them to stop it.
Should these patients be monitored for serum magnesium or B12? Because serum magnesium is a very important.
Yes.
Very important, and because of low serum magnesium, you can kind of have a cardiac arrhythmia and cardiac arrest and even that. So
I already mentioned that there are no professional societies in the world at the moment who are recommending routine measurements of these.
No, but in India, because as Dr. My colleague mentioned, that these people are addicted to it, and they don't get any relief until they take it, and they get this PPI without prescription.
Again, even the Indian societies are not recommending routine management, but if you have a patient who has got multiple comorbidities, etc., then I think you are better off just checking it out.
Thank you, sir.
Thank you.
Thank you, sir.
I would like to take this opportunity to inform everybody that the APCON 2024 is going to be held in Delhi from 22nd of February to 25th of February 2024 at Bharat Mandapam, which is the venue where the G20 was conducted. Now I will request everybody to please participate. This is our function. This is the great national function of importance, and I will request everybody to join hands to make it a great success. Thank you.
I'll request Dr. Ajay Gambhir also to please come for the dais. Dr. Ajay Gambhir. Last topic. So the last topic of the day is bone health and diabetes, and for this I invite Dr. Anil Gombar, Senior Consultant Physician, Fortis Hospital, Shalimar Bagh, and the chairpersons for the session are Dr. Atul Gupta, Dr. P.K. Goel, Dr. V.K. Singh, and Dr. Bakshi. I invite them to the dais, please.
Good evening, everybody. I think this is the last concluding session. I welcome Dr. Gombar to start his deliberations on bone health. At the end of,
Thank you,
I
my
think, the concluding
chairperson,
session,
for
everybody is feeling.
giving me the opportunity to be the last batsman of the conference. But before that, I would like to have few words with all of you that this is a gathering that epitomizes the spirit of medical education and professional growth. We are gathered here today not just as individuals but as a community. The CME initiative is a testament of our collective dedication to staying at the forefront of medical innovations. So one of the innovations in the recent times has been the bone diseases, bone health with diabetes. It's a very rare phenomenon that we keep speaking about bone health in diabetes in the recent times. From the last about 5-7 years, we have collected so many data and we have innovated so many peptide molecules to reduce this bone health. I would like to hurry up my slides because I know the people, those who are sitting, are very apprehensive about the bone health again. The bone health and the bone mineralization in Indians is largely unknown. And in the recent times also people do not know even with the diabetes what happens. It's an organ. It's an organ which is a complex tissue affected by multiple hormones and minerals. So it's a very important aspect of a bone health in diabetics. The hormones which are involved in a diabetic situation are parathormones, sex hormones, and calcitriol, which plays a very important role in maintaining the bone health. So these are all are affected in diabetes. We do talk about nephropathy, retinopathy, coronary artery disease, diabetic neuropathy, and other macrovascular complications of diabetes. But we never talked about bone. The bone quality and the quantity are compromised and may increase the risk of easy fracture. Low calcium intake, prevalence of vitamin D. We stop here because we never had any other clinical trials on bone mineralization. The C-terminal cross-linked teropeptide decreases releases in diabetics. Bone-specific alkaline phosphatase is increased. Increased serum sclerostin results in reduced bone formation. Factors regulating bone growth like insulin-like growth factors and angiogenesis. So these are all factors which are producing a metabolic change in a diabetic with the bone health. Bone modeling and remodeling are going on even in a diabetic also, where there is an osteoblast which will say that there is a bone formation, and there are osteoclasts which says bone resorption. Now this bone formation and resorption keeps on going in the body. This is maximum bone quantity, or the bone health is the best in 25 to 35 years of age. After that it goes on resorption. Effects of diabetes and pre-diabetes on bone health. Fracture risk is definitely much increased in type 1 diabetes and type 2 too. And even in pre-diabetes, there are certain studies. Now I have done a question mark whether it happens in pre-diabetes or not. As you know, when you diagnose diabetes, it means already insulin sensitivity or secretion or its resistance is been going on from the last 5 years. Down the line, UKPDS has already evolved that. So it means even in pre-diabetic also, people, those who are pre-diabetic, may have a reduced bone health. The bone turnover is also reduced. Bone turnover in type 1 is reduced and type 2 is much reduced. I have a lot of studies with me, and I've been studying this subject from the last about a year or so and seeing that a lot of change has come into bone health. bone matrix where AGEs are increased in type 1, type 2, and there is a question mark in pre-diabetic status. Micro architecture, geometry of the cortical porosity is also increased in type 1, type 2, and trabecular and cortical bone size may not be having an effect on pre-diabetic status. AGE, advanced glycogen end products, are very much raised in type 1 as well as in type 2, which are derogatory to the bone health. I have few slides for this, that there is a low BMD in type 1 and as well as in type 2. It is less in BMD in type 1. Hip fractures are much more common in type 1. Wrist fractures are common in type 1 and even in type 2. So almost all fractures anywhere on the body, they are all present in much more quantity, which is significant in diabetic patients. So across this, adults with type 1 have greater fracture risk, which I have told you that they achieve lower peak bone mass as the lower bone health in type 1. Because I said 25 to 35 is the best period. Before that, we need almost every mineral products in the bone marrow. In postmenopausal women now, particular subject, as estrogen decline, a bone protective agent in the females, so increase the breakdown of existing bone tissue, making it prone for fragility fractures. So the fragility fractures are much more common in diabetic, in postmenopausal women. So those who are diabetic ladies, having a postmenopausal, they have almost got 2 times fracture risk more as compared to the normal lady. So I'll say that the Women's Health Initiative study has taken up this study that the fracture risk in type 2 diabetes, postmenopausal, whether type 1 or type 2, they are more common. But in type 2 now again, because we are seeing much more type 2 diabetics, any fracture is much more. Risk score is much more. So there's a linear increase in hip fracture even in HbA1c when it increases. So higher the HbA1c, more the fracture risk. Now other factors also in type 2, because there are chances of hypoglycemia, there are chances of diminution of vision, people do have a fall. So type 2 do have more fracture risk. Adults with type 1 have greater fracture risk, as I have told you. So I'll skip these few slides. Now this slide will tell you everything about it. There's a hyperglycemia, there's hyperlipidemia in type 2, and there is hyperinsulinemia. Obesity is another factor where in few of the studies I have seen that those people who are obese, they have a less fracture risk. So there are some studies which also tell you that when the BMI is more, fracture risk is a little less. Now in the red line, a type of fat deposit in bone marrow. This relationship between bone marrow adiposity and bone loss, bone marrow adiposity, is very important aspect in a bone one. And this bone marrow adiposity is well known that bone marrow adipose tissue increases with age, and that reduces bone quantity and quality. Osteopenia and osteoporosis. So related to aging, menopausal states, and diabetic chronic glucocorticoid exposure. And anorexia nervosa is frequently associated with elevated bone fragility. So bone marrow adiposity is a very important marker for going for a fracture risk. Similarly, in type 2, there is a less of bone turnover, bone strength is reduced, fractures are more. Now I can talk about type 2 diabetes medications which are affecting bone health also, which I think I will not pick up this matter today because of the people are getting apprehensive to close down my talk, fracture prediction tools in diabetes can still use conventional risk factors. Diabetes was a risk for fracture, and there are more fractures in type 2, as I told you, that there is cerebral ischemia, hypoglycemia, impaired eyesight complications, and even anti-diabetic drugs also. Now, how to manage osteoporosis or a bone health in a 50 years old with type 2 diabetes? Very common question asked. How to do that? There are certain now anti-resorptive drugs available. We can even use it in diabetics. How to go for that? The diabetes increased risk of bone fracture, as I've told you, that sulfonylureas, metformin, thiazolidines normally are seen that they increases the fracture risk. How sulfonylurea? Hypoglycemia, patient falls down. Eyesight problem, patient falls down. So that is why sulfonylurea and metformin has been implicated in the people, those who are above 60 years of age, when they do have a lot of hypoglycemia. Thiazolidines, a lot of studies have been seen that there are bone resorption with these thiazolidines. Normally people say that we should not give thiazolidines, but there are now negative studies available. They say that in the required dose of even glitazones are helpful in reducing or even neutral bone fragility. Some word about adipocytes, osteoblasts and osteoclasts. These are all metabolic markers which can associated with bone health. Anti-diabetic drugs, as I've told you, the clinical use of these drugs decreases bone formation and enhances bone resorption, as well as increased risk for bone fracture. Similarly, it means they are having an effect on adipocytes, so later on adipokines. And osteoblast, later on osteocalcin, sclerostin. So I think I will end up my talk very fast now. The T-score is more important to see, but it has been seen in many studies that it has got not much value in type 2 diabetes. Sometimes the BMD is more, still people are suffering from fractures. So it is a negative aspect of a BMD in a type 2 diabetic. Even if you do not get less BMD, it doesn't mean that you have to go for something like peptides or something like bone health. If they are at normal level, still people do suffer from that. So there is a complex matter in that. A lot of studies have come up, and now to know about the T-score, that there are bone assessments then. We have to go for FRAC studies, DEXA scans, high resolution, and impractical in vivo measurement of cortical bone. Anti-resorptive drugs are now available, and which has been used in plenty from the last about 4-5 years, and it is being now, there are in India also, denosumab, teriparatide, strontium, all these are available now, and with this, we have to use non-pharmacological management of adequate calcium and vitamin D. Weight-bearing exercises are still the #1 choices. You have to reduce smoking or cessation of smoking, limitation of alcohol, caffeine consumption, fall preventive technologies. To avoid glitazones, at present, yes, good glycemic control, minimizing hypoglycemic episodes, prevention of diabetic complications, especially kidney disease, to assess and prevent falls. Supplementation with calcium and vitamin D are the general management of bone health in a diabetic person. We need more of vitamin D even in diabetics. We need more of calcium in diabetics. So supplementation of calcium and vitamin D, not in the general public, but even in diabetic people. So specific anti-resorptive medications are available, anti-resorptive or osteoanabolic treatment. Now, people are heading for that, and we do not know about much in diabetes that how to control this bone health. So I end up here, and I wish that this gives an enthusiastic process in your mind to know about your bone health in diabetics. Thank you.
Thank you, Gombar sir, for delivering a wonderful talk on the bone health and diabetes. It's a very burning topic and needs awareness about the bone health, obviously osteoporosis in elderly peoples. So thank you. Now the session is open for discussion and any questions from Dr. Gombar.
I have all the papers with me, and people can go along with those papers and see that we have never talked about bone health in any of the forums in the recent times.
Thank you, Dr. Gombar. If no more questions, I invite Dr. Sandeep Biglani to deliver the final address.
First of all, I salute all the persons present in the hall from my core of heart. And it's very heartening from the day when I started at 7 a.m. and the number of persons who attended this very conference. The registration was 350 plus who actually were present at this very place from morning. Despite that, at this very time, attendance is very poor, but on throughout the day, it was reasonably good, and more than 350 people. And the effort put by the members in last 1 month, despite change of place, change of venue because of G20, and there were a lot of disturbances and we have to postpone it, but despite that, it was a success. And the executive members tirelessly worked day and night, and they are still present in this hall, and it will be very unfair not to mention other names which are not present at this very moment. Now, I invite all the executive members to come on stage for photograph, and that's a mark of respect and thanks to all the persons who are present. Thank you.
In the last, from my side, thank you to all wives of all executive members who have allowed them to work for the NDPF. So we must give a big round of the applause for the wives.
Another good news, India has won the Asia Cup final.
Very good. Second year. Recording बंद कर दो भाई.
Two non-executive members are also invited.